A very good evening, my dear friends. Welcome back. Now, this is Dr. Azam here, your faculty of anatomy at PrepLadder. And today we are actually going to do a session of 100 one-liners of anatomy. And this session is actually for all the students who are preparing for their exams like NEET PG as well as INSET exam, as well as for the FMG students, and of course, mostly focus for the FMG students because that is the closest exam that we are having right now. Fine. Yes, a very good evening to all of you. I'm able to see all your messages over here. And now, my dear friends, before starting here, I'll tell you like a couple of things here. Like in this session, what I have done is that mostly like 99% of the things are already written there. Why? Because hardly a matter of like another 3 days, you have your FMG exam. And because you have just 3 days for your exam, of course, this is not the time of, you and me writing here. So it's mostly like, you have to revise the things along with me. Whatever you have learned along with me in the regular classes, just you have to like, brush up all the concepts. And of course, the PDF of this one, the annotated PDF will be provided at the end of the session so that you will also have the video available on the YouTube as well as the PDF also so that you can revise n number of times before going to the exam. Fine. And saying that, my dear friends, let's get started right now. The first thing what will happen, like most of the time, at this moment, at this last moment, we'll be getting the messages from the students, sir. We are not able to recall what we have learned, we are feeling as if though we have forgot everything and all those, my dear friends. Please don't worry about that one. Why? Because definitely whatever hard work you have done for the last 6 months of preparation, that will be there in your mind, and whenever a question comes in front of you, the concept is definitely going to strike. And the only and only thing that is going to motivate you right now is that please, whenever you feel low at this point of time, my dear friends, please remember that yes, the day of the result, please remember that one. And yes, of course, remember your parents whom you're going to make proud on the day of the result. These two things are going to, energize you again to start your preparation back. So please don't worry that, don't go into the low phase. Whatever hard work you have done, you'll surely going to come out with the flying colors. Okay. Now saying that, without any further ado, we are not going to waste any time over here. Sit back and relax and then try to recall all the concepts along with me, my dear friends. And yes, of course, we are not going to write down much here. Quickly, we are going to brush up the concepts. So I think I'll be taking like another like 2.5 to 3 hours, another 3 hours completely be with me. So keep your water, coffee, everything ready along with you. So you're not going to move from your place for another 3 hours. And in the next 3 hours, I am going to give you like 20 marks of your FMG exam. I hope you all know you have to score 150, and out of that 150, if 20 marks, that is a huge thing, है ना? So just sit back, relax. Another 3 hours, we are going to become like perfect in all the concepts required for your anatomy, my dear friends. Okay. Now, the next thing here, the first thing that we are going to begin, the first topic we are going to begin is neuroanatomy. See, what I'm trying to do here is the entire revision session, we are going to divide into into four categories. Number one category, I'm going to teach you about the head and neck and neuroanatomy, first of all, being like fresh right now. And number two, of course, the limbs, upper limb and lower limb. Number three, we're going to learn about the thorax, abdomen, and pelvis and perineum. And the number fourth one will be the embryology along with the miscellaneous topics like joints and all. So I have divided the entire session into the four categories here. So first, let's get started with the neuroanatomy right now. Is it okay? So just give me a thumbs up, my dear friends, if I'm audible and visible to all of you. I hope I'm audible and visible to all of you, my dear friends. Yes, of course. Okay, fine. Thank you. Yes, of course, Pratik, we are going to integrate, integrate not only with ortho, with also medicine also. I'm going to teach you a lot of clinical anatomy in this one also. ठीक है ना? थैंक यू सब चंगा सी. चलिए जी स्टार्ट करते हैं. अब यहाँ से कोई डिस्ट्रैक्शन नहीं चाहिए. Like next 3 hours, it should be like only you, me, and our anatomy. Okay, so let's get started right now. First with the neuroanatomy. Now, the first thing I want to tell you is about the ventricles here. In this diagram, you're able to see this one here will be the lateral ventricles, which are located in telencephalon. And this will be the third ventricle, which is located in diencephalon. And then this one here will be the fourth ventricle located in the complete hindbrain, that is rhombencephalon. And connecting the lateral ventricle with the third ventricle, there will be foramen of Monro. And connecting the third ventricle with the fourth ventricle, there will be aqueduct of Sylvius. Now, why I'm telling you this one? As I told you, I'm going to tell you a lot of clinical anatomy here, my dear friends. Suppose if there is a aqueductal stenosis, if there is aqueductal stenosis, narrowing of the aqueduct, then suppose if there is aqueductal stenosis over here, narrowing of the aqueduct, my dear friends, then what is going to happen? The CSF will get accumulated in the third ventricle and the third ventricle is going to enlarge in this one. Fine. That is a case of aqueductal stenosis. Then in the fourth ventricle, you all know very well, on the lateral side, you'll be having foramen of Lashka, and in the midline, you'll be having foramen of Magendie. If those foramens will undergo atresia, then there is fluid getting accumulated in the fourth ventricle, and then the fourth ventricle will get enlarged, and that you'll be able to observe in Dandy-Walker syndrome. Dandy-Walker syndrome. So let us see the first two clinical condition. Number one, in aqueductal stenosis, yes, what is going to happen? It will lead to dilatation of which ventricle? Of course, it will lead to dilatation of third ventricle here, sir. So no need to mug up. We are learning conceptually over here. Third ventricle will be enlarged in this one. And please remember one more one-liner here, that the most common cause of congenital hydrocephalus will be the congenital aqueductal stenosis. When there will be atresia of foramen of Lashka and Magendie, of course, which ventricle will be enlarged? Fourth ventricle, that will be observing in Dandy-Walker syndrome. Yes, my dear friends, and you can also look at the image here. This image was also given in your exam, where you can see the fourth ventricle is enlarged here in the Dandy-Walker syndrome. Fine. Now, now, my dear friends, once you are done with this one here, let us go ahead with the next concept. Yes, a spinal cord. Every now and then in your exam, there will be questions asked from the spinal cord. अब spinal cord में क्या पढ़ना होगा? What you have to learn in the spinal cord? The first most important thing is what is the extent of spinal cord. We all know that in adults it will be extending from C1 to L1, of course the lower border of L1, and in the infants it will be from C1 to L3, L3 upper border of L3, sir. It will be up to the upper border of L3. Recently in the exam they have asked in the neonates, please keep that point in mind. Apart from learning the extent of the spinal cord, you just have to learn the ending part of the spinal cord. We all know that the spinal cord ends in a cone-shaped structure, and this cone-shaped structure will be conus medullaris. Now this is surrounded by the meninges, and out of the three meninges, the innermost meninge will be the pia mater. Now what is going to happen to the pia mater at the end of the spinal cord? Is it going to stop here only? No, that is going to continue down further, and that itself is referred to as the filum terminale. So please remember that filum terminale is modification of the pia mater. Then if this is your pia mater, then what about the arachnoid and dura mater, my dear friends? Arachnoid and dura mater are going to descend down and merge with the pia mater and then continue down here. Now the important thing is, where are they going to merge? Remember, at the lower border of S2. Remember, at the lower border of S2. That's the reason why we can say that this subarachnoid space is also ending where only? Remember, it is going to end at lower border of S2 only. And that is the reason why this is the place where you can actually do the lumbar puncture. So lumbar puncture is done between L3 and L4. That is actually a better option when compared to L4 and L5. When compared to L4 and L5. If you remember these many points, they are more than enough for your exams, my dear friends, about the spinal cord. So in spinal cord, हम क्या पढ़ने वाले हैं? What we are going to study in spinal cord? Number one, the extent of the spinal cord, and number two, the ending part of the spinal cord. I hope it is very much clear. Now, I told you about one of the modification of pia mater, that is filum terminale. Apart from that, number two, second modification will be the linea splendens. The pia mater is going to extend in the anterior median fissure. The pia mater is going to extend into the anterior median fissure of the spinal cord, and that extension of the pia mater into that one is known as linea splendens. But the most important one is actually the ligamentum denticulatum. You'll be able to find that, like, tooth-like projections on either side of the spinal cord. That is ligamentum denticulatum. Now, can anyone tell me ligamentum denticulatum? Like, there are how many ligamentum denticulatum? Tell me the number. In total, how many ligamentum denticulatum do we have? Please remember that we have only and only two ligamentum denticulatum. One will be on the right side and another one is on the left side. Right and left one. And don't get confused here. Both on the right and left, you'll be having 21 projections on each side. There will be 21 projections on each side. Most of the time in the classes, what is going to happen is the students are like directly telling me, okay, there are like 21 ligamentum denticulatum. No, 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 no. You don't have 21 ligamentum denticulatum. There are like 21 projections on each side, 21 and 21. There are only 2 ligamentum denticulatum. Chalo, we have even revised this one also. आगे बढ़ते हैं. Let's go ahead now. Now, my dear friends, please listen to this concept very carefully. In neuroanatomy, take my words right now, the exam paper is not going to get completed without the section of the brain. Out of the 3 sections of brain, definitely they will be asking you one of the section, whether coronal or transverse or the sagittal section. So now we are going to learn about the sections of the brain, and along with that, my dear friends, remember, along with the sections of the brain, we are also going to learn like many topics associated with this one here. Fine. तो चलिए सबसे पहले हम स्टार्ट करते हैं with the ventricle here. Now in this diagram again you are able to see here, this is the lateral ventricle, and this lateral ventricle, my dear friends, remember, there will be anterior horn of the lateral ventricle, and this is the central part of the lateral ventricle, and this is the posterior horn of the lateral ventricle, and this is the inferior horn of the lateral ventricle. Now in your exams they are asking you the relations of all this one. I will tell you one of the easiest way to remember the relations of this one. Okay. Now for example, if this one here will be the lateral ventricle, fine, and this lateral ventricle is having anterior horn, and then this is the central part, the posterior horn, and then you'll be having the inferior horns. This is the inferior horn. Fine. Now the only and only thing that you have to remember here is inside this one you'll be able to appreciate the caudate nucleus. Inside this you'll be able to appreciate the caudate nucleus. Fine. And then outside this here you'll be able to appreciate here the corpus callosum here, sir. This is your corpus callosum. You know the 4 parts of the corpus callosum: rostrum, genu, body, and the splenium part. Fine. If you remember this diagram, you are done, my dear friends. Now you yourself, anterior horn. The roof of the anterior horn is formed by corpus callosum, and the floor here will be formed by caudate nucleus. We are done with the anterior horn. Similarly, what about the inferior horn? The roof again is formed by caudate nucleus, and in the floor of this inferior horn you will be able to appreciate the hippocampus present over here. So there will be the hippocampus over here. Done. So in this manner, that is why I'm telling you one simple diagram, you're done with the relations of this one over here. Now comes the posterior horn, and this was actually asked in your exam. In one of the PG exam, they have asked about the posterior horn relations. Now for the posterior horn, please look at this diagram here. We have taken a section here. Now in this diagram, my dear friends, this one here will be the posterior horn. If this is the posterior horn, you can clearly see the roof of the posterior horn and the lateral wall. The roof and the lateral wall, that blue colored one structure, it is formed by tapetum. These tapetum fibers here. The roof and the lateral wall will be formed by the tapetum fibers. But in the exam, in the PG exam, they have asked about the medial wall. Now on the medial wall, you'll be able to appreciate like 2 elevations over here. Okay. Now this one here will be referred to as the bulb of the posterior horn, and this one will be referred to as the calcar avis. Remember, the bulb of the posterior horn will be formed by the forceps major fibers. The forceps major fibers, whereas the calcar avis will be formed by a sulcus known as calcarine sulcus here. Calcarine sulcus. And yes, of course, the bulb of the posterior horn has been asked in your exam. Please remember that one. Please remember this one here. So in this manner, my dear friends, just with the help of 2 simple diagrams, we are actually done with the relations of the lateral ventricle over here. अब हम क्या करेंगे? What we are going to do is we will be taking a coronal section. Now please listen with 200% concentration. Let me take a coronal section here. Now once you take a coronal section, the diagram will be something like this here. The diagram will be something like this. Now in this diagram, my dear friends, this one here again will be the lateral ventricle and lateral ventricle, and both of them are going to open into the third ventricle via foramina of Monro. Now you can clearly see there are bundle of fibers which are going to connect the right half with the left half. Now you know very well in anatomy, in the regular classes we have learned the bundle of fibers connecting the right and left half of the brain are known as commissural fiber, and this is the largest commissure, and this largest commissure here will be the corpus callosum. So therefore we can say that corpus callosum is going to form the roof of the lateral ventricle. Wonderful, done here. Then apart from that, between the two lateral ventricles, we are able to appreciate one septum here, and this septum will be the septum pellucidum. And septum pellucidum is going to form the medial wall of the lateral ventricle. This is going to form the medial wall of the lateral ventricle over here. So easy. And after that, my dear friends, welcome to the floor of the lateral ventricle. And please remember, in every ventricle, the floor is very much important. Now in this diagram, you're able to see one nucleus here. This nucleus here will be the caudate nucleus, number one. Then you'll be able to appreciate a vein here. That vein will be thalamostriate vein. And then this structure over here will be, of course, the thalamus. Fine. And then please don't forget this one. Remember this one very carefully. This one here will be the fornix, my dear friend. You should be able to identify the fornix in every diagram possible. Hot favorite of the examiner. And then you'll be able to find the network of capillaries over here, that is known as the choroid plexus. And all these structures together, they are going to form the floor of the lateral ventricle. Floor of the lateral ventricle. I hope you are able to recall all these things, my dear friends. I hope you're able to recall all these things right now. तो जैसे मैंने आपको स्टार्टिंग में कहा था, as I told you in the very beginning of the our session here, that yes, majority of the things I have written here. आराम से बैठिए and try to calmly recall if you're able to recall all these things. Now, if you know these structures, my dear friends, yes, of course, you'll be able to deal with many questions over here. Fine. Now in one of the PG exam, they have put an arrow mark here and identify the structure, that black colored pigmented substance. Okay, and that one will be your substantia nigra, and that will be present in the midbrain. So in the PG exam, they have asked about this one here. And I'll tell you one more question here. If this is your caudate nucleus over here, and then if this is the thalamus over here, then this one here will be the lentiform nucleus, lens-shaped lentiform nucleus. Already that has been asked in your MCI exam, in your FMG exam, arrow mark on the lentiform nucleus. And in the last exam, they have put an arrow mark over here. This white matter passing from here, my dear friends, that is nothing but your internal capsule. So you are able to answer like 3 questions from here. Yes, that black colored pigmented substance will be substantia nigra, caudate nucleus, thalamus, lentiform nucleus. In between them, you'll be able to find the internal capsule. That is why I told you very clearly, in every exam, there'll be one section of the brain definitely given in your exam, sir. ठीक है ना? Now, my dear friends, यहीं से हम क्या करते हैं? Because I told you that fornix is very much important for your exam. Let us discuss all the points about the fornix right now. है ना? Now, question number 1. The structure indicated in the image originates from where? Now you all know that the structure which is indicated in the image over here, this one is actually your fornix here. Fine, we know. But what is the question? It is asking it is going to begin from where? So please remember, it is going to begin from hippocampus. Hippocampus. Let us see this one in detail here. Understanding everything is like well planned, my dear friends. Just try to follow my session over here. Fine. Now, number 1, in this diagram, you will be able to find here, there is hippocampus over here. And from the hippocampus, you'll be able to appreciate the fornix beginning from here, going all the way, getting attached to what? Mammillary body here. And from the mammillary body, what is going to happen? Mammillothalamic tract will go and join with the thalamus. And that one will be the anterior nucleus of thalamus, already asked in your exam. So the first one-liner that we are studying here is, from the hippocampus begins your fornix, that will go and get attached to what? Mammillary body. From the mammillary body, mammillothalamic tract will go and get attached with what here? Anterior nucleus of the thalamus. Number 1. Number 2, second question here, fornix belongs to which category of fibers? You know about the white matter. जो आगे पीछे कनेक्ट करता है association fiber, जो right and left कनेक्ट करता है commissural fiber, जो up and down कनेक्ट करेगा वो होता है projection fiber. Please remember that, number 1, fornix belongs to all the 3 categories of fibers, association, commissural and projection. तो अगर एग्जाम में all the above दिया जाएगा, you are going to mark all the above. It belongs to all the 3 categories of fibers. Number 2, if they are giving a combination, please remember it is mainly belonging to association and commissural when compared to any other combination, either association projection or commissural projection. Clear? So fornix belongs to all the 3 categories of fibers. If they are giving in combination, please remember that it belongs to both association and commissural type of fibers. Now, the fornix on one side and fornix on the other side will be connected by what? They are connected by commissure, and that commissure will be the hippocampal commissure. Right and left half always connected by commissure, and that will be the hippocampal commissure. So on this slide, we have completed all the points related to fornix. Now you're ready to answer any question related to the fornix, my dear friends. Okay. Now, after this, yes, as I told you, we are done with what here? The coronal section is completed. Now let us take a sagittal section. When you are going to take a sagittal section, first of all, you are able to appreciate here that this ventricle here will be the third ventricle, my dear friend. So which ventricle is this one here? This one will be the third ventricle. Now, in this sagittal section, we are also going to learn like all the boundaries of the third ventricle. First of all, what is going to form the lateral wall of the third ventricle? This one here will be the thalamus, and below the thalamus, there will be hypothalamus. So thalamus and hypothalamus are going to form the lateral wall of the third ventricle. Then what do you have in the roof? In the roof, you're able to see here, number one, this network of capillaries here will be the choroid plexus. Above them, you'll be able to appreciate the fornix. So these two structures are going to form the roof of the third ventricle here. Perfect. Then what is forming the anterior wall? Anterior wall will be actually formed by, yes, there is a commissural fiber here, that is anterior commissure. Then again, you'll be able to find the lamina here, lamina terminalis. So these two structures are going to form the anterior wall of the third ventricle. Anterior wall of the third ventricle. Fine. Now, I want you to remember like two more points regarding the lamina terminalis. Number one, what is this lamina terminalis representing, my dear friends? Please remember that it is the remnant of anterior neuropore or the cranial neuropore. Okay. So in embryology, we learn about the neural tube. In neural tube, my dear friend, there will be two neuropores, anterior and posterior. Anterior neuropore का जो remnant होता है, remnant is lamina terminalis. नंबर टू, सेकेंड पॉइंट जो आपको याद रखनी होगी, यहां पर ब्लड ब्रेन बैरियर नहीं होता है. देयर इज नो ब्लड ब्रेन बैरियर ओवर हियर. That's the reason why this is referred to as circumventricular organ. The organs where you don't have a blood-brain barrier, that is known as circumventricular organ. One of the example is lamina terminalis. ये दो पॉइंट यहाँ पर याद रखिए, ठीक है ना. Then come down to the posterior wall. In posterior wall, first you should be able to identify this gland. This gland will be pineal gland. Above the pineal gland, there is a commissure here, that is habenular commissure, and below the pineal gland, there is one more commissure, that is posterior commissure. Okay, and then my dear friend, there is a duct here. That duct will be the aqueduct. All these four structures together, they are going to form the posterior wall of the third ventricle. Posterior wall of the third ventricle. Hope it is getting revised or refreshed in your mind quickly, hai na? So that is the advantage of this session at this moment here, sir. Full focus here, my dear friends. Now the last and final thing is the floor right now. So we are done with the anterior wall, we are done with the posterior wall, we are done with the roof. Now welcome to the floor, and floor we are already expert here. Number one, you're able to see this crossing here. This crossing is referred to as the optic chiasma here. Just behind the optic chiasma, you'll be able to find the pituitary stalk, which is also known as infundibulum. Along with the infundibulum, there will be tuber cinereum. Then this body here will be the mammillary body, of course, and this perforated substance here will be the posterior perforated substance. And now, my dear friends, welcome to this midbrain here. Try to recall. In the midbrain, I told you there will be aqueduct. That is an important landmark. Why? Why? Because all the structures present behind the aqueduct here, this is tectum part, and whatever you find in front of the aqueduct here, that is tegmentum part. तो एक्वेडक्ट के जो पीछे होता है टेक्टम होता है, जो एक्वेडक्ट के आगे होता है दैट इज नथिंग बट द टेगमेंटम पार्ट. फाइन. सो देयरफॉर all these structures together they are going to form the floor of the third ventricle. So in this manner we are done with the sagittal section. Now recently in one of your exam, what happened is they have given a radiological image of this one, and now my dear friends, I think after learning that you'll be easily able to identify the structure. Now in this diagram, the first thing that you should be able to identify is this is corpus callosum here, and beneath the corpus callosum, this part here will be the fornix. First to identify these two structure. Then I told you very clearly, this crossing here will be optic chiasma. Behind that there is infundibulum, of course connecting the pituitary gland. And then this body here will be the mammillary body. And yes, my dear friends, this is midbrain, and then the pons and the medulla oblongata, cerebellum. All these structures are very much simple for you. And my dear FMG students who are preparing for your FMG exam on 12th January, in your exam after learning all this, recently they have given this radiological image where there was an arrow mark on this structure, and that is nothing but pons, and you have to identify that, 1 mark for that one. I hope damn easy है ना. So there is your pons over there. Clear with this one here, sir? तो ऐसे मतलब questions तो बड़े मतलब it's like improving your score and confidence in the exam. So don't get worried about radiological image there. See that and mark the answer easily, my dear friends. Next one. Now, now by this, what we have completed here, we are already done in the sagittal section. I hope you're actually following my planning here, sir. तो कोरोनल सेक्शन भी हो गया है और सैजिटल सेक्शन भी हो गया है और उसी के साथ में वी हैव कंप्लीटेड अबाउट द लेटरल वेंट्रिकल एज वेल एज द थर्ड वेंट्रिकल. Many topics are completed there, sir. Now we'll come to the last and final one, the transverse section. Now in this transverse section, understanding the orientation is very much important. Now for example, if this one here is cerebral hemisphere, now inside the cerebral hemisphere there will be like corpus callosum here, and we are actually taking the section at this level, ठीक है ना. Now in corpus callosum, in front you'll be having genu here, and that genu is corresponding to this part here. So this is your genu. Okay, और genu के आगे क्या होता है? What do you have in front of this one here? This one is the frontal lobe here. And behind what you have here, this is splenium. और splenium के यहाँ पर पीछे क्या होता है सर? Occipital lobe. So this part is actually corresponding to your splenium part here. I hope now you are understanding the transverse section over here. Now, from the genu part, you are able to observe the white matter fibers which are connecting the frontal lobe here, my dear friend. From the genu, there are fibers connecting to the frontal lobe. They are known as forceps minor. And from the splenium, you can see the fibers connecting with the occipital lobe here, forceps major. Forceps major. And then this genu and the splenium are connected by the body in the middle, and from the body there are fibers going laterally, and those fibers which are going laterally here, these are tapetum fibers. They're known as tapetum fibers. And try to recall this now. I told you that this one here will be the posterior horn of the lateral ventricle. And the posterior horn of the lateral ventricle, अभी मैंने आपको बताया था, the roof and the lateral wall. The roof and the lateral wall is formed by tapetum fibers, and on the medial wall there is a bulb here, and the bulb will be formed by forceps major. We are actually connecting the dots here. Perfect. Now once you are done with this one here, let us welcome to the middle part right now. Now in the middle part, my dear friends, again the same thing. This is caudate nucleus, this one is thalamus, and this is lens shaped lentiform nucleus. Now what do you find in middle of these three of them? Yes, this white matter fibers over here is internal capsule. अगर आपने कभी ध्यान दिया होगा कि why is this internal capsule known as internal capsule, my dear friends? Why? Because lentiform nucleus is like lens shape, and there is one capsule inside, internal capsule, and there is one capsule outside, that is external capsule. So outside you are able to find this bundle of fibers over here, white matter fibers over here, this is external capsule. Similarly, you'll also have a sheet of gray matter here, and that sheet of gray matter will be claustrum. Then just lateral to that one, again there is a sheet of white matter here. That one will be extreme capsule. And then this hidden lobe of the cerebrum here will be the insula. So I want all of you to please remember all these structures in sequence from medial towards the lateral side. And once in your exam, they have even asked about the insula also. So in the image, you should be able to identify the insula there. Perfectly done. Now, once you are done with this one, now my dear friends, as I told you, in every section we are going to learn like many topics. Let us pick up this part outside here. So let us take this part outside. And yes, of course, welcome to internal capsule topic here. Now in internal capsule topic, number one, you have to remember the parts. How many parts do you have in internal capsule? Yes, of course, they are like how many parts in the internal capsule, my dear friends? They are like 5 parts in the internal capsule. Now out of that 5 parts, remember number one, this one here will be the anterior limb here. Then this bent here in the middle will be genu here. And then this one here will be the posterior limb. And then you'll be having the retrolentiform part. And then you'll be having sublentiform part. They're like totally 5 parts in the renal capsule: anterior limb, genu, posterior limb, and then retrolentiform part and sublentiform part. 5 parts are there. Number 2, what the examiner can ask you is about the relations of the internal capsule. Now you can clearly see on the medial side you're having the caudate nucleus and the thalamus. On the medial side you're having caudate and thalamus. On the lateral side you're having the lentiform nucleus. Come on, my dear friend, from the basal ganglia topic, can you recall what is this lentiform nucleus in turn made up of? Lentiform nucleus is in turn made up of putamen and globus pallidus. In that, you have to remember, already asked in FMGE exam, that putamen will be on the outer part. This is the putamen part here, and globus pallidus will be on the inner side here, sir. I repeat again, lentiform nucleus is made up of 2 things, that is putamen and globus pallidus. Putamen will be on the outer part, whereas the globus pallidus will be on the inner side, sir. Please remember that, already a previous year question in your FMG exam. Clear? Now, apart from that, in your PG exams, they are interested about the tracts passing through the internal capsule. Tracts passing through the internal capsule. You can very clearly see here. Number one, corticonuclear tract. Corticonuclear tract is going to pass from which part? That is from the genu part. Whereas the corticospinal tract, that is your famous pyramidal tract, is going to pass through the anterior two-third of posterior limb. These 2 points has been asked in your NEET PG exam as well as your INSET exams. Fine. I repeat again, corticonuclear tract is going to pass from the genu part, whereas the corticospinal tract is going to pass from anterior two-third of the posterior limb. Perfect. Now by this, my dear friends, we are done with the parts of the internal capsule, relations of the internal capsule, as well as tracts passing through the internal capsule. Now, blood supply of internal capsule is also very much important, and this is actually the best diagram to learn the blood supply of internal capsule. Okay. Now in this diagram, you're able to see here like all those 5 parts, my dear friends: anterior limb, the genu, posterior limb, and the retrolentiform part, and the sublentiform part here. Fine. Now, my dear friends, remember, in the anterior limb, genu, and the posterior limb, the superior part, the upper part of that one. Okay, we are going to divide that into 2 parts here, the superior part and the inferior part here. The superior part of anterior limb, genu, and the posterior limb will be supplied by striate branches of middle cerebral artery, MCA. Similarly, the inferior part of the anterior limb, the inferior part of the anterior limb only, that will be supplied by recurrent branch of anterior cerebral artery. Recurrent branch of anterior cerebral artery, which is also known as the Huebner's artery. Fine. Then the inferior part of the genu will be supplied by the internal carotid artery. Internal carotid artery itself. And then whatever part is highlighted in this green color here, I mean to say the inferior part of the posterior limb as well as retrolentiform, sublentiform part, all will be taken care by the anterior choroidal artery. So please remember this diagram, that will be like easier for you, my dear friends. Clear? So my dear doctors, in this manner, we are now done with one very, very important segment in neuroanatomy, that we have completed all the 3 sections. Okay, coronal section, sagittal section, and the transverse section, and many topics related to that one is done, sir. So definitely you are going to get like 1 or 2 marks definitely from this part here. So I want you all to revise this perfectly. Is it okay? चलिए आगे बढ़ते हैं. Now nowadays in your exam they're asking about the basal ganglia lesions. They're asking, sir. They're asking the lesions. Already in the regular classes you have learned about the parts of the basal ganglia. Number 1, it will consist of corpus tritum, subthalamic nucleus, substantia nigra, caudate nucleus, lentiform nucleus. You know all the parts of that one. Now please remember, if there is a lesion in globus pallidus, it will lead to athetosis. Similarly, if there is a lesion in putamen and caudate nucleus, it will lead to chorea. Recently, they have asked the question in a reverse manner. In chorea, which parts of the basal ganglia are actually involved? Of course, putamen and caudate nucleus will be involved. Of course, in Parkinson's disease, you know very well, substantia nigra, decreasing the dopamine levels. Fine. And yes, of course, one more question asked recently was hemibalismus also. Hemibalismus is caused due to the lesion in which part? The subthalamic nucleus. Subthalamic nucleus. So this is an important thing I want you to remember here. Next one. Now after completing this one segment in the neuroanatomy, my dear friends, now let us focus on the brainstem topic. Another one question from here for sure. And please have some patience. Why? Because at the end of this brainstem topic, my dear friends, I am also going to tell you about the syndromes also, where many of the students will be actually confused a lot. So I'll tell you about the syndromes also. Okay. Now on the screen here, you're able to see the brainstem, midbrain, pons, and medulla oblongata. Fine. And now midbrain, pons, and medulla oblongata, ventral aspect of the brainstem is very famous for the origin of cranial nerves. Cranial nerves are going to originate from here. So let us see all the cranial nerves quickly here. Now this one here will be the 3rd nerve, and this one here will be the 4th nerve. Remember, 3rd and 4th nerve are going to begin from midbrain. Okay. Then this one here will be the 5th nerve. 5th nerve is going to begin from pons. To be more specific, it is coming out from the junction between the pons and middle cerebellar peduncle. So in this diagram, you're able to see this one here will be the pons, and this one here will be the middle cerebellar peduncle. So 5th nerve is coming out between the pons and middle cerebellar peduncle. And then the very famous one, the sixth nerve and the seventh nerve and the eighth nerve, these three are going to come out at the pontomedullary junction. Pontomedullary junction. Fine. And then in this diagram, this one here is the ninth nerve, then the 10th nerve and the 11th nerve. These three nerves are going to exit lateral to olive here, my dear friend. So this elevation here will be referred to as olive, and this is the pyramid here. Between the pyramid and olive, there will be 12th nerve coming out here. Perfectly done. This we all know very well. Now, one point that you have to remember is 9th, 10th and 11th nerve will have a common nucleus, and that nucleus will be known as nucleus ambiguous. Number one point. Number 2 point, this elevation here will be the olive, and this elevation here will be the pyramid. You also have to remember the reason for the olive and pyramid. The olive elevation is formed due to the inferior olivary nucleus, due to the presence of inferior olivary nucleus. Whereas the pyramid will be formed due to the tract passing from here, and that tract will be the pyramidal tract passing from here. Okay, you have to remember the reason for that one. I'll tell you the clinical importance of that within some time. Now in this diagram, one more point to remember is, in your exams, they're asking many questions regarding the fourth nerve, my dear friend, trochlear nerve. Remember, it is the only cranial nerve coming from behind. It is having dorsal origin. Hot favorite of INI set examiner. Recently, there was an image-based question here. It is having dorsal origin. Now, because it is having dorsal origin, then it is going to take a turn and come in the front. That is why it will also have the longest intracranial course. It will also have longest intracranial course. Clear? And then one more point is that it will also have internal decussation. What is the meaning of decussation? It is going to cross. And that too, the crossing is taking place inside the midbrain. That is why it is known as internal decussation. Please remember these 3 points here, sir. It's having dorsal origin, longest intracranial course, and internal decussation. If you remember these important points, after that I hope you all remember it is the thinnest cranial nerve, slendermost cranial nerve, as well as it is the smallest cranial nerve, sir. So all these are the important points regarding the fourth cranial nerve, trochlear nerve. And by this, we have completed like many points regarding the ventral aspect of brainstem. Now, my dear friends, welcome here. One more important point is, in this diagram, you're able to find here cerebral peduncle on one side, and there is a cerebral peduncle on the other side. If there is a cerebral peduncle and peduncle on either side, in between them, you'll be able to appreciate the interpeduncular fossa. Now, what are the contents of interpeduncular fossa? Number one, you are able to appreciate here, there is infundibulum along with tuber cinereum. Number two, behind that, you'll be able to appreciate the mammillary body and mammillary body here. Number three, there will be posterior perforated substance here, sir. And then, of course, there is a cranial nerve number 3 here, oculomotor nerve. Yes, my dear friends, I hope all of you are able to recall quickly here all the points, my dear friends. I think it is getting refreshed. And I think this is like the best time to revise all these things just like 3 to 4 days before your exam. Why? Because everything will be like fresh and you can just go to the exam and dump there. That's all. Okay. Yes. So these are the contents of the interpeduncular fossa here. So Dr. A.M., please remember that optic tract and optic chiasma, they are forming the boundaries of that one. Okay, now optic tract and optic chiasma is going to form the boundaries of that one here. Take it now. My dear friends, please don't ask about the PDF again and again. I told you in the beginning of the session that PDF will be given to you at the end of the session. Yes, in the Telegram groups. Yes, I will even post it in my Telegram group also. Don't worry about that. Now, please focus completely on recalling this one. So along with me, don't worry about writing and all. Just try to recall. The moment I'm trying to tell you, just try to recall this one here. Okay, sir. Okay, Dr. AM, thank you. Yes. Now, are you observing one thing here? After every topic, I'm telling you a clinical anatomy associated with that one. Fine. Now, okay, well and good, sir. We are able to identify everything here in the ventral aspect of brainstem. Fine. Now, how they are asking the question in the exam? In one of the exam, they have given this ventral aspect of brainstem, arrow mark. If there is an injury over here at that arrow mark structure, then what is going to happen? You know very well, this is elevation. This elevation is actually pyramid here. And pyramid will be formed due to what? Due to the pyramidal tract going down. And we know that the pyramidal tract is going to cross. And that crossing will be known as the pyramidal decussation. Very important MCQ, has been asked in almost every exam. NEET PG, INI set and FMG. All the 3 exams they've asked this question, pyramidal decussation कहाँ होता है, where it is going to take place. So please remember, pyramidal decussation ekkada avutundi, lower medulla. Pyramidal decussation is going to take place where? At the lower medulla. Now, because the decussation is taking place over here, now agar maan lo, if there is an injury to the pyramidal tract before decussation, injury to pyramidal tract before decussation, then of course it will lead to what? Paralysis. It is a descending tract. It is going to carry the motor information. It is leading to what? Paralysis. Hemiplegia will occur. Ipsilateral or contralateral? Contralateral hemiplegia will occur. If the injury will occur after the decussation, I mean to say in the spinal cord, then it will lead to what? Ipsilateral hemiplegia. So therefore, my dear friends, in the exam, your criteria has to be like pyramidal decussation. I repeat again, if the injury is taking place before the decussation, then it is contralateral hemiplegia. Okay, and if the injury is going to take place after the decussation, then it will be ipsilateral hemiplegia. And I'll tell you here itself, my dear friend, ipsilateral hemiplegia, you'll be able to observe that in Brown-Séquard syndrome. Brown-Séquard syndrome, क्योंकि Brown-Séquard syndrome क्या होता है? Hemisection of the spinal cord. Hemisection of the spinal cord. If suppose the injury to the pyramidal tract is taking place in medulla oblongata or in the pons or in the midbrain, yes, that will come in your midbrain and the pontine and medullary syndromes mein aayega, and always there will be contralateral hemiplegia. Within few minutes, I'll tell you in a crystal clear manner. Is it okay? So please remember that one, my dear friends. I'll just repeat this once more here. It's worth repeating, my dear friends. If the injury to pyramidal tract is taking place before the decussation, contralateral hemiplegia. If the injury is taking place after the decussation, then it is ipsilateral hemiplegia. So recently this question was given in your PG exams. Injury at the arrow mark structure will lead to contralateral hemiplegia. Okay, next one. Now welcome to the dorsal aspect of the brainstem. Behind the midbrain, you'll be able to find four bodies. Together they are known as corpora quadriga minor. There'll be two superior colliculi and there'll be two inferior colliculi. The superior colliculi is concerned with vision. The inferior colliculi are concerned with audition. लिजनिंग है ना, आंखें ऊपर होती है, कान नीचे होते हैं, ऐसे मैंने आपको बताया था इन द रेगुलर क्लासेस. सुपीरियर कॉलिक्लाई कंसर्न विद विजन, inferior colliculi are concerned with, yes, auditory pathway. Now that is behind the midbrain, वो हो गया है. Now what do you have behind the pons and behind the medulla oblongata? Behind the pons and medulla oblongata, you will be able to see the floor of fourth ventricle. And this floor of the fourth ventricle is rhomboid shape. Rhomboid fossa bhi kehte hain sir. It is also known as the rhomboid fossa. Now in this one, you'll be able to find like four elevations here. Now we have to find the reason for this elevation here. Number one, the vagal triangle is formed due to the vagus nucleus, 10th nucleus. Forget about that one. Hypoglossal triangle is formed by hypoglossal nucleus, the 12th nucleus. Forget about that one. Vestibular area will be formed by vestibulocochlear nucleus. That is your 8th nucleus. Forget about that one. Now why I'm telling you to forget about this one here? Any student can answer this one. नाम में ही लिखा है. It is there in the name itself. Vagal triangle, vagus nucleus. Hypoglossal triangle, hypoglossal nucleus. Vestibular area, vestibulocochlear nucleus. Examiner will never ask you. Study smartly. Examiner क्या ऐसी चीजें पूछेगा? नहीं. Always in your exam they are asking about the facial colliculus only. Even though the name is facial colliculus, remember it is formed due to the abducens nucleus, 6th nucleus. इसीलिए आपको हमेशा पता होना चाहिए कि लाइक यू नो स्टडी स्मार्टली, कि क्या पढ़ना चाहिए क्या नहीं पढ़ना चाहिए. ठीक है ना. नाउ माय डियर फ्रेंड्स, इफ देयर इज अ इंजुरी एट दिस फेशियल कॉलिकुलस, व्हाट इज गोइंग टू हैपन? वेलकम टू क्लिनिकल एनाटॉमी. नाउ इफ देयर इज अ इंजुरी एट दिस फेशियल कॉलिकुलस, व्हाट इज गोइंग टू हैपन? ऑफ कोर्स, इसका नाम फेशियल कॉलिकुलस क्यों रखा गया है? व्हाई द नेम इज गिवन लाइक दैट? व्हाई? बिकॉज दे विल बी फॉर्मेशन ऑफ, there will be 6 nucleus available, fine, but the 7th nerve is going to take a turn around this one here. Are you understanding the point here? That is the reason why this facial colliculus which will be formed here, it is formed due to what? 6th nucleus. But why the name is given as facial colliculus then? Why? Because the 7th nerve is going to take a turn around that one. So therefore, if there is an injury at this facial colliculus, सबसे पहले क्या injure होगा? What is going to get injured? Of course, the 7th nerve is going to go on. So damage to facial nerve will occur. That is more better answer when compared to abducens nuclei. Damage to this one is more better answer, this one. And then if the facial nerve is gone, obviously which muscles will be involved? The muscles of facial expression will be involved rather than lateral rectus. Please don't mark the answer as lateral rectus. Remember, the muscles of facial expression will be involved here. And in one of your exam, they have given the name of the muscle as risorius muscle. Understood, my dear friend? I hope this concept is also revised here. Let's go ahead with the next one. Another important question. Now, after learning all these concepts, what happened, recently in one of the exam, they have given a radiological image like this. And in this image, there was an arrow mark given here. Can you please answer me, my dear friends? If there is an arrow mark there, which nerve is visible at the arrow mark structure? Which nerve is visible at the arrow mark structure? Yes, my dear friends, which nerve is visible? Very good, Samprita. Very good, Ishan Verma. Very nice. The fourth nerve is visible. Now, suppose if I give you an arrow mark little bit below here, sir, behind the pons, then which nerve is visible there? Little bit below, behind the pons, which nerve is visible? अभी अभी मैंने आपको बताया था facial colliculus करके, है ना? So therefore, please remember the seventh nerve will be visible here, sir. So please look at the arrow mark very carefully in your exams, my dear friend. If the arrow mark is behind the midbrain, which nerve is visible? That is your fourth nerve will be visible. Trochlear nerve will be visible. And if they're putting the arrow mark behind the pons, then your which nerve is visible there, sir? The seventh nerve. Why? Because that is the one which is going to form that facial colliculus. Please be careful in your exam. So two more MCQs are solved here. Two more one-liners are done here, my dear friends. Clear? चलिए अब हम बढ़ते हैं आगे with the next one. Yes. Now, now we'll just try to little bit slow down here and I'll tell you about the syndromes here. The midbrain syndromes, the pontine syndrome and the medullary syndrome, easily how to answer in the exam. Fine here. So now my dear friends, look at this diagram here. In this diagram, you are able to see the transverse section of the midbrain. Now in the transverse section of the midbrain, this one here will be the ventral aspect here. This is the ventral side here, my dear friends. And this one here will be the dorsal aspect. On the dorsal side, you'll be able to appreciate the colliculi. And suppose we are going to take a section at the level of superior colliculi. Fine. At the level of superior colliculi, you will be able to appreciate that there will be which nerve beginning from here? There will be third nerve beginning from here. At the level of inferior colliculi, there will be fourth nerve. At the level of superior colliculi, there will be like third nerve beginning from here. Then I told you this in the middle, you'll be having a duct here. That duct is aqueduct here. And whatever structure that you're able to find behind the aqueduct, that is tectum, in the middle, tegmentum, and this part here will be the cerebral peduncle. And because this is like cerebral peduncle and cerebral peduncle, in the middle, you'll be able to find interpeduncular fossa. Perfectly fine. Now, what is this gray matter here? This gray matter will be substantia nigra. Substantia nigra. In front of that, there is white matter over here, and this white matter will be crus cerebri. Crus cerebri. Now, in this crus cerebri, of course, it is white matter. Therefore, what is going to pass from here? Your tracts are going to pass from here. So, if you divide that into like three parts, please remember the middle part is the one where pyramidal tract is going to pass. Pyramidal tract or the corticospinal tract is going to pass from here. And now, if you are at the level of superior colliculus, please remember, यहाँ पर ना red nucleus भी होता है. You'll also appreciate the red nucleus also. Red nucleus here. Fine. And last and final thing, if you people remember, our midbrain pons and medulla oblongata are connected to cerebellum behind. And they are connected to the cerebellum with the help of cerebellar peduncle. Cerebellar peduncle. ठीक है ना? Now, midbrain is connected to cerebellum with the help of superior cerebellar peduncle. Superior cerebellar peduncle. तो मान लो कि यहाँ पर ना superior cerebellar peduncle भी होता है. I'm just giving you a schematic diagram. Fine. So if you follow my one diagram here, you will be able to learn about all the syndromes very much easily, my dear friends. Done? आपको इतना सब information अगर आपको पता होगा तो that is like more than enough over here. Now, just a second here, sir. Yes. So now, my dear friends, ये diagram आपको recall हो गया? Now you're able to recall this one? यार एक मिनट disconnect हो गया ये ना. That is about the transverse section of the midbrain. You're able to recall all the structures and we are at the level of superior colliculus. अगर आपको इतने structures पता है, if you know these many structures, more than enough. Now number one, For example, if this part of the, for example, like this part of the midbrain is involved here. अगर मान लो यहाँ पर लेशन होता है, तो what is involved here? Third nerve is involved, and along with the third nerve, what is involved there? That is pyramidal tract involved here. Fine. Third nerve involved होगा, तो obviously there will be third nerve palsy. And whenever nerve is involved, obviously that will be ipsilateral only, my dear friends. Why? Because nerve is actually the lower motor neuron. Fine. It's not like upper motor neuron. तो nerve जब involve होगा, तो उसी वाला side effect होगा. So don't worry about that ipsilateral contralateral right now. I'll make it easy for you people. Okay now. So if third nerve, anytime you remember that nerve is involved, it will be always ipsilateral. So ipsilateral third nerve palsy will be there, and you are like perfect expert in that third nerve palsy. Third nerve palsy में आप perfect हो, है ना? There will be down and out eyeball, there will be ptosis and loss of light reflex and all. ये तो आपको पता ही है अच्छे से. Along with that, pyramidal tract is involved. Now try to recall pyramidal tract कहाँ पर involved हो रहा है? Midbrain में. If it is involved in midbrain, just 2 minutes back I told you, okay, it is before decussation. क्योंकि decussation तो कहाँ पर होता है? Lower medulla में होता है. So therefore, my dear friend, that's like before the decussation there. So therefore, what is going to happen? It will lead to contralateral hemiplegia. क्या होगा? Contralateral hemiplegia. और इस syndrome को हम कहते हैं Weber's syndrome. So Weber's syndrome में क्या होगा? Third nerve involved होगा, ipsilateral third nerve palsy along with contralateral hemiplegia. If you see this combination, that syndrome is Weber's syndrome. Third nerve palsy with the contralateral hemiplegia. Done. Then similarly, my dear friends, if suppose this part is involved here, if this much part of the midbrain is involved here, I mean to say third nerve is involved. If nerve is involved, again it is what, sir? Ipsilateral third nerve palsy will be there. Fine. And along with that, red nucleus will be involved. अब जब red nucleus involved होता है ना, तो please याद रखिए, red nucleus will be connected to what? Your basal ganglia. Basal ganglia is concerned with what? Movement. And therefore, if there is a lesion in that one, it will lead to what? Chorea. So ipsilateral third nerve palsy along with the contralateral chorea and resting tremors. Yes, if you see this combination, that syndrome will be the Benedict syndrome. Benedict syndrome here. Fine. Next one here. Now, my dear friends, for example, if this part is involved here, which one? The superior cerebellar peduncle along with the third nerve. Superior cerebellar peduncle along with the third nerve. Of course, again, what is going to happen? Ipsilateral third nerve palsy hoga. There will be ipsilateral third nerve palsy, and whenever anything related with cerebellum will be there, of course the balance will be gone, so there will be contralateral ataxia. The gait ataxia will be there, and along with that intentional tremors. और इस syndrome को कहा जाता है North Nagel syndrome. इसको हम कहते हैं North Nagel syndrome. Are you understanding me? So in the exam, if you see there is a third nerve palsy, first of all you can narrow down, यार medullary syndrome तो नहीं हो सकता है, Pontine syndrome भी नहीं हो सकता है, क्योंकि third nerve will be coming from midbrain only. So therefore they are giving third nerve palsy. First of all midbrain syndrome में आ जाइए. Then look at the combination. Try to recall this slide in your mind, sir. Along with third nerve palsy, contralateral hemiplegia, Weber syndrome. Along with third nerve palsy, contralateral chorea, Benedict syndrome. Along with third nerve palsy, if there is contralateral ataxia, my dear friend, then it will lead to what? North Nagel syndrome. ठीक है ना? Now, one more thing, what is going to happen is behind here, you'll be able to find the pineal gland here, my dear friends. और यहाँ पर क्या होता है? Sometimes there will be tumor in this one. Pinealoma कहते हैं. When there is a pinealoma, when there is a tumor here, that tumor is going to compress the superior colliculi here. And superior colliculi are concerned with vision. And that too, that is nothing but concerned mainly with the vertical gaze, my dear friend. So if there is an impaired vertical gaze over there, yes, that is nothing but known as the perinod syndrome. So pinealoma, the tumor of the pineal gland, along with what? The impaired vertical gaze, that is nothing but the perinod syndrome, where you will be actually able to appreciate the sun setting sign hota hai. Because the vertical gaze will be gone, the eyeballs will be looking down only. Sun setting sign will be seen in that one. And yes, one more question asked in your exam is about the Claude syndrome here. And in the Claude syndrome, it is a combination of Benedict syndrome along with the North Nagel syndrome. So Benedict along with the North Nagel, together it is nothing but the Claude syndrome. So therefore, my dear friends, yes, if you just remember my one simple diagram over here, you're done. You're good to go with that one. Is it okay? So just look at the combinations there. It is easier for you to understand what has to be done. Is it okay? I think this is like a little bit easier, my dear friends here. Yes. Next one. After that, welcome to the Pontine syndrome. Let us take a transverse section of the pons. when you take a transverse section of the pons here, ventral aspect and dorsal aspect, the first thing is that in the ventral aspect, there will be the corticospinal tract passing from here. Corticospinal tract passing from here, sir, in the ventral aspect. Okay, corticospinal tract is passing from there, from the ventral aspect. It is descending down, pyramidal tract. Then after that, here, you'll be able to find the sixth nucleus and the sixth nerve is coming out from here. और मैंने आपको अभी अभी बताया था the seventh nucleus here and the seventh nerve is going to take a turn around the sixth nucleus and come out. This is the seventh one here. Clear? Now, what is going to happen? There is a syndrome here where this part will be involved. This part of the pons will be involved. I mean to say, sixth nerve is involved, seventh nerve is involved, as well as corticospinal tract will also be involved here. Corticospinal tract is also involved. Okay, and this syndrome will be known as Millard-Gubler syndrome. And you know very well, if sixth nerve will be involved, then what is going to happen, my dear friend? Sixth nerve is the one which is supplying to the lateral rectus, SO4LR6. Sixth nerve is supplying to lateral rectus, and therefore it will lead to, yes, squint. And that will be the convergent squint, because lateral rectus is gone, you're not able to abduct, so it will be like convergent squint. If seventh nerve is gone, of course it will lead to what? The paralysis of the muscles of the face. Facial paralysis will occur. And I told you, whenever it is about the nerve, don't even think, it will be always ipsilateral only. And then corticospinal tract is involved in the pons here, that is before decussation, therefore it will lead to contralateral hemiplegia. So if you are able to see the convergent squint along with the facial paralysis and then contralateral hemiplegia, it is nothing but Millard-Gubler syndrome. Now welcome to the transverse section of the medulla oblongata. All my dear FMG students, this picture was given in your exam, just you have to identify. And you can easily identify the transverse section of the medulla oblongata. Why? Because it is looking like a beautiful butterfly shape. Posteriorly, you'll be able to find the fourth ventricle here, the floor of the fourth ventricle. Anteriorly, you're able to find this elevation, that is olive, and this elevation here, that is the pyramid here. So you're able to find the olive and pyramid. Olive will be formed due to this nucleus here. That nucleus will be the inferior olivary nucleus here. And pyramid is formed due to the corticospinal tract passing from here. Corticospinal tract passing from here, sir. Perfect. By this, we'll be easily able to identify the transverse section of medulla oblongata. Fine. One MCQ is completed. Now let us take only one half of the medulla oblongata and let us see the most important syndromes. One is medial medullary syndrome and lateral medullary syndrome here. Okay, now, my dear friends, please look here carefully. Medial medullary syndrome, नाम से ही हमको समझ में आ रहा है कि this part will be involved. If this part of the medulla oblongata is involved, the medial part is involved, you can clearly look at my diagram and tell me which nerve is involved here. 12th nerve is involved here. Which tract is involved here? The corticospinal tract is involved here. Again, the same thing. If corticospinal tract is involved here, it will lead to contralateral hemiplegia because the crossing is taking place in lower medulla oblongata. And then if 12th nerve is involved, 12th nerve is the one which will be supplying to all the muscles of your tongue. All the muscles of tongue. Okay. And therefore what will happen? It will lead to, yes, deviation of the tongue. When you ask the patient to protrude the tongue will be deviated to the ipsilateral side. Okay, now ipsilateral side, my dear friends. Okay. So therefore the medial medullary syndrome, which is also known as the Dejerin syndrome, okay, in this the 12th nerve will be involved, leading to ipsilateral tongue deviation, and then along with that you'll be able to find the contralateral hemiplegia. And now in the lateral medullary syndrome, all these structures will be involved here. First, remember, my dear friends, lateral medullary syndrome, it is also known as the Wallenberg syndrome. Fine. Now, at this last moment, just before the exam, if you don't want to confuse with all the structure, I'll tell you one thing. At least remember these two things here. Number one, I want all of you to remember that there will be the trigeminal nerve nucleus here. Trigeminal nerve का जो nucleus होता है ना, sensory nucleus. So that is why I wrote here as 5S. Trigeminal nerve sensory nucleus. It's a huge one. And which nucleus will be present in the medulla oblongata? Spinal nucleus. And trigeminal nerve is the one which is going to carry the sensory supply to your face. And then you'll also find the spinal lemniscus. अब यार ये spinal lemniscus किसका continuation होता है? Spinal lemniscus is the continuation of the, yes, lateral spinothalamic tract. And spinothalamic tract is going to carry what? The pain and temperature. but from where? From the body. So therefore, the fifth nerve is going to carry the sensory sensations from your face, that is pain and temperature from the face, whereas the spinal lemniscus is the one which is going to carry the pain and temperature from the body. So therefore, what is going to happen? Therefore, what is going to happen? In lateral medullary syndrome, the pain and temperature from the face will be lost on one side, whereas lateral spinothalamic tract, the contralateral side. Why? Because it is going to cross at the level of spinal cord only. Are you understanding here? So this will be the most important thing. Pain and temperature will be lost on one side of the face, but the pain and temperature will be lost on the opposite side of the body. So there will be, this is known as the crossed hemianesthesia. This is known as what? Crossed hemianesthesia. This is the most important feature, and by this you can easily in the exam differentiate from the other syndromes, the lateral medullary syndrome. तो ये दो पॉइंट एटलीस्ट अभी के लिए याद रखिए. रिमेनिंग the syndromes in detail I have covered in my classes, my dear friends, and all the videos which have been recorded at the PrepLadder. I have covered all the syndromes in detail. Later on you can learn. Now because we are very much near to the exam, please remember this feature. Pain and temperature will be lost in the face on one side. Contralateral side, the pain and temperature is lost in the body. Crossed hemianesthesia. Yes, my dear friend, that is lateral medullary syndrome, also known as the Wallenberg syndrome. Okay, so I think all these syndromes have become a little bit easier for you right now. Clear with this one here? Are you all clear with this one here, my dear friends? Yes. Now moving ahead with the tracts. Tracts तो आपने कई बार पढ़ा होगा. You have learned like many times. तो ये थोड़ा हमारे लिए आसान है. Pain, temperature, crude touch and pressure. All this will be carried by the spinothalamic tract. The information will enter from the dorsal root ganglion. After entering here, they'll be ending in a nucleus here. I want you all to remember the name of this nucleus. It is substantia gelatinosa. Already asked in your exam here. From here, the fibers are going to cross at the level of spinal cord only. Some of them are going to lateral column, and that is going to become the lateral spinothalamic tract. And we have learned many times in our classes that, remember, like lath spinothalamic tract is going to carry pain and temperature. Some of the fibers are going to anterior column. They are going to form your anterior spinothalamic tract. And remember, like ant is going to carry the crude touch and the pressure. Perfect. That is about the spinothalamic tract. You have to remember about that. Then what about the dorsal column? That is important. Dorsal column, you'll be actually having two tracts in the dorsal column. Dorsal column tracts, there will be two of them, fasciculus gracilis and fasciculus cuneatus. Please remember, gracilis is on the medial side, cuneatus towards the lateral side. Already has been asked in your exam. And fasciculus gracilis fibers are coming from where? From the lower limb, whereas cuneatus fibers are coming from where? From the upper limb. And they are going to carry which sensations, my dear friend? The fine touch, vibration, stereognosis, and conscious proprioception. Fine touch, vibration, stereognosis, and conscious proprioception will be carried by dorsal column tract. Now welcome to the very famous one, Brown-Séquard syndrome. What is Brown-Séquard syndrome? Hemisection of spinal cord. मान लो कि आधा स्पाइनल कॉर्ड यहाँ पर कट हो जाता है. If half of the spinal cord is cut here, yes, of course, what is going to happen? The fine touch, vibration, stereognosis, and conscious proprioception will be lost on the same side, ipsilateral side, whereas the pain and temperature, crude touch and pressure will be lost on the opposite side because it is crossing and coming there. I hope my one diagram is very much clear for your tracts. And recently in your exam, this picture was given. This is the site of lesion here. On the opposite side, contralateral side, there is loss of pain and temperature. And on the same side, there is a loss of vibration, the position sense, conscious proprioception, everything. Yes, of course, this diagram is representing the Brown-Séquard syndrome. Brown-Séquard syndrome. Is it okay? Fine here. And in the Brown-Séquard syndrome, I told you about very clearly about hemiplegia. Can you please tell me in the chat box? Let's see whether you are following me or not. Will it be contralateral hemiplegia or ipsilateral hemiplegia? Will it be contralateral or ipsilateral hemiplegia in Brown-Séquard syndrome? Very good, very nice. It will be ipsilateral hemiplegia. क्योंकि यहाँ पर इंजुरी कहाँ पर हो रहा है सर? Where is the injury taking place? Is it like before decussation or after decussation? Yes, it is after decussation. The injury is taking place after decussation. Clear? चलिए sir. So in this manner, my dear friends, as I promised you, yes, we are doing a lot of like clinical anatomy. Initially, someone was telling me, sir, correlate with orthopedics and all. I think we have correlated with the medicine also here. Like all the syndromes we have covered in a simple manner, my dear friends. So I will give you this PDF after the session. Don't worry about that. I'll upload this one in my Telegram channel also. Don't worry about that. You can take the PDF. You can see the video at 1.5x or 2x multiple number of times before the exam. Yes, you will be able to cover all the questions from here. Fine. Fine, my dear friends. Okay. Shubham guy is asking, sir, is this enough for LMR or for revising? I think this is like the most uh, frequently asked questions nowadays, है ना? Sir, ये enough है क्या? PDF चाहिए, PDF चाहिए, ये enough है क्या? Remember, my dear friends, Dr. Shubham guy, this is what is the best that we can do just before your exam. We are covering the entire anatomy here. This is the best that we can do here. ठीक है? Next one, association fibers. After completing all the difficult topics, my dear friend, let us see some quickly miscellaneous topics over here. Yes, once in your exam, they have also asked about the Broca speech area number 44 and area number 45. And the auditory area will be area number 41 and 42, and these two are connected by uncinate fasciculus. Please be very careful. Broca's and auditory are connected by uncinate fasciculus. Now, similarly, this 44 and 45 will be the Broca speech area, and somewhere here we'll be having the area number 22, 39, and 40. That is Wernicke speech area, and those two will be actually connected by the arcuate fasciculus. Both the questions has been asked in your exam, and this is frequently asked. Broca's and Wernicke are connected by arcuate fasciculus. So two more one-liners completed here, sir. Now in the cerebral cortex, where exactly do you find these areas here? Area number 44 and 45 here, Broca speech area. In the inferior frontal gyrus, area number 22 here, then 39 here and 40 here. That is Wernicke speech area. Now, what is the difference between the Broca's and Wernicke? Remember, the Broca speech area will be the motor area, whereas the Wernicke speech area, this will be the sensory area. Okay, Broca speech area, because of which I am able to speak right now, and Wernicke speech area because of which I am able to understand, comprehend right now. Okay, and these two will be connected by the arcuate fasciculus, as I told you. They are connected by the arcuate fasciculus. Fine. Now, suppose if there is a lesion in the Broca speech area, that is very frequently asked in your exam. Okay. Suppose if there is a lesion in the Broca speech area, that will lead to Broca's aphasia, which is also known as expressive aphasia or non-fluent aphasia or agrammatic aphasia. In this, what is going to happen? Broca's is motor wala part. So the person will not be able to speak. Speech become difficult, but he'll be able to understand everything. Similarly, if there is a lesion in the Wernicke speech area, Wernicke aphasia or receptive aphasia or fluent aphasia, please remember the another names very carefully. In exams, they are using all these different names. Okay, and here what is going to happen? The patient will not be able to understand all the spoken and the written language. The patient will not be able to understand here. Wernicke speech area is gone. Okay. तो अगर मान लो कि arcuate fasciculus में गड़बड़ी होती है, if there is an injury in the arcuate fasciculus, then there will be no conduction. So therefore it is known as conduction aphasia. If all the three of them are gone, then it will lead to what? Global aphasia. So conduction aphasia is due to the lesion in which one? Arcuate fasciculus here. And global aphasia, yes, of course, all the three of them are gone there. Clear? So please remember all these aphasias here, sir. So in the cerebral cortex wala part, in all the areas, these areas are very much important, and along with that, the clinical anatomy is completed here, sir. Next one, let us go towards the medial surface. On the medial surface, you are able to appreciate one sulcus here. This sulcus will be the cingulate sulcus. Now this cingulate sulcus, if you follow this one here, it will be going here and splitting. And because it is splitting here, you're able to appreciate one lobe here, and this one will be the paracentral lobule. What is the name of that one? Paracentral lobule. Now two one-liners from here. Number one, paracentral lobule is going to represent the perineum and the lower limb region. Please remember your favorite way of remembering, like mnemonics. Paracentral lobule, P for paracentral, P for perineum, and lobule, L for lobule, L for lower limb. The paracentral lobule is representing the perineum and the lower limb. Now in the perineum region, you have anal sphincter as well as urethral sphincter, and they are going to control the urination as well as defecation. That is the reason why paracentral lobule is the highest center in our body, which is going to control the urination as well as defecation. Highest center in our body, which is going to control the urination and defecation. Are you clear with this one here? So on the medial surface, this is what I want you to remember. And once in your exam, they have given the image-based question to identify this paracentral lobule also. Perfectly done, sir. Now moving on to the next concept, that is cerebellum. Cerebellum, yes. Cerebellar cortex, very much important image-based question. Multiple times this histological image has been repeated in your exam. In the cerebellar cortex, you'll be actually having 3 layers. In these 3 layers, you'll be having 5 types of cells. Okay. Now, outermost layer here will be the molecular layer. The middle layer is Purkinje layer. Innermost layer will be the granular layer. Outermost molecular layer will have stellate cells and basket cell. And then the Purkinje layer will be having the Purkinje cell. And then the granular layer will have granular cells and Golgi cells. Now, what are the MCQs to be remembered here, sir? Number one, and the repeated MCQ in your exams is they will give you this image. In this image, always, my dear friend, they are putting an arrow mark on this cell. Identify that cell. I think in this diagram, the only cell which you can clearly identify is Purkinje cell. Number one, why? Because it is the largest cell. Out of all the cell, it is the largest one. And even remember the shape, it is flask shaped. It is flask shaped. You can easily identify that one. First question completed. Second MCQ. All these cells will be inhibitory, except for the granular cells. Granular cells are the only one which is excitatory. Remaining all the cells are inhibitory. So therefore, we can say that cerebellar cortex is actually the largest collection of inhibitory neurons. It is the largest collection of inhibitory neurons. Only excitatory will be the granular cells. Clear with this one? Next one. Now, what is going to happen about the afferent and efferent? Information is going to come inside the cerebellum. Afferent fibers, and those afferent fibers we divide into 2 categories here, sir. Climbing fibers and mossy fibers. Climbing fibers means what? They are going to climb all the way up to the outermost layer. They're like climbing fibers. Whereas mossy fibers will be going only up to the granular layer. They are mossy fibers. Now in the exam, they'll be asking you which tracts will be included under the climbing and mossy. Just follow my simple method here, sir. Climbing fibers will be including only and only 2 tracts here. One will be the olivocerebellar tract, another one will be the para-olivocerebellar tract. These 2 comes under the climbing fibers category. Rest all the tracts which are going to enter inside the cerebellum comes under the mossy fibers category. That's what. Olivocerebellar and the para-olivocerebellar, these 2 comes under climbing, and remaining all will come under the mossy fibers category. अब ये तो हो गया afferent information is coming in. Now how the information is going out? Efferent fibers. Remember, the efferent fibers are going to start from your Purkinje cells only. Now from the Purkinje cells, the efferent fibers will go deep inside the cerebellum to the deep nuclei, and from the deep nuclei, the efferent fibers are going out into the other parts of the brain. Now, question number 1, from the entire cerebellum, which structure is going to carry the information out? Your answer has to be deep nuclei. Deep nuclei are going to act as efferent from the entire cerebellum. Whereas if they ask you cerebellar cortex, then your answer has to be the Purkinje cells. So from the cerebellar cortex, efferent from the cerebellar cortex will be the Purkinje cells. Efferent from the entire cerebellum will be the deep nuclei. Please remember that one. Fine. And my dear friends, after remembering these 2 points here, yes, my dear friends, after remembering these 2 points here, one more question asked in your exam is about the Purkinje cells are excitatory or inhibitory to the deep nuclei. Of course, I told you all the cells are inhibitory except for granular cells. So Purkinje cells are actually inhibiting the deep nuclei. So don't write the answer as, they are exciting the deep nuclei. They're actually inhibiting the deep nuclei. Okay, done. Now, once you are done with this one, welcome to the deep nuclei of cerebellum. Yes. How many deep nuclei are there in the cerebellum? There are totally 4 deep nuclei in the cerebellum. And the best mnemonic to remember, doctors eat good food. Dentate nucleus, emboliform nucleus, globose nucleus, and fastigial nucleus. It is globose nucleus and fastigial nucleus. Perfect. Now, why I'm telling you this mnemonic here? Why? Because you have to remember them in the same order. Doctors eat good food. Dentate, emboliform, globose, and fastigial. Now, they have asked already in the exam, which is the medialmost nucleus. The medialmost nucleus will be the fastigial nucleus. Now, which one will be the lateralmost nucleus? The lateralmost will be the dentate nucleus. And of course, it is the largest one. And sometimes what is going to happen, globose and emboliform are combined together, and together they are going to be known as interpositus nucleus. Interpositus nucleus. So all the MCQs are covered here. Is it okay, my dear friends? Yes, of course. Yes, of course, Shubham. It is doctors eat good food. Perfectly correct here. Next one, sir. Now, this question was asked in the PG exam. Fibers from the marked structure terminate at which of the following? In this diagram, you can clearly see this one is cerebellum here. Fine. And this one here will be the midbrain. I told you very clearly, midbrain and cerebellum will be connected by the superior cerebellar peduncle. So the marked structure is superior cerebellar peduncle. Now, what are the fibers which are going to pass from here? So please remember that from the dentate nucleus and the interpositus nucleus, that is emboliform and globose, you can see these fibers, and these fibers are going from the superior cerebellar peduncle, and they are going to enter into the midbrain and cross there, and after crossing, finally they are going and ending in the thalamus and the red nucleus. So basically for your PG exam, you also have to remember about all the afferent and efferent passing from the cerebellar peduncles. The afferents and efferents from the cerebellar peduncles, I have taught that in detail in the videos at PrepLadder, my dear friends. You can go and study over there. The afferents and efferents of the cerebellar peduncles. So from the dentate nucleus and the globose and emboliform, the fibers are finally going and ending in red nucleus and thalamus. So this question answer here is red nucleus. The fibers will go and end in the red nucleus. Clear with this one here? And by this, my dear friend, welcome to the last and final thing in the neuroanatomy here. Circle of Willis. Yes, of course, I'm not going in detail of that one. You know very well about that one. Hai? Now, in the circle of Willis, what is going to happen? This one here will be the vertebral artery here and vertebral artery here. Both of them will combine together to form basilar artery here. This is finally dividing into posterior cerebral artery here and posterior cerebral artery here. This one here will be your internal carotid artery here. It will give rise to ACA and ACA here, sir. And it itself is going to continue into your MCA here. And the ACA and ACA are connected by this ACOM here, anterior communicating artery. And this one here will be the PCOM here. Everyone knows very well. We have been learning about this one right from first year MBBS days. So we are not going to waste our time in learning the circle of Willis right now. I hope till now, whatever I taught you, you are able to understand what I am focusing on. All the difficult and the high yield topics, very much important one. अब यहाँ से सवाल क्या आएगा? Clinical anatomy is very much important here. If there is an aneurysm in the anterior communicating artery, you can clearly see the ACOM is very much nearer to optic chiasma. So anterior communicating artery aneurysm is going to compress the optic chiasm. ACOM aneurysm, anterior communicating artery aneurysm is going to compress optic chiasm. Similarly, the posterior communicating artery उसके बिल्कुल पास से पास होता है third nerve, oculomotor nerve. So therefore, that is going to get compressed there. Okay. And if there is a rupture of the saccular aneurysm, it will lead to which type of hemorrhage? It will lead to subarachnoid hemorrhage. Subarachnoid hemorrhage. Is it okay? Now, once you are done with this one here, my dear friends, by this we are actually done with all the information regarding the neuroanatomy. I think the students who are revising along with me and who have actually done their regular class perfectly, my dear friends, you are able to recall now everything in the neuroanatomy. The way I am doing the revision session here, even though we are learning 100 important one-liners over here, of course, anatomy is incomplete without the images. Images has to be there here in the anatomy. It can't be just one-liners. So I have included everything over here. So the people who have done the regular classes, they might be observing here. Almost everything is done in the neuroanatomy here. Everything. Now moving on to the next topic, that is head and neck topic right now. Have some patience. Don't worry that it is taking a longer time. Of course, this topic, head and neck and neuroanatomy, will take a longer time. After that, upper limb, lower limb, thorax, abdomen, that will be done very quickly. Don't worry about that one. Okay. Now? So, and these are the topics where you will be finding like a lot of MCQs you will be losing in the exam. So that is why I'm giving like ample time here. Don't worry about that. Everything is like well planned. Follow the planning here, sir. Is it okay? I hope all of you are enjoying the session here. Okay, Shubham. Now let's start with the head and neck topic right now, my dear friends. Okay. In head and neck topic, yes, one of the most important topic is about the cranial foramina. In the cranial foramina, there are like so many cranial foramina, but what I have observed in the exam, the most important focus is always on this cranial foramina over here. Now in this one, first you'll be able to find lesser wing and the greater wing of the sphenoid bone. Between the lesser wing and greater wing, you'll be able to find one opening here. That is nothing but superior orbital fissure. Now what is going to pass from the superior orbital fissure? Oculomotor nerve, third nerve, the trochlear nerve, and the sixth nerve. Why these three nerves are passing from here? Because they have to supply to extraocular muscle. We know that world famous formula SO4 LR6 rest all by 3. They're passing from here. Along with that, even 5-1 will be passing from here. What is 5-1? The first branch of the trigeminal, that is ophthalmic nerve. Ophthalmic nerve. Trigeminal nerve has got like 3 branches: ophthalmic, maxillary, and the mandibular nerve. Okay, now ophthalmic, maxillary, and mandibular. So please remember, ophthalmic nerve is going to pass through the superorbital fissure. In fact, actually, to be very frank with you, ophthalmic nerve itself is not going to pass through the superorbital fissure. इसके ना तीनों branches होते हैं. There will be like 3 branches of this one here. Okay, number 1, there will be the frontal nerve. Number 2, nasociliary nerve, and number 3 will be the lacrimal nerve. These 3 branches are going to enter inside the superorbital fissure. I'll tell you the importance of that within few minutes. Along with that, even ophthalmic veins are also passing from here. Then what is going to pass through foramen rotundum? That is maxillary nerve is going to pass from here. 5-2. Then what is going to pass through foramen ovale? Very much important for your exam. Yes, there are like 4 structures passing from here. We remember with the mnemonic as male. M for mandibular nerve, A for accessory meningeal artery, L for lesser petrosal nerve, and E for emissary veins. Please remember that very carefully. Many times asked in the exam. Then after this, you'll be able to find the foramen spinosum. So we are going to remember all the 3 of them as ROS, rotundum, ovale, and spinosum. Rotundum, ovale, and the spinosum. Now foramen spinosum, there is a nerve passing from there, nervus spinosus. That is easier to remember. Foramen spinosum, nervus spinosus. But the most important thing and trending question in your exams nowadays is middle meningeal artery. If this artery is ruptured here, then obviously it will lead to epidural hemorrhage. Epidural hemorrhage. I hope you have learned in radiology very well about this one, that biconvex shape will be visible in the radiological image. Idli shape, बहुत सारे उसके नाम दिए गए हैं, है ना? So you'll be able to find that hemorrhage, that biconvex hemorrhage. Yes. And second point that you have to remember along with that one is lucid interval. So one will be the biconvex hemorrhage that we'll be able to see, that idli shape one. Along with that, remember lucid interval. The patient will become unconscious, then again conscious for some time, then again unconscious. Lucid interval will be there in that one. Okay, so middle meningeal artery rupture will lead to epidural hemorrhage. Now the next one here, this is the internal acoustic meatus, my dear friend. And what is going to pass from here? That is the 7th and 8th nerve is going to pass from here. And then the very famous jugular foramen. So what is going to pass from the jugular foramen? 9th, 10th, and 11th nerve is going to pass from here. So this is all that you have to actually revise before the exam in the cranial foramina. Now in one of the PG exam, the question is about the foramen lacerum here, sir. Now what is the question asked about the foramen lacerum? Please look at this diagram very carefully here. This one here will be the foramen lacerum here. Perfect. To be very frank with you, foramen lacerum is actually not a foramen. It is a space which is left between 3 bones. Now which 3 bones? On one side you're able to appreciate the sphenoid bone. On the other side you're able to appreciate the temporal bone. And then other side you're able to appreciate the occipital bone. First you learn this one. So that foramen lacerum is actually a space left between 3 bones actually. One is the sphenoid, and then the occipital, and then the temporal bone. Then you go in detail of that one. Yes, number 1, there will be sphenoid bone. Number 2, there will be apex of the petrous part of temporal bone. And number 3, there will be the basilar part of the occipital bone. The sphenoid bone, occipital bone and temporal bone, इन तीनों के दरमियान में होता है foramen lacerum. Then jugular foramen कहाँ पर होता है? It is actually present between only 2 bones. This one here is your temporal bone and this one here will be the occipital bone. Fine. Now apart from that, the most important thing here is that about the superior orbital fissure. First, let us take up the superior orbital fissure. Now near the superior orbital fissure, you'll be actually having a ring of Zinn. There is a ring of Zinn from where the extraocular muscles will actually take origin, the recti muscles. So now what you have to do is, if this one here will be the superior orbital fissure between the lesser wing and the greater wing, if that is a superior orbital fissure, And if this is the ring of Zinn over here, you need to learn what are the structures passing inside the ring and which are going to pass outside the ring. So this entire superior orbital fissure is actually divided into three parts here. One is the superolateral part, one is the intermediate part, and then another one will be inferomedial part. Superolateral, intermediate part, and inferomedial part. Fine. Now I'll tell you one beautiful way how to remember the structures here. Okay. Please remember LFT. LFT is left outside the ring of Zinn. L for lacrimal nerve, F for frontal nerve, and then T stands for the trochlear nerve. So remember, like left is left outside the ring. Left is left outside the ring, sir. So please remember lacrimal nerve, frontal nerve, and trochlear nerve is outside the ring. Remaining all the structures, the nasociliary nerve, the oculomotor nerve, the abducent nerve, all the remaining structures are going to pass inside the ring. Clear? And after that, you will be having ophthalmic veins also passing from here, superior and inferior. Superior ophthalmic vein will be here in the superolateral part, and inferior ophthalmic vein will be in the inferomedial part. That's all. Make it very simple. So LFT, left is left outside the ring, sir. Please remember that, more than enough. The next one here. After learning this one here, welcome to jugular foramen. Now in jugular foramen, why the name is given like this here? Please look at the image very, very carefully here. Now in this diagram, my dear friend, there will be a transverse sinus coming from here. And this transverse sinus is going to take a turn and become sigmoid sinus passing from here only. And then from the other side, we'll be having the inferior petrosal sinus coming and passing from here only. So this sigmoid sinus and inferior petrosal sinus. Now, for example, imagine my hand here to be like jugular foramen here. If this is jugular foramen, transverse sinus is coming from here and then becoming sigmoid sinus and passing from here only. And then inferior petrosal passing from here only. And both of them will join together to form your internal jugular vein. Internal jugular vein is forming. That is the reason why this foramen here will be referred to as your jugular foramen. So don't think that only the 9th, 10th and 11th nerve is passing from here. Along with that one, sigmoid sinus as well as inferior petrosal sinus is also passing from here. And you have to remember all of them in order. So in jugular foramen, number 1, there is inferior petrosal sinus. Number 2, 9th nerve, 10th nerve and 11th nerve. And then the sigmoid sinus. All the structures are passing in this order here. Perfectly done. Revision ho gaya. Now, one more important point to revise here is, out of the 3 nerve, 9, 10, 11, which nerve will be in a separate sheath? Can you please tell me? Out of 3 nerves, which nerve will be in the separate sheath? Of course, the 9th nerve will be in the separate sheath here, whereas the 10th and 11th nerve, these two are present together. And 10th and 11th together, they are going to form that VAC. VAC is nothing but your vago-accessory complex. The 10th nerve is vagus nerve and 11th nerve is accessory nerve, and they are together going to form the vago-accessory complex. Is it clear? So by this, we have revised all the points regarding the jugular foramen also. Now let's move ahead with the next one. Another important thing nowadays asked in your exam is not only the foramen, you also have to remember which nerves are going to pass from all these foramina. Along with the foramens, you also have to remember like which nerves are going to pass from here. Anyone can say that what is the nerve passing from cribriform plate? This one here will be the first cranial nerve, that is your olfactory nerve. Then passing through the optic canal here, this one here will be the second cranial nerve, that is your optic nerve. Fine. And just now I told you, if this is the superior orbital fissure here, then you have to understand that third, fourth and sixth nerve will pass from here. But that is important to identify. So please look at this diagram very carefully. In the exam, whenever you see a nerve here, this one will be your third nerve, oculomotor nerve. And the nerve which is going to take a turn and come from behind, that is fourth nerve, trochlear nerve. I told you trochlear nerve will have dorsal origin. It's going to take a turn and then come in the front. So it is your fourth nerve. And whenever you see any nerve, climbing up from this slope here, this nerve here will be the sixth nerve, abducens nerve. I'm telling you a little slowly here. Why? Because these 3 nerves are the one which you have to identify in the exam. So third nerve, then the fourth nerve and the sixth nerve. Of course, this largest one anyone will identify. This one is your fifth cranial nerve, that is trigeminal nerve. And what is going to pass into the, internal acoustic meatus, that is the 7th nerve and the 8th nerve, facial and vestibulocochlear along with the labyrinthine vessels. And then what is going to pass through jugular foramen, 9th, 10th and 11th one. And what is going to pass from the hypoglossal canal, that will be the 12th nerve. That is very much easier to identify. Your focus should be actually on these three of them. Confusion yahin par hota hai. Third nerve, the fourth nerve and the sixth nerve. Don't get confused in that one. Fine. One of the question asked in your PG exams is intracranial spread of the COVID. Intracranial spread of the COVID is through which one? Of course through the cribriform plate, क्योंकि वहीं से तो कौन सी वाली nerve pass हो रही है sir? Olfactory nerve is going to pass from the cribriform plate. So intracranial spread of the COVID is via cribriform plate. Already asked in your exams. Next one. This image was given in your exam, in the PG exam, and you have to identify the foramen here. This foramen here will be the foramen rotundum. What is going to pass through foramen rotundum? Of course, it is the maxillary nerve. Then this foramen here will be the pterygoid canal. And what is going to pass through the pterygoid canal? The nerve to pterygoid canal. And this nerve to pterygoid canal itself is known as the Vidian's nerve. Vidian's nerve. ये बहुत important है, अच्छे से याद रखिए इसे. So on the screen, you are able to see the sphenoid bone. In the sphenoid bone, you should be able to identify this foramina. Clear? Moving on to the next one, sir. Yes. How can you leave this concept and go to the exam? Pterion. Definite question in your exams. The people who are actually going to approach, go and write the, FMG exam on 12 January. Please remember that. One question for sure in your exam, pterion. Every time in every exam, they're asking one question from here, sir. Now, first of all, what is pterion? We have discussed this many a time. Recently, on my YouTube channel, I have even made a beautiful reel also on this one. YouTube shorts also on this one. You can go and watch. All the points are covered in that one. Pterion is actually a H-shaped suture. It is H-shaped suture here. And that is formed between the four bones. Okay. Number one, you're able to see here the frontal bone here. Number two, parietal bone here. The squamous part of the temporal bone and the greater wing of the sphenoid. Pterion is a H-shaped suture between these four bones here. Now, what is more important for your exams is relations. The deep relations of pterion. What do you have just inside the pterion? Number one, you'll be having the middle meningeal artery. But in the exam, they're asking which division of this one. Remember, it is the frontal or anterior division. So, यहाँ पर क्या होता है? Middle meningeal artery is going to enter here. And after entering here, it is divided into two divisions. One is posterior division, another is frontal. So which division is present just inside the pterion? That is a frontal division or anterior division. Next one. And apart from that, you'll also have your cerebral hemisphere here. Now, if this is the cerebral hemisphere, now my dear doctors, what is this fissure here? This one will be nothing but the sylvian fissure, also known as the lateral sulcus. And inside the sylvian fissure itself, what is going to pass from here is the middle cerebral artery will be passing from here. So you'll be also able to appreciate the middle cerebral artery as well as sylvian fissure here, the beginning of the sylvian fissure. And of course, it is formed by greater wing of the sphenoid. But remember, inside you'll be having the lesser wing of the sphenoid. And one more question here about the clinical correlation, my dear friend. If there is a fracture at this pterion, अगर यहाँ पर fracture होता है, I told you just inside this which artery is there? Middle meningeal artery. If that is ruptured, again it will lead to epidural hemorrhage. Again it will also lead to epidural hemorrhage. Perfectly done here, my dear friends. Okay. Now once you are done with the pterion, next one, another very important topic for your exam, muscles of mastication. Actually, in the PG exams, so it is like compulsory question. INA said examiners like mad about behind these muscles of mastication. There are totally like 4 muscles of mastication. Number one, this one here will be the masseter. This one here will be the temporalis. And then this one here will be the lateral pterygoid. And this is the medial pterygoid. In NEET PG exam, they have asked about identifying this lateral pterygoid. Please remember, it is going and inserting where? Onto the capsule of temporomandibular joint. So first you should be able to identify the 4 muscles of mastication. Okay, now you should be able to identify the 4 muscles of mastication. Now let me tell you like two one-liners here itself, my dear friend. Number one, this temporalis muscle is a big muscle. So therefore, what is going to happen? The fibers which are present more posteriorly, they are more like horizontal fibers. So because they're like more horizontal fibers, when they are going to contract, what is going to happen? Retraction of mandible will occur. So these are helping in retraction of the mandible. These vertical fibers here, they are helping in what? They are helping in, yes, elevation of the mandible. So retraction of the mandible and then elevation of the mandible. There are 2 functions of that. Now in the exam already they have asked if both the options are given, which is like more better option. So please remember, for temporalis, elevation is more better than retraction. Temporalis has got like two function, elevation and retraction. But out of them, if both the options are given, elevation is more better option when compared to retraction. Number one MCQ completed here. Now welcome to the six MCQs here, sir. Six one-liners here, one by one. All the muscles of mastication will be supplied by which nerve? Remember, all the muscles of mastication will be supplied by mandibular nerve. Okay, trigeminal, three branches, mandibular. Mandibular nerve is supplying to all the muscles of mastication. Now, opening of the jaw or depression of the mandible is done by lateral pterygoid muscle. Now, most of the time we have seen the students are getting confused in the exam by lateral pterygoid and medial pterygoid. Please remember that lowering of the jaw is by lateral pterygoid. Opening is nothing but like lowering of the jaw. So lowering of the jaw is done by lateral pterygoid. Remaining three muscles are helping in closing the jaw. Learn very smartly. I'm telling you only about the opening of the jaw. Don't think that Azam sir is not telling about the closing of the jaw. Rest all the three muscles will help in closing the jaw. Retraction of mandible, I told you just now, it is done by temporalis muscle. I told you very conceptually, it is done by temporalis muscle. Most commonly involved in trismus, locked jaw, mute, remember medial pterygoid muscle. I hope you'll not get any confusion here now. You know, so locked jaw is nothing but like mute. We are not able to speak in that one. So therefore, remember medial pterygoid one. Locked jaw while yawning. This was given in the exam. Hai na? Locked jaw while yawning. Now please be very careful in the exam here. Don't answer as medial pterygoid again. Yawning, you're opening the jaw. So therefore, now the answer will be the lateral pterygoid muscle. Now out of all the muscles of mastication, remember, which one is the accessory muscle of mastication? This was given in FMGE exam, my dear friend. Accessory muscle of mastication will be buccinator muscle. Buccinator muscle will be the accessory muscle of mastication. Fine with this one here. So in this manner, my dear doctors, we are done with all the points that are required to be learned in the muscles of mastication. Muscles of mastication, all the one-liners are complete here. Done. Next one, guys. Muscles of the tongue. Yes, how can you forget this tongue topic right now? Extremely important one for your FMG exam. You can expect one question on 12th January 2025. Okay. Now in muscles of tongue, remember, there will be like two categories, intrinsic, extrinsic. Don't waste your time in learning intrinsic muscle. Only extrinsic is important. Number one, you're able to find one muscle here coming from the genioid tubercle of the mandible, and this muscle here will be the genioglossus muscle here, sir. Number one. Number two, there will be styloid process here. From the styloid process coming into the tongue, styloglossus muscle here. Number three, above here, there will be a palate here, sir. And from the palate, there is a muscle coming into the tongue, palatoglossus here, sir. And below here, there will be hyoid bone. And from the hyoid bone, there is a muscle coming into the tongue, that is hyoglossus muscle. Okay, so you can remember that very easily with the help of directions there. Aage genioglossus, piche styloglossus, above palatoglossus, and below there, it will be hyoglossus. Now, three MCQs here. Out of that, which is the largest muscle of mastication? Sorry, which is the largest muscle of tongue? Genioglossus muscle. Which will be the safety muscle of tongue? Number two, genioglossus muscle. Which is not a true muscle of tongue? That is palatoglossus muscle. So three one-liners are completed here. Then we know the nerve supply very well. All the muscles of tongue will be supplied by which nerve only? It is supplied by hypoglossal nerve, except for which muscle? That is your palatoglossus muscle. And palatoglossus muscle is actually supplied by the pharyngeal plexus, which is also referred to as your vago-accessory complex here, sir. I hope this is very clear. So we have completed all the points related to muscles of tongue over here. Now moving on to the supply, nerve supply of tongue, that is sensory supply. I told you about the motor supply, now sensory supply. Now when it comes to sensory supply, my dear friends, many students will be actually confused here. Why? Because we have like both the sensation from the tongue, the general sensation as well as the special sensation, the taste as well as the general sensation. The best way, follow my method as I teach in my regular classes also. Divide the tongue into anterior 2/3, posterior 1/3 and posterior most part. After that, remember 5, 7, then 9 and 9 and then 10 and 10 here. So 5, 7, 9, 9, 10, 10. That is the best way to remember about the sensory supply of the tongue. How? What is the meaning of this one here? Remember, Anterior two-third of the tongue, taste sensation, special sensation taste will be carried by the seventh nerve, facial nerve. Which branch of the facial nerve was asked in the FMG exam? You know very well, it is chorda tympani branch. Chorda tympani branch. So the taste sensation from the anterior two-third is carried by chorda tympani branch. But you have to remember the exception here. यहाँ पर papillae होते हैं जिनको हम कहते हैं circumvallate papillae. And from the circumvallate papillae, the taste will be carried by the ninth nerve. That's an exception that you have to remember. So from the anterior two-third of the tongue, the special sensation taste will be carried by the seventh nerve, that is your facial nerve, except for what? Except for the circumvallate papillae, and from there, the taste will be carried by the ninth nerve, glossopharyngeal nerve. Now, whereas the general sensation from the anterior two-third will be carried by the trigeminal nerve, that is your fifth cranial nerve. Now, which branch of the fifth cranial nerve? Of course, trigeminal nerve will give like three branches, which is coming down to the tongue. Mandibular. Mandibular will give like many branches. Out of them, the one which is going to the tongue will be the lingual branch. The lingual branch of the mandibular of trigeminal will be carrying the general sensation from anterior two-third. If you remember this very clearly, my dear friends, after that, no problem at all. Posterior one-third of the tongue, both general and special sensation is carried by ninth nerve, and posterior most part of the tongue, both general and special are carried by 10th nerve. No tension at all here. Are you getting me? So anterior two-third is very much important, and mostly the questions will come from there itself. Please remember that very carefully, my dear friends. Take it. Now, once you are done with this one here, yes, nowadays, like one question which has been added into your exams, that is about the papillae of the tongue. I hope you all know very well the filiform papillae, fungiform papillae, circumvallate papillae. This is like a new question which is coming in the PG exams nowadays. So please remember about them. Identify the papillae which is given here in this diagram. Yes, first of all, please remember this one here will be the circumvallate papillae. Now, how to remember this one here in the circumvallate papillae? You will be able to find a deep trench here. On either side, you'll be able to find a deep trench here, and the taste buds will be located here. Let me tell you about the few points that you have to remember about the papillae of the tongue. Remember, all the papillae of the tongue have taste buds, except which one? The filiform papillae. MCQ number 1. Okay, one-liner number 1, question number 1. All the papillae of the tongue will be having taste buds, except which one? Filiform papillae will not have the taste buds. Point number 2, one-liner number 2 that you have to remember is all the papillae are lined by non-keratinized stratified squamous epithelium. Non-keratinized one, but the filiform papillae will be having the keratinized one. All of them will have non-keratinized epithelium, but this one will be having the keratinized one. And I told you about the nerve supply very clearly. All the papillae will be supplied by the chorda tympani branch of the facial nerve, except for circumvallate papillae. And circumvallate papillae will be supplied by the ninth nerve. Okay, so if you remember these 3 points, you will be able to actually identify in the exam and mark the answer. Fine here. चलिए सर आगे बढ़ते हैं. Rule of 17. Many students are confused with the ipsilateral deviation and the contralateral deviation. First of all, whenever the uvula is deviated there, we are testing which nerve? 10th nerve, that is your vagus nerve. Whenever the angle of mouth is deviated, then we are actually testing which nerve here? The 7th nerve. Whenever the tongue is getting deviated here, we are testing which cranial nerve? The 12th nerve. And wherever the jaw is deviated, we are testing which nerve here, sir? That is a 5th nerve. 5th nerve, that is your trigeminal nerve, supplying to all the muscles of mastication. 12 plus 5 will be totally 17 here, and 10 plus 7 will also be like 17 here. Now this 10 plus 7, remember, it will be the contralateral deviation here, my dear friends. And whereas the 12 plus 5, this will be ipsilateral deviation here. That makes remembering very much easier. है ना. तो कॉन्ट्रालेटरल आप कैसे याद रखोगे? वेरी गुड शुभम, वेरी नाइस समृता, वेरी नाइस डॉक्टर एम. You people are learning very nicely. I hope you have learned in the regular classes very nicely there, है ना. So for example, if you ask the patient to protrude the tongue and the tongue is deviating towards the right side, ipsilateral side, 12th nerve is gone. If the jaw is deviating towards the right side, that means the right side 5th nerve is gone there. So that is actually the rule of 17 here, sir. Thank you, Dr. Ramesh. Simple, sir. And now, welcome to this one here, the cranial nerve nuclei. Now, actually, in this our like one-liner session here, of course, we'll not be able to do the entire cranial nerve nuclei. I have taught that in detail how to locate. In fact, at the end of the topic, you yourself can locate all the nuclei. But for your exams, just for your exam, at least recall or revise these two columns over here. One is your GVE column, very much important, sir. General visceral efferent column. Another one will be the GSA column, that is the general somatic afferent column. Okay. Now in the GVE column, general visceral efferent column, from the name itself, we are able to recall that. Yes, GVE, general visceral efferent supplying to the viscera. So viscera, in the sense, it will be supplying to the smooth muscles and glands. This is the column which is concerned with all the nuclei supplying to the smooth muscles and glands. Fine. Now, why I'm asking you to remember this one? Yes, it is even important for the FMG exam also, my dear friend. In all the cranial nerves that I taught you, it is like a summary of this one here. For example, number one, there is a Edinger-Westphal nucleus in the midbrain. Of course, all the cranial nerve nuclei will be in the brainstem. So this is your midbrain here, and this one is the pons here, and this one is the medulla oblongata here. Edinger-Westphal nucleus will be located in the midbrain. And from the Edinger-Westphal nucleus, the fibers are passing along with which nerve? Along with the third nerve. And yes, of course, they are going to end in which ganglion? Ciliary ganglion. And from the ciliary ganglion, there will be short ciliary nerve, which will be supplying to the smooth muscles present inside the eyeball. That is your sphincter papillae muscle and the ciliaris muscle. So the sphincter papillae muscle and the ciliaris muscle, these two muscles are, yes, supplied by the Edinger-Westphal nucleus fibers, which are passing through which nerve? Third nerve, via which ganglion? Ciliary ganglion. Now, the one which is asked in the FMG exam recently, my dear friend, welcome here. The seventh nerve, this seventh nerve will give a branch here, that is your greater petrosal nerve. And greater petrosal nerve will go and end in which ganglion? Pterygopalatine ganglion. And via that one, we are supplying to which gland? Lacrimal gland. Already asked in your exam recently, sir. Then the same seventh nerve is giving chorda tympani branch. It is going and ending in which ganglion? That is the submandibular ganglion here. And submandibular ganglion, via that it is supplying to submandibular gland and sublingual gland here. And one more MCQ which is asked in your MC exam is ninth nerve will be going and actually giving a branch. There are like so many branches in the middle which we have done in detail. Ninth nerve will give a branch, that is Jacobson's nerve. It will be going to finally going and ending in tympanic plexus, and from there you will be having the lesser petrosal nerve going and ending in otic ganglion, and via otic ganglion it will be supplying to the parotid gland. Very much important, parotid gland. So they have asked like two MCQs here. Parotid gland is supplied by which nerve? Of course the ninth nerve. Via which ganglion? Of course via otic ganglion. Lacrimal gland is supplied by which nerve? The seventh nerve. Via which ganglion? Pterygopalatine ganglion. So like all these MCQs has been asked in your exam. Please take care about this one here. Done. Now after that, my dear friends, remember GSA, general somatic afferent. From the name itself, you are able to understand. General, it is going to carry general sensation. Somatic will be referring to body wall. And here in the body wall, we are referring to head and neck here. So in the head and neck here, the skin here, from here, the sensory afferent. Sensory supply to this skin will be by, of course, trigeminal nerve. तो यहाँ कौन सा वाला nucleus होना चाहिए? It should be the sensory nucleus of trigeminal. And the sensory nucleus of trigeminal is such a big nucleus. You can see in the table here, entire table, the largest one out of all the nuclei. The largest one out of all the nuclei will be the sensory nucleus of trigeminal. Sensory nucleus of trigeminal, it is the largest one. It is present in midbrain as well as pons as well as medulla oblongata. Midbrain, pons and medulla oblongata. Therefore, my dear friend, you have to remember the part which is present in midbrain is known as mesencephalic nucleus. The part which is present in pons, it is known as chief sensory nucleus, and the part which is present in the medulla oblongata is known as the spinal nucleus. Okay, are you understanding, my dear friends here? Now remember, from the face, the pain and temperature will be carried to which nucleus? Spinal nucleus. From the face, the pain and temperature is carried to spinal nucleus. Now from the face, remember, the touch and pressure will be carried to which nucleus? The chief sensory nucleus. Similarly, please remember this one. Proprioception from the face will be carried to which nucleus? Mesencephalic nucleus. This is very much important, already asked in your exams. Proprioception from the face will be carried to the mesencephalic nucleus. Clear with this one here? Next one. Now, mandibular nerve. Nowadays, very much important for your exam, sir. In mandibular nerve, what you do is, first of all, on the screen you're able to see, it will be having like two things, sir. One is the motor as well as the sensory part. Mandibular nerve, mixed one. It is having two components. One is the sensory component, another one is the motor component. And both of them are combining together. They are passing through which foramen? Foramen ovale. We know the mnemonic male. So we know that the mandibular nerve is going to pass through which foramen? Foramen ovale. Fine. Now first you'll be able to find the trunk of the mandibular nerve. This is the trunk of the mandibular nerve here, sir. And now the trunk will actually divide into two divisions. One is anterior division and posterior division. About the anterior and posterior division, I'll tell you later on. Now please remember first about the trunk, my dear friend. In the trunk, you have to remember 4 points. Point number 1. We know that mandibular nerve 5-3 is supplying to all the muscles of mastication. And out of the 4 muscles of mastication, trunk is supplying to one of the muscle of mastication. Remember, medial pterygoid muscle. Point number 1. Remaining all the muscles, rest all muscles of mastication will be supplied by anterior division. Rest all muscles will be supplied by anterior division, but they have already asked in the exam, trunk will be supplying to only one muscle of mastication, that is medial pterygoid. Now, that same nerve which is supplying to medial pterygoid muscle, it is also giving a branch supplying to two tensors. How you are going to remember? Two tensor. Tensor veli palatini, tensor tympani. Then third point is the same nerve, the trunk is giving one more branch, that is nervus spinosus. What is its name here? What is this nerve here, my dear friend? This is nothing but nervus spinosus. And I told you very clearly, nervus spinosus is going to pass through the foramen spinosum. The foramen spinosum along with middle meningeal artery. So that is the third point to remember. And finally, the fourth point to remember is the trunk of the mandibular nerve is passing through a ganglion, that is otic ganglion. So on this slide, there are like 4 MCQs possible here. 4 MCQs यहाँ पर important है इस slide पर, ठीक है ना? So the trunk of the mandibular nerve is supplying only one muscle of mastication, medial pterygoid. Number 2, it is supplying to two tensor, tensor veli palatini, tensor tympani. Number 3, it is giving nervus spinosus. And number 4, it is passing through a ganglion, otic ganglion. Now about the anterior division, you just have to remember it is supplying to the rest all muscles of mastication. Lateral pterygoid, masseter, temporalis, usko supply करता है. But posterior division is very much important, sir. Why? Because questions are coming from here in your exam. Posterior division is the one which is giving 3 branches, and we remember that as Ali branches. A stands for auriculotemporal nerve, L stands for lingual nerve, I stands for inferior alveolar nerve. Every branch is very much important. They're asking questions in your exams nowadays from here, sir. Okay, so now let us see the posterior division. Now, don't worry about seeing this diagram here. In the posterior division, it is giving Ali branches. A stands for auriculotemporal nerve. Auriculotemporal nerve. And the name itself is telling it is going behind here. Auriculotemporal nerve. You can see here in this diagram, it will be actually going behind here. This one here, auriculotemporal nerve. So it will be supplying to the skin over the auricle, upper 2/3, as well as the temporal region here. Okay. And then it is also supplying to temporomandibular joint, as well as it is also supplying to parotid gland. That is important. So auriculotemporal nerve is supplying to which gland? Parotid gland finally. Number 1, it is important. And then I told you very clearly, it is also supplying to upper 2/3 of the auricle. It is supplying to the upper 2/3 of the auricle, auriculotemporal nerve. Then what about the lower 1/3, sir? This lobule here, it is supplied by great auricular nerve. So this is taken care by auriculotemporal nerve, and this is taken care by great auricular nerve. Are you able to recall the last NEET PG exam? In the last NEET PG exam, they have asked about the nerve supply to the auricle here, sir. So upper 2/3 auriculotemporal nerve and lower 1/3 is by great auricular. Done. Remember these points here. Next one. The second one I told you, Ali branches. L stands for lingual nerve. अब यार ये lingual nerve में क्या याद रखना होगा? You can clearly see here. Lingual nerve. The first point you have to remember in the lingual nerve is it is going to pass through a ganglion here, and that ganglion will be the submandibular ganglion. मैंने आपको अभी बताया था. Lingual nerve is the one which is going to pass through a ganglion. Which ganglion? Submandibular ganglion. Okay, number 1 thing. And after that, it is going to the tongue, carrying the general sensation from the anterior 2/3 of the tongue. I told you that very, very clearly. Fine. But along with that, remember, there will be a gland here. there will be one salivary gland, submandibular gland. और सबमैंडिबुलर ग्लैंड जो होता है ना, उसका जो डक्ट होता है, द डक्ट इज गोइंग टू turn around this lingual nerve. The duct is going to turn around this lingual nerve. So in the exam, they are giving this clinical question here, my dear friends, that yes, most common nerve to be damaged while submandibular duct removal is lingual nerve. Most common nerve to be damaged whenever you're going to remove the submandibular duct here, that is which nerve here, sir? That is a lingual nerve. Because of this, please remember this clinical correlation here, sir. Okay, and in the early branches comes now I. I stands for the inferior alveolar nerve. From the name itself, you are able to understand the inferior alveolar nerve. Yes, it is going to go into the inferior alveolar nerve is going to go into the mandible, the lower jaw. Okay, now, and it is going to enter into the mandible via foramen, and that foramen was asked in your exam. That is mandibular foramen. So mandibular foramen is the one which is going to transmit inferior alveolar nerve along with the even the vessels also. समझ में आ रहा है? So what I am trying to tell you here, sir, my dear friends, in the posterior division, there are like three branches given here, early branches. In all the three branches, remember, like 2 points are asked from here, sir. And I have covered all those points here. Okay. So auriculotemporal nerve, important for your nerve supply over here. And then L stands for lingual nerve. Number 2 points here. It is passing through submandibular ganglion as well as the clinical correlation with submandibular gland. And then I stands for the inferior alveolar nerve, which is going to pass into the mandible via mandibular foramen here. I hope it is very clear now. So in this manner, we have revised the mandibular nerve. Now welcome to facial nerve. Facial nerve na diagram itna bada lagta hai, sir. Diagram looks like a very big one here. Only 2 points to remember here. And all those 2 points already I told you. Seventh nerve, number 1, it will give rise to a branch known as greater petrosal nerve. And that is passing through which ganglion? Pterygopalatine ganglion. Supplying to which gland? Lacrimal gland. Did I tell you this point in GVE column? जनरल विसरल इफरेंट कॉलम ऑलरेडी मैंने आपको बताया, तो आपको ये एक पॉइंट याद रखनी है. नंबर 2, सेवेंथ नर्व विल आल्सो गिव कॉर्डा टिम्पैनी ब्रांच. हु डजंट नोज अबाउट दिस वन? इट विल गो एंड इन अ गैंग्लियन, दैट इज सबमैंडिबुलर गैंग्लियन में एंड हो जाता है, एंड देन इट विल बी कैरिंग द टेस्ट फ्रॉम एंटीरियर 2/3 ऑफ द टंग as well as the submandibular and the sublingual gland को supply करता है. Clear with this one here? So just concentrate on 2 points here. Number 1 will be the greater petrosal nerve. Another one will be the chorda tympani branch. That's all done. Remaining things you know that very well, sir. So at this last moment, just like 3-4 days before the exam, don't look at this diagram and like, what the hell now? How should I revise this and all? So that is why I have come here just at the last moment to help you out what to focus on just before the exam. Okay, now. So greater petrosal nerve here and the chorda tympani branch here, sir. Next one, sir. Yes, there was a question recently in the INA-SET exam also from here about the facial nerve palsy, UMN and LMN lesion of facial nerve. Now, first of all, what is going to happen in the lower motor neuron lesion and then upper motor neuron lesion? Okay. Now, my dear friends, remember, whenever there is a upper motor neuron lesion जब होता है ना facial nerve का, तो what is going to happen? Contralateral lower half of the face will be involved, sir. I'll just use the same color here. Upper motor neuron lesion जब होगा, तो it will lead to what? Contralateral lower half of the face will be paralyzed. Contralateral. Now, if there is a lower motor neuron lesion, what is going to happen? Both upper half and lower half, complete half of the face on the same side will be paralyzed. So wherever you have the nerve, the same side. I told you in the very beginning also of this session here, whenever you listen the nerve means ipsilateral only, it can't be contralateral. Clear with this one here? I repeat again, if the facial nerve is gone, complete half of the face will be gone. And if the upper motor neuron lesion, in this upper motor neuron lesion, what is going to happen? Only the lower half of the face, that too contralateral. Fine. ये तो आपको clear है. Now what is happening? We have learned this very clearly in our regular classes. Fine, well and good. Now what is happening is, now in the exam, they are giving with the clinical aspect over here. कैसे? यहाँ देखो. First I'll tell you about the upper motor neuron lesion. Now, एक बार दोबारा रिवाइज कर लीजिए सर. Please revise in your mind. If there is upper motor neuron lesion, what is going to happen? Yes, the contralateral side, lower half of the face is gone. If the lower half of the face, if these muscles are gone, then what is going to happen? Nasolabial fold will be gone. Okay, that is like okay type. Now, this is extremely important here. Dropping of the angle of the mouth. dropping of the angle of the mouth. Okay. Number two important point, the saliva will be dribbling from there, dropping of the angle of the mouth along with the dribbling of saliva. Then recently given in the INI set exam, my dear friend, in this year only, that is 2024, it was given. Accumulation of food in between the cheek and the gums. The food is getting accumulated. Of course, अगर यहाँ के muscles paralyze हो जाएंगे तो यहाँ पर food accumulate हो जाएगा, है ना? तो inability to blow the cheek as well as inability to show the teeth properly. ये simple points है. जो मैंने स्टार मार्क किया है वो बहुत इंपॉर्टेंट है, बहुत इंपॉर्टेंट है, ठीक है ना? तो अपर मोटा न्यूरॉन लेशन, कम ऑन, लेट अस कोरिलेट राइट नाउ सर, एवरीवन along with me. In the upper motor neuron lesion, what is going to happen? Contralateral lower half of the face is gone. If this contralateral lower half of the face is gone, then what is going to happen? Dropping of the angle of the mouth along with dribbling of saliva, and then the accumulation of food between the cheek and the gums there. Is it okay? Fine here. And then, my dear friends, if suppose lower motor neuron is gone, if lower motor neuron is gone, complete half of the face, along with this one, remember some other points also. Along with all those points that I told you here, you have to remember about the upper half of the face. I am able to form these horizontal wrinkles here on the face, on the forehead, that will be gone. So inability to raise the eyebrows with the absence of wrinkles on forehead. Inability to raise the eyebrows with the absence of wrinkles on the forehead. Inability to close the eyes, but when the patient is attempting to close the eyes, the eyeballs will roll upwards. That is known as Bell's phenomena. And if all these 7 points are present, it is known as your Bell's palsy here. Simple. The lower half of the face, upper motor neuron lesion, complete half of the face, the lower motor neuron lesion. I hope it is very clear now. ठीक है ना? तो ये वर्ड्स आपके एग्जाम्स में दिए जाएंगे, आपके क्वेश्चंस में दिए जाएंगे. प्लीज लर्न देम वेरी मच केयरफुली हियर. क्लियर? I hope it is very clear, sir. I hope in our revision session we are including everything here. Almost everything here, my dear friends, है ना? Now moving on. Now in this diagram, you are able to see the dural venous sinuses. Number one, this one here will be the superior sagittal sinus. Number two, this is inferior sagittal sinus connected by straight sinus. And from below here, you'll be able to find the occipital sinus. All sinuses are going to join at one place. That is nothing but the confluence of sinuses. Now from the confluence of sinuses, the blood will be going away from here via transverse sinus, and then it is going to take a turn. That is your sigmoid sinus. And I told you very clearly, sigmoid sinus is going to combine along with the inferior petrosal sinus, and together they are going to form internal jugular vein. Internal jugular vein. Now the MCQ number one-liner that you have to learn here is, yes, the internal jugular vein will be formed by dash and dash. So remember, internal jugular vein is formed by sigmoid sinus and inferior petrosal sinus. The sigmoid sinus and inferior petrosal sinus, together they are going to combine and form the internal jugular vein. Next one. Number two, the great cerebral vein you are able to see here, which is also known as the vein of Galen, and that is going to continue into which sinus? That is nothing but the straight sinus. So great cerebral vein or vein of Galen continues as straight sinus. Now remember, dural venous sinuses, they are actually present between the two layers of the dura mater, that is endosteal layer and the meningeal layer. So all the dural venous sinuses are present between two layers, endosteal layer and the meningeal layer. दो layers के बीच में होते हैं. But there are the dural venous sinuses which is not present between the two layers. It is present only and only in the meningeal layer. Only and only in the meningeal layer, sir. That is your inferior sagittal sinus and straight sinus. So this inferior sagittal sinus and straight sinus are present only in the meningeal layer. Only in the meningeal layer. That's all, sir. Done. Now apart from that, recently in one of the exams they have given this image. And in this image, there was an arrow mark over here. And you have to identify this sinus. Basically, this image we are seeing in which section here? We are seeing in the transverse section. Okay. So when you are taking a transverse section, oh my God, you will be able to see which sinus over here. That is a straight sinus. And which is going to connect the inferior sagittal sinus and the superior sagittal sinus. So in this diagram, somewhere here, you'll be able to find the inferior sagittal sinus, and here there will be superior sagittal sinus, and these two will be connected by which one? Straight sinus. So if they give you this diagram here and arrow mark there, identify the sinus, that is your straight sinus here. Next one. How can you forget the very famous one? That is your cavernous sinus. And in cavernous sinus, why I have given you this diagram here, I want to tell you about one of the latest update here. What is passing through the lateral wall of the cavernous sinus? This one here will be the third nerve, oculomotor nerve. This is the fourth nerve, trochlear nerve, and this one here will be the phi 1, ophthalmic nerve. And here there will be phi 2. But according to the latest edition of the Gray's Anatomy, remember phi 2 is not passing from the lateral wall. It's given very, very clearly. Maxillary nerve does not pass to the lateral wall of the cavernous sinus. Only third nerve, fourth nerve, and phi 1 is passing from here. Then what is passing inside the cavernous sinus? You can clearly see there is internal carotid artery here. Along with the internal carotid artery, there will be sixth nerve passing from here, sir. Which nerve? Abducens nerve is passing from there. Internal carotid artery along with the abducens nerve is passing inside the cavernous sinus. Clear with this one here? Next one, my dear friends. Now, the transverse section of neck, very much important here. In this, you have all the fascia, the deep cervical fascia, and there are four modifications of deep cervical fascia. Yes, the four modifications of deep cervical fascia. The outermost one that you are able to see here, which is surrounding the entire neck, is known as the investing layer here. And you can clearly see it is going to split and enclose sternocleidomastoid muscle, sternocleidomastoid muscle. And it is going to split and enclose the trapezius muscle here and trapezius muscle here, sir. Fine. So the layer that you are able to see on the outermost side of the neck there, outermost part of the neck there, that is investing layer, sir. And investing layer is splitting and enclosing these two muscles. So you have to remember the rule of two here. First of all, it is enclosing two muscles here, my dear friends. Number one, sternocleidomastoid muscle and trapezius muscle. It is enclosing two muscles. Sternocleidomastoid muscle and trapezius muscle. Number two, it is enclosing two glands here, the parotid gland here and the submandibular gland here. And below, then it will be enclosing like two spaces here, sir. The suprasternal space and the supraclavicular space. And then it is also enclosing like two ligaments here, the stylomandibular ligament and the sphenomandibular ligament. Stylomandibular and the sphenomandibular. And then it will be forming like two pulleys, the pulleys required for digastric muscle and the omohyoid muscle. So you have to remember the rule of two for the investing layer. Is it okay? Now, you all know very well that posterior triangle of neck kahan par hota hai, sir? For example, if I am turning like this here, this is sternocleidomastoid and trapezius. यहाँ पर इन दोनों के बीच में होता है posterior triangle. Sternocleidomastoid and trapezius, there will be posterior triangle. Now, if this is the sternocleidomastoid here and this is the trapezius here, of course, this should be the posterior triangle. You will agree with me? See, look at the way how you have to observe the things differently here. ये वाला posterior triangle of neck होगा ना? Now, if this is the posterior triangle of neck, of course, what is going to form the roof of this one here? Investing layer. If this is the posterior triangle of the neck here, then roof will be formed by investing layer here. Is it okay? And please remember this point which was asked in the PG exam. It can be repeated in the FMG exam, my dear friend. Parotid swellings. The parotid swellings are very much painful due to the unyielding nature of the capsule. Unyielding nature of the capsule surrounding the parotid swelling. Exact line it was given in Gray's Anatomy and they have given in the PG exam, sir. The parotid swellings are painful due to what? It is due to the investing layer, which is going to form the capsule surrounding the parotid gland. Capsule surrounding the parotid gland, sir. Done. Now, after that, what you have to remember about the prevertebral fascia? This fascia which is surrounding the vertebrae here, prevertebral fascia. Now, from here begins your brachial plexus, and the brachial plexus actually has to come out and enter into the upper limb, sir. Now, all those branches which has to enter into the upper limb over here, they're going to carry that prevertebral fascia into the axilla, and that extension of the prevertebral fascia into the axilla, that will be forming the axillary sheath. That is going to form what, sir? Axillary sheath. So this question was asked in your exam. Okay, axillary sheath is the continuation of which fascia? It is the continuation of prevertebral fascia. Axillary sheath is the continuation of prevertebral fascia. Okay? And yes, of course, you can clearly see in this diagram again. If this is the posterior triangle of the neck, then which is going to form the floor of this one here? The floor is formed by the prevertebral fascia. Prevertebral fascia. Easy to remember. Fine. Now, once you are done with the investing layer here and the prevertebral fascia here, now let us go ahead with the two more. One is your carotid sheath. Another one is the pretracheal fascia. Pretracheal fascia, you don't have to remember much here, my dear friends. It is just enclosing the thyroid gland. Pretracheal fascia is going to enclose the thyroid gland, but carotid sheath is very much important for your exams, even for the PG exam as well as FMG exams. Number one, in the carotid sheath, always they're asking the questions regarding the contents of the carotid sheath. So I've drawn a simple diagram here. By this you can remember what are the contents. Number one, common carotid artery. Number two, internal carotid artery, but not the external carotid artery. No, not the external carotid artery. Yes, along with that, the vagus nerve and internal jugular vein, sir. Fine. Now, we have been learning these contents of carotid sheath right from our first year MBBS days. We know that very well. Apart from that, in the PG exam, it was given ninth nerve. I have asked this to many students. They gave the feedback very clearly that 10th was not given sir, in the option, ninth was given in the option. Remember, even the ninth nerve is also a content of this one, as well as the 11th and 12th will also be the content of this one here, the false contents. Sir, how come they are the contents here? Please remember, ninth nerve will actually enter into the carotid sheath, but it is not going to pass throughout the carotid sheath. It is just going to exit out immediately. So it is not present in the entire carotid sheath here. It is only present in the upper part of that one, the cranial part of that one. So it is actually a false content. But yes, it is a content. Options में अगर दिया जाएगा, you have to mark yes, it is a content of that one. Please remember that one, sir. Okay, चलिए done. Now after completing this one, again the same thing. This image can be given as an image-based question, and you have to identify all the nerves present in this one here, sir. Now in this diagram, there will be the trachea here, and behind the trachea there will be esophagus here, sir. Now, what is the nerve present in the tracheo-esophageal groove here? That will be the recurrent laryngeal nerve. Next one, what is the nerve which is present inside the carotid sheath? Just now I told you it is the vagus nerve, sir. What is the nerve that will be able to find behind the carotid sheath? That will be sympathetic trunk. That is a posterior relation of the carotid sheath, sir. Then inside here you'll be able to find the scalenus anterior muscle and the scalenus medius and the scalenus posterior भी होता है. Now, if you are given an arrow mark right in front of the scalenus anterior, which nerve will be present here? That one will be the phrenic nerve. Please remember that right in front of the scalenus anterior, there will be phrenic nerve present here. Now, between the scalenus anterior and medius, you will be able to find the brachial plexus. The main thing, my dear friends, please remember the location. What is the location and which nerve you'll be able to find there? Fine. So if they are giving you the tracheoesophageal groove here, there you'll be able to find the recurrent laryngeal nerve, and then inside the carotid sheath, the vagus nerve, and then just behind the carotid sheath, there will be sympathetic trunk, and then in front of the scalenus anterior, there will be phrenic nerve, and then between the scalenus anterior and medius, there will be the brachial plexus. There will be the brachial plexus. Are you clear with this one here? Chaliye, the next one. Yes. In this diagram looks like very complicated, and I find this the easiest one. आपको बस ये करना है कि there are like 3 fascia, and in between the 3 fascia there are 2 spaces. That's all. There are like 3 fascia, there are like 2 spaces. Okay, now welcome here, my dear friends. Number 1, this green colored fascia present over here. This one will be the buccopharyngeal fascia. Buccopharyngeal fascia. Now this fascia, the yellow colored one surrounding the vertebrae here, will be the prevertebral fascia. That is a prevertebral fascia. In between these two, you'll be having one more fascia here, and this one here will be the alar fascia. That is the alar fascia. So yes, there will be buccopharyngeal fascia and buccopharyngeal fascia, then the alar fascia and the prevertebral. Now between the buccopharyngeal fascia and the alar fascia, this space here will be present behind the pharynx. So therefore, this space here will be the retropharyngeal space. This is retropharyngeal space here. And now the space present between the alar fascia and the prevertebral fascia, this space will be the dangerous space here. This is important, asked in your exam, sir. Now, why it is known as a dangerous space? Please observe that this space is not closed here, sir. It is going to continue down into the thorax. So if there is any infection in this one here, what is going to happen? That infection is actually going to continue down into the mediastinum. That is the reason why it is known as dangerous space. Just remember, there are like 3 fascia and 2 spaces. You should be able to identify the dangerous space. That was given as an image-based question in the exam, sir. Done? Now after that, yes, अगर मान लो यहाँ पर ना thyroid swelling होता है, the thyroid swelling is going to move with deglutition, with swallowing. So whenever you are going to swallow here, the thyroid swelling is going to move with deglutition. Why? Why? Because the answer is Berry ligament. Ligament of Berry. Why? Because Berry's ligament is the one which is going to connect the thyroid gland behind with the cricoid cartilage. Thyroid gland with the help of, to the cricoid cartilage behind. So therefore, with the swallowing, what is going to happen? The thyroid swelling is going to move. Answer should be, it is due to the ligament of Berry. Similarly, very old question asked in the PG exams. Yes, there is a one more cyst here. There is a thyroglossal cyst करके होता है. And thyroglossal cyst is going to move due to the protrusion of tongue. Due to swallowing, which is going to move? thyroid swelling is going to move due to ligament of Berry, and then the thyroglossal cyst is actually going to move due to the protrusion of tongue, sir. Please remember these two MCQs here. I hope we are covering like many one-liners in this session here, sir. Okay, चलिए आगे बढ़ते हैं. Next one. Yes, of course. Another important question, and we can actually expect one question from here, the great auricular nerve. Actually, in this diagram, you're able to see this is the posterior triangle of neck here, sir. Between the sternocleidomastoid and this one here is the trapezius, and below here there will be the clavicle here. Between the three of them, posterior triangle of the neck. And the roof of the posterior triangle of the neck, you'll be able to find the four cutaneous branches. Number one, lesser occipital nerve over here. And number two, the great auricular nerve here. Number three, transverse cervical nerve going transversely in the neck, transverse cervical. And then these nerves are going above the clavicle, supraclavicular nerve. Supraclavicular nerve, fine. So by this, we are able to identify all the all the nerves in the image here. All the nerves you are able to identify here, sir. Fine. Now in your exams, nowadays, this is the trending one, sir. Great auricular nerve. The first point that you have to remember is what is the root value of the great auricular nerve? It's going to originate from C2 and C3. Number two, there will be external jugular vein present over here. And external jugular vein के साथ में ये pass हो रही है. So it is going to run along with which vein? External jugular vein. Second point, remember. Then third point, remember, greater auricular nerve, it is going to supply to what, sir? It is going to supply to the skin over the angle of mandible here. Number one, the skin over the angle of mandible here. And number two, the parotid region and the lobule of the ear, lower one third. मैंने आपको अभी बताया था, important one. And then what is going to happen? There is a syndrome known as the Frey syndrome, sir. In Frey syndrome, what is going to happen? Number one, which nerve is going to get damaged here? The nerve that is getting damaged will be auriculotemporal nerve. But that auriculotemporal nerve, when it is going to regenerate, it is most commonly joining with which nerve? Most commonly it is going to join with great auricular nerve. That is the reason why what is going to happen in Frey syndrome. Whenever the person is eating something in this region, there will be redness as well as sweating taking place here, sir. So redness and sweating will occur over here. Yes, whenever the person is trying to eat. Why? Because auriculotemporal nerve most commonly goes and joins with great auricular nerve. Okay, now. And one more simple question here. After the parotid surgery, parotidectomy, suppose a person is shaving in one fine morning, he's shaving there. So he'll not able to sense anything. The loss of sensation in the shaving area, then what is the nerve that is gone? Again, answer is greater auricular nerve. The great auricular nerve. So all the points regarding the great auricular nerve, all the one-liners I have included over here, sir. So you should be able to answer everything regarding the great auricular nerve here. Next, moving on to the next concept right now. Now this can come as an image-based question here. In this diagram, my dear friends, you are able to see this is the hyoid bone here. And यहाँ से ये वाला जो muscle होता है ना, this is hyoglossus muscle. Hyoglossus muscle. And we have to learn what are the superficial relations of this one and what are the deep relations of this one. The superficial relations and deep relations of hyoglossus muscle. Okay. Now, number one, first I'll tell you the superficial relations here, sir. First of all, are you all able to see this nerve here? This nerve will be the lingual nerve, sir. Superficially present here, and this lingual nerve is present along with a ganglion here, and this ganglion will be submandibular ganglion. Number one. Number two, there is a muscle coming from the styloid process. This muscle here will be styloglossus muscle. That is also present where? Superficial to this muscle here, sir. Hyoglossus muscle. Number three, yes, you will be able to find the submandibular gland here. But you'll be telling like, sir, ये तो visible नहीं है यहाँ पर. Yes, actually it is cut here. There will be a gland here present, submandibular gland, और उसका आपको duct नजर आ रहा है. And that duct is going to take a turn around which nerve? Lingual nerve. इसलिए तो मैंने आपको अभी भी बताया था. Whenever you are trying to remove the submandibular gland duct, then which nerve is most commonly injured? Lingual nerve is most commonly injured there. And finally, what is this nerve which is going to come from below and supply to all the muscles of tongue? Hypoglossal nerve. That is your 12th nerve. इसीलिए तो उसका नाम हाइपोग्लॉसल रखा गया है, क्योंकि that nerve is actually coming from below and supplying to all the muscles of tongue. Now all these structures are present superficial to what, my dear friends? Yes, hyoglossus muscle. Superficial to hyoglossus muscles. Next one. So again the same thing here. This is how the clinical question will be given to you. A patient presented with jaw swelling and weight loss, suspecting a malignancy. The submandibular gland has been resected. submandibular gland has been resected. Which is most likely nerve to be damaged during submandibular gland resection? Most common nerve to be damaged will be lingual nerve. So based on this concept, my dear friend, this is how the questions will be asked in your exam. So I have given you this question so that you can understand how they will ask the question from here, sir. Okay, next one. Now, once you are done with the superficial relation, now let us see the deep relations of the hyoglossus muscle. Are you all able to find one ligament here? Stylohyoid ligament. From the styloid process, it is going to hyoid bone, stylohyoid ligament. And then there is a nerve here, and this nerve here will be actually the ninth nerve. Be very careful. Glossopharyngeal nerve. Ninth nerve is going to pass, yes, beneath or deep to the hyoglossus muscles. Okay. And finally, this artery and vein over here that you're able to see here, sir. This one here, this one will be your lingual artery and vein here, lingual vessels. Fine. The stylohyoid ligament, the ninth nerve, and the lingual vessels are going to see beneath the, yes, the hyoglossus muscle over here, sir. So by this, we are actually done with what here? The superficial relations and the deep relations of hyoglossus muscle here. Clear? Now, another hot favorite question which has been asked recently in the INI set exam also, as well as multiple times in the FMG exam. You are able to see that there is a diverticulum, and that diverticulum will be what, guys? Yes, Zenker's diverticulum. And Zenker's diverticulum is formed between which two muscles was the question in the MCI exam. First of all, I hope you all know that whenever you learn about the muscles of pharynx, they are divided into two categories here. One will be the longitudinal muscle, another one will be the circular muscle. In the circular muscle, there will be like three constrictor. And here, the muscle that I'm showing you on the screen here, this is inferior constrictor. Now, this inferior constrictor is in turn made up of two muscles here, sir. One from the oblique line of the thyroid cartilage going to the pharyngeal raphe behind. So this one here will be the thyropharyngeus muscle. And then from the cricoid cartilage, it is going to the pharyngeal raphe, cricopharyngeus muscles. So one is the thyropharyngeus muscle, another one is cricopharyngeus. Now between the thyropharyngeus and cricopharyngeus, there is a weak area, triangular weak area. That weak area is known as Killian's dehiscence. And from that Killian's dehiscence, you will be able to find a diverticulum coming out here, and that will be nothing but the Zenker's diverticulum that will be seen in the elderly people. Why? Because the age increases, what is going to happen? The wall of the pharynx will become very much weaker. So when they are coughing with very much high force, what is going to happen? The outward protrusion will be formed there. Fine. Fine here, my dear friends. चलिए अब हम बढ़ते हैं आगे. Once you are done with this one here, very much important for the PG exams, my dear friend here. Now in this diagram, are you all able to see superior constrictor here, and then the middle constrictor here, and the inferior constrictor? And now you have to remember what are the structures passing between them. Now first of all, above the superior constrictor, you will be able to find first of all the auditory tube here, eustachian tube, and then along with that levator veli palatini muscle, LVP muscle. And please remember these two arteries very much carefully, very much confusing, my dear friends. Number one, ascending palatine artery होता है. Number two, palatine branch of ascending pharyngeal artery. एक होता है ascending palatine artery. Number two will be palatine branch of ascending pharyngeal artery. All these structures are passing above the superior constrictor. Now, what are the structures between the superior constrictor and the middle constrictor? Now, between the superior and the middle constrictor, you are able to find here, there will be ninth cranial nerve, glossopharyngeal nerve, along with the stylopharyngeus muscle. Fine. And then, what are the structures found between the middle and inferior constrictor here? इसको पढ़ने का आसान तरीका है. I'll tell you one easy way to learn here. You can clearly see that there is a nerve which is going to pierce this membrane and go inside the larynx. It has to be internal laryngeal nerve. And you know very well, my dear friend, the nerve which is actually going down, then again taking a turn and coming back in the tracheo-esophageal groove here, that is recurrent laryngeal nerve. The one which is piercing this membrane will be internal laryngeal. The one which is coming back from here will be recurrent laryngeal nerve. Okay, once you have identified these two structures, now above you'll be actually having the superior laryngeal artery, and below you'll be having the inferior laryngeal artery. Understanding makes sense? So this is how you can actually easily remember all the structures over here. So you have to remember what are the structures passing between these constrictor muscles, recently asked in your exams. Fine. And yes, of course, my dear friends, by this we are actually done with the head and neck part over here, sir. And we have completed almost everything here, sir. Almost everything here in this revision session here. So whoever are actually confused with the like sir इसमें से आता नहीं कि नहीं है, are whoever are actually waiting for asking that question, okay, will everything come from here? Yes, of course, my dear friends, we have covered almost everything here. Is it okay? आगे बढ़ेंगे, shall we go ahead now? So by this we have actually completed the neuroanatomy and head and neck, and this is going to be like more than enough, sir. इसको अगर आप प्रॉपरली पढ़ोगे और प्रॉपरली आंसर कर पाओगे एग्जाम्स में ना, then yes, of course, my dear friends, you will be able to answer the questions from here. Is it okay? Thank you, Vipul Patel. Thank you. More than enough, sir. Thank you, Shubham. Thank you. Yes, of course, Zishan Ahmed. As I told you, the first segment was a longer one. Why? Because the neuroanatomy and head and neck is very much important. We have discussed that in detail. Now, the second segment we are going to discuss about the limbs. अब यहाँ से ना fast हो जाएगा. All the topics will be done very quickly from here. We are going to do the limbs here, upper limb and the lower limb part, and then we'll do the thorax abdomen part. Then at the end we'll be seeing the embryology part. Okay, Zishan Ahmed. We'll be seeing the embryology part also at the end, sir. Fine. ठीक है जी, फाइन. आई थिंक इट्स बीन ऑलमोस्ट लाइक 2 hours राइट नाउ, एक 2 घंटा हो गया होगा. I'll do one thing, sir. I'll just give you, just give me like couple of minutes of time, just 2 minutes of time, my dear friends. I'll just come back with some water so that we can continue ahead further. Fine. And remaining session will be done quickly. थोड़ा सा आप भी थोड़ा सा ना रिलैक्स हो जाओ, थोड़ा सा रिलैक्स हो जाओ. But don't leave here. Don't leave the session. It's going to be like worth enough revising. Okay. So I'll just join you back in couple of minutes now. I hope I'm visible and audible to everyone here. Just give me a thumbs up, my dear friends. Med student, just help me revise the neuroanatomy before starting neurology and medicine. Thank you, thank you. It is completely revised there. Thank you, Ramesh. Thank you, Inside Medical. Fabulous. Thank you all. Yes, Zishanima, thank you. So now let us do one thing, sir. After completing all those difficult topics like head and neck and neuroanatomy, now let us go ahead with the some easy topics in the middle. Okay, let us try to ease out this one here. And my dear friends, I promise you that the remaining topics will be completed just in a span of like 1.5 hours. एक डेढ़ घंटे में सब कुछ खत्म हो जाएगा. And by this, you will get a complete confidence that entire anatomy has been revised. So let us not do like half-hearted, revision. लेट अस डू लाइक फुल रिविजन, क्योंकि मेरा मानना ये है कि अगर आप सौंतेला व्यवहार करोगे तो सौंतेला परिणाम मिलेगा. सो हाफ हार्टेड अटेम्प्ट विल गिव यू हाफ हार्टेड रिजल्ट ओनली. तो लेट्स हैव कंप्लीट रिविजन हियर. अगले एक डेढ़ घंटे में आपको सब कुछ खत्म हो जाएगा, ठीक है ना. यस, थैंक यू शम्स, थैंक यू डॉक्टर माइग्रेन. Okay, now let's start with the upper limb topic here. Upper limb topic, no doubt about that. Definitely questions will come from here. Number one, you have to remember about the muscles of hand here. Muscles of hand, there are totally like 20 muscles in hand here, sir. Out of that, the group of muscles present below the thumb will be the thenar, and below the little finger will be the hypothenar. In thenar group of muscle, number one, you'll be having the abductor pollicis brevis. Number two, there will be flexor pollicis brevis. And number three, you'll be having the opponens pollicis. And then number four, you'll be having the adductor pollicis here, sir. Adductor pollicis. Okay, and then in hypothenar muscle, exactly the same. There will be abductor digiti minimi, and then there will be flexor digiti minimi, and then there will be opponens digiti minimi, exactly the same. And the fourth one will be a different one, that is palmaris brevis. Palmaris brevis one here, sir. Now we also know the nerve supply to all this. All the hypothenar muscle along with adductor pollicis will be supplied by ulnar nerve, and the remaining three thenar muscles, they will be taken care by the median nerve, sir. Fine, perfectly revised here. Now, once you are done with the thenar muscles and hypothenar muscles, in your exams, they're actually asking the attachment. So they will give you a diagram where they'll give you the bones of the hand, all the bones of the hand. You know very well, the carpal bone, metacarpal and the phalanges. I have given you a simple line diagram here. And there was recently an arrow mark at this point here, sir. Can you please tell me which muscle will be attached here? Of course, that is the first metacarpal, and that is a shaft of that one, sir. Shaft of the first metacarpal. Can you please tell me which muscle will be attached here? At the shaft, it will be the opponens pollicis that is attached here, sir. Opponens pollicis. And if the arrow mark is near the base of the first metacarpal, then remember it will be the abductor pollicis longus muscle. Please be very careful where is the arrow mark. If it is at the shaft, it is opponens pollicis. If it is at the base of the first metacarpal, that will be the abductor pollicis longus. Now, after completing the thenar and hypothenar, welcome to the most important one, lumbricals. In total, you'll be having like 4 lumbricals here, sir. This is the lumbrical number 1 and 2, which are going to originate from only and only one tendon of FDP. They are going to begin only from one tendon of FDP. That is why they are said to be unipinnate, the first and second lumbrical. The third and fourth lumbrical, they are going to originate from the 2 adjacent tendons here. So therefore, that is known as the bipinnate one, sir. Fine. And the lumbricals are all going to originate from this tendon here, then going to take a turn, go back and insert onto the dorsal digital extension. Dorsal digital expansion. Fine. So lumbricals are going to originate from where? They're going to originate from FDP tendon, and then they're going to insert where? Dorsal digital expansion. Then the nerve supply, the first and second lumbrical will be unipinnate supplied by median nerve. The third and fourth lumbrical will be bipinnate and they will be supplied by ulnar nerve here. And what is the action of lumbricals? Make your hand like L shape here, like this, L shape. Flexion at metacarpophalangeal joint and extension at interphalangeal joint. Flexion at metacarpophalangeal joint and extension at interphalangeal joint. That makes your hand like L shape, L for lumbrical, and you can easily remember the action here, sir. Next one, after the lumbricals here, now let us go ahead with the interossei. There'll be 4 palmar interossei and there'll be 4 dorsal interossei. How to identify? Name itself is telling you they're present between the bones. Interossei. Whatever is a unipinnate here, sir, the one which are unipinnate, you can clearly see here, they are palmar interossei. The one which are bipinnate here, that will be dorsal interossei. All the interossei will be supplied by ulnar nerve. Don't even think about that one. Interossei supplied by ulnar nerve. Now, Palmar interossei will be helping in bringing all the fingers closer. Closer, that is nothing but adduction. So palmar interossei will be helping in adduction of fingers. Pad. Whereas dorsal interossei will be helping in taking the fingers away. So therefore they are helping in abduction of the fingers. Dab. So palmar interossei will be helping in what, sir? Yes, adduction. Whereas dorsal interossei will be helping in what, guys? Abduction. Okay, that is the reason why if you give a card in between the two fingers, if the person is able to hold that, you can say that, yes, sir, the palmar interossei are perfect, ulnar nerve is perfect. So what is the test done here? That is a card test, and card test is done for which nerve? Of course, we are testing which nerve? Ulnar nerve. And similarly, if you're just going to keep the hand of the person here like this and then ask him to move the middle finger here. That means both the dorsal interossei are working very well. That means what's an Egawa test. And this Egawa test is also done for which nerve again? Again, it is done for the ulnar nerve. Egawa test is also done for which nerve, my dear friends? Ulnar nerve. Perfect. So by this, we are done with all the muscles of hand here, sir. Then in the nerve supply of the hand, we know that the palmar surface. On the palmar surface, it is very much easier, my dear friend. Why? Because the medial 1.5 digit is supplied by ulnar nerve. Lateral 3.5 digit is supplied by median nerve. Please be very much careful with the dorsal surface of the hand. In the dorsal surface, the medial 1.5 digit, again it is supplied by ulnar nerve only. But lateral 3.5, only distal phalanges. Only the distal phalanges. I mean to say the nail beds here. The thumb, index finger, middle finger and half of the ring finger. These nail beds are again taken care by median nerve only. And whereas the dorsum of the hand is supplied by the radial nerve. So whatever is not highlighted here, that is taken care by the radial nerves. Next one. Now, my dear friends, I am going to revise you the ulnar nerve and the median nerve and the radial nerve in detail. We are going to revise this one. Ulnar, median and the radial nerve, we are going to revise. And definitely, there will be a question from here in your exams. Definitely, there will be a question from here in your exams. Fine. Now, first of all, in this diagram, you're able to see here, this is your arm, and this one will be the forearm, and then your hand here. Sir. Arm, forearm, and the hand. Ulnar nerve is coming from the arm here. Is it supplying to any muscle in the arm? No, it is not supplying to any muscle in the arm. Then please remember this point very carefully here. Ulnar nerve is going to pass behind the medial epicondyle. Very much important. Repeated question in your exam. So what is the nerve passing behind the medial epicondyle? Ulnar nerve. Then it will enter the forearm. How it is going to enter? Between the two heads of flexor carpi ulnaris muscle. And between these two heads only you'll be able to find a tunnel, and that tunnel will be the cubital tunnel. Cubital tunnel here, sir. And sometimes ulnar nerve is going to get compressed there. It is leading to cubital tunnel syndrome. Don't get confused with the carpal tunnel syndrome. It is cubital tunnel syndrome. And remember, it is also supplying to one more muscle, that is FDP, flexor digitorum profundus muscle, but only half of that one, medial half of that muscle. And lateral half is taken care by the median nerve. Why? Because we know from our golden rule that all the muscles in the anterior compartment of the forearm will be supplied by ulnar nerve and median nerve. So basically it is supplying to how many muscles in the forearm here? It is supplying to 1.5 muscle. One complete muscle, FCU, flexor carpi ulnaris, and then flexor digitorum profundus, which has a medial half. Clear with this one here? Next one. After that, now let us move ahead from the forearm into the hand. अब यहाँ पर important landmark है flexor retinaculum. Will the ulnar nerve is going to pass superficial to flexor retinaculum or deep to that one? Please remember ulnar ऊपर. Ulnar ऊपर. It is going to pass superficial to flexor retinaculum. Then in the hand, it is dividing into two branches here. That is your deep branch and superficial branch. And already मैंने आपको बता रखा है, out of the 20 muscles in hand, almost 15 muscles, 15 muscles are supplied by ulnar nerve only. Superficial branch will be supplying to palmaris brevis muscle. Palmaris brevis muscle, hypothenar wala. And then it is also supplying to the skin of medial 1.5 digit here, sir. Skin of medial 1.5 digit here. Done. And once you are done with the superficial branch, remaining everything is taken care by the deep branch. So deep branch will be supplying to all the hypothenar muscles here. Then the third and fourth lumbrical here. And then it is going to take a turn and supply all the interossei, 4 palmar and 4 dorsal interossei here. Then it is going on the other side. Remember this carefully here. It is supplying to the muscle here, that is adductor pollicis. Okay. Are you getting my dear friends? So that is the reason why, because it is supplying to many muscles in the hand, therefore it is the dominant nerve in the hand. And all those muscles are required for playing fine musical instruments. Therefore, ulnar nerve is also known as the musician's nerve. Ulnar nerve, it is also known as the musician nerve. And yes, of course, what is the root value? Ulnar nerve is going to begin from where, sir? Ulnar nerve is going to begin from C7, C8 and T1. It is getting the root value of C7, C8 and T1. That is an exception one. You have to remember that. Fine. Now, after learning about the ulnar nerve, revising everything about the ulnar nerve very quickly here, sir. अगर मान लो कि if the ulnar nerve is injured here near the wrist, if the ulnar nerve is injured here, all that 15 muscles will be paralyzed. My hand is going to become like this here, and that is nothing but partial claw hand. So what is the nerve involved in partial claw hand? Ulnar nerve. अगर मान लो कि ulnar nerve and median nerve, both the nerves are gone, then even the remaining 5 muscles will also be gone. Complete claw hand. So what is the nerve involved in complete claw hand? Both ulnar nerve and median nerve. So in this manner, we have actually revised the entire ulnar nerve here. Done. Moving on to the next one, that is your median nerve. Again, the same diagram, I don't have to tell you again and again. This one here will be your arm, then the forearm, then the hand here. Again, the same thing. Will median nerve supply to any muscle in arm? No, it is not supplying to any muscle in arm. Now that median nerve from the arm will enter into the forearm. How? By passing between the two heads of pronator teres. By passing between the two heads of pronator teres. And sometimes what is going to happen, that median nerve is getting compressed there. And that is why it is known as pronator teres syndrome. So what is the nerve involved in pronator teres syndrome? That is your median nerve will be involved in that one. Done. Now this median nerve will give rise to a branch here, and this branch will be known as the interosseous nerve. Here you'll be having two bones here. So one is your radius and another one is ulna. And if the nerve is present between the two bones, it is known as interosseous nerve. And it is present in which compartment? Anterior interosseous nerve. It is a branch of which one? It's a branch of median nerve only. Now, one important point to remember here, all the muscles in the anterior compartment of the forearm are divided into two groups, superficial group of muscle and deep. Remember, the superficial flexors will be supplied by median nerve itself. Median nerve will be supplying, but the deep flexors will be supplied by AIN. Superficial group will be supplied by median nerve itself, but the deep flexors are supplied by AIN, anterior interosseous nerve. Next one. Median nerve is going to pass deep to flexor retinaculum. It is going to pass deep to flexor retinaculum. That means it is passing through carpal tunnel. So therefore, what is the nerve involved in carpal tunnel syndrome? Median nerve. Are you observing there? We are completing like many points here. Now, after entering into the hand, it will be supplying to just like 5 muscles here, sir. The three thenars, the three thenar muscle except the adductor pollicis, and then first and second lumbrical. Fine. Now, apart from that, yes, it is also giving one sensory branch, and that branch will be taking care of the skin of the lateral 3.5 digits here, sir. Lateral 3.5 digits here. But be very careful here, sir. If you want to learn a little bit in depth for your PG exams, this median nerve, before entering deep to the flexor retinaculum, before going deep to the flexor retinaculum, just proximal to that, it will be giving a branch, and that branch will be coming superficially. And this branch will be the palmar cutaneous branch. This branch here will be the palmar cutaneous branch. And from the name itself, you're able to understand it will be supplying to the lateral 3.5 skin of palm. Skin of the palm here, sir. And it is coming just before, it is given just before the flexor retinaculum, proximal to flexor retinaculum. Now, what is the importance of this one? Yes, the importance of this one is, if the median nerve is involved here in the carpal tunnel, if it is injured in the carpal tunnel syndrome, then what is going to happen? Palmar cutaneous branch will be actually spared there, sir. It will not be involved there. Okay, now? Now you know very well the clinical conditions here. Median nerve, number 1, it is involved in pronator teres syndrome. Number 2, it is involved in carpal tunnel syndrome. Number 3, median nerve is also involved in pointing index. If median nerve is gone, then what is going to happen? Ask the patient to make a fist. He will be able to fold these fingers very nicely, but this will be remaining like this only. So pointing index. Also, one more condition you have to remember is hand of benediction also. Hand of benediction, what is the nerve involved? Median nerve involved. And along with that, the last and final one and the very famous one, ape thumb deformity. In ape thumb deformity also, what is the nerve involved? That is median nerve that is involved, sir. Now after that, the last and final thing will be the radial nerve. A radial nerve is going to come from the axilla here. And after coming from the axilla, it is first of all going behind the shaft of humerus in the spiral groove, in the radial groove. Then it is coming towards the lateral side of the arm, and there, right in front of the lateral epicondyle, right in front of the lateral epicondyle, it will be dividing into superficial branch and deep branch. Now in the axilla itself, it is supplying to the long head and the medial head of triceps. In the spiral groove, it is supplying to lateral head and a remaining part of the medial head of triceps. Then on the lateral side of the arm, very much important, it is supplying to brachioradialis muscle and ECRL, extensor carpi radialis longus. Okay, and then it is dividing into superficial branch and deep branch. Superficial branch नाम से ही हमको समझ में आ रहा है जो superficial होगा और supply करेगा skin को. So it is supplying to the skin of dorsum of the hand. Okay, and deep branch is piercing one muscle here, and that muscle will be the supinator muscle. After piercing that supinator muscle, it is going behind, and behind it is itself is now known as the PIN, posterior interosseous nerve, and that posterior interosseous nerve will be supplying to the muscles present in the posterior compartment of forearm. All those will be your extensor muscles. Extensor muscles, fine. So in this manner, my dear friends, please remember about the radial nerve. So therefore, because it is supplying to ECRL, from the name itself, you are able to understand extensor carpi radialis longus. It is helping in extending the wrist. So if radial nerve is getting injured, all these extensors will be gone and there will be wrist drop. So wrist drop, what is the nerve involved? Radial nerve. Number two, Saturday night palsy. Okay, now after drinking on the Saturday nights, the person is keeping the hand on the chair like this and sitting. So therefore, in Saturday night palsy also radial nerve is involved. Number three, crutch palsy. Handicapped people are using like long crutches, giving the support in the axilla and they're walking. Which nerve will be compressed? Radial nerve is involved. So I'll just repeat these 3 points again, sir. Number one, one-liner. Number one, wrist drop. What is the nerve involved? Radial nerve. Saturday night palsy, radial nerve. Crutch palsy, radial nerve is involved. Okay. One beautiful question here is that suppose if there is a finger drop, only finger drop is taking place, sir, not the wrist drop. Wrist is perfect, fine. Only finger drop is occurring. So if this finger drop is taking place, it is because of which muscle? Extensor digitorum. Extensor digitorum is supplied by posterior interosseous nerve, PIN. So remember, if they are giving you finger drop but no wrist drop, I repeat again, finger drop but no wrist drop, then the answer should be PIN. So in this manner, my dear friends, we have revised all the points regarding ulnar nerve, median nerve and the radial nerve. Is it very clear? Okay, so definitely, my dear friends, I'm telling you pakka definite question. I'm not even telling you expected question. Definite question out of these 3 slides. Out of the 3 slides, please revise them carefully. 1 mark will be for sure. 1 to 2 marks will be asked from here, sir. Okay. Moving ahead with the next concept, you know very well, this is like brachial plexus. In brachial plexus, what is going to happen? C5 and C6 will combine together to form your upper trunk. C7 will continue here to form the middle trunk, and C8 and T1 will combine together to form the lower trunk. If there is an injury to upper trunk, if upper trunk is injured, it will lead to what? Erb's paralysis. If there is an injury to lower trunk, it will lead to Klumpke's paralysis. And if there is an injury to the long thoracic nerve, which is coming from C5, C6, C7, then it will lead to winging of scapula. Winging of scapula. Now let's see all the 3 conditions one by one. Now what is happening in Erb's paralysis? Number 1, in Erb's paralysis, there is an injury to which trunk? Upper trunk. If upper trunk is injured, then which is the root value involved? C5, C6. What are the nerves involved? Remember, 3 nerves will be involved there. Remember with the mnemonic as SAM. Suprascapular nerve, axillary nerve and musculocutaneous nerve. These 3 nerves will be mainly involved here. Now, what are the 2 clinical conditions they can give you in the exam? Number 1, this upper trunk can be damaged during birth injury. I hope you remember the case of shoulder dystocia. Shoulders are inside, head is going to come out, and therefore if there is an overstretch, upper trunk will be gone. Number 2, the person falling on shoulder, fall on shoulder. Again, what is going to happen? Upper trunk will be gone. If this upper trunk is gone in Erb's paralysis, what is the sign of Erb's paralysis? Yes, that is nothing but policeman tip hand or waiter's tip hand or porter's tip hand. What is happening in the policeman's tip hand? Number 1, the arm will be actually adducted and medially rotated. The arm is adducted and medially rotated. Number 1. Next is what is happening at the elbow. Elbow will be flexed or extended. It will be extended. Next is forearm. Is it supinated or pronated? It is pronated. And finally, the fingers will be flexed and that will give the appearance of a policeman's tip hand. Policeman tip hand. So all the one-liners of Earth's paralysis has been completed here, sir. Now moving ahead with the Klumpke's paralysis. In Klumpke's paralysis, there is an injury to which trunk? Lower trunk. If lower trunk is gone, then what is the root value involved? That is C8 and T1 will be involved. Which nerves will be involved here? Ulnar nerve and median nerve will be involved here. And how it is happening, sir? How it is injured here? What is a clinical case they can give you? Hyperabduction of the arm, moving the arm away, but it is hyperabduction. Like when the person is falling down from a tree, trying to catch something, hyperabduction of the arm. Yes, that will lead to injury of which trunk? Lower trunk of the brachial plexus. What is the sign here? The sign here will be the claw hand. And how to describe the claw hand? Come on, try to make the claw hand along with me. Metacarpophalangeal joint पर क्या होगा? Will it be flexed or extended? Extended. That too hyperextension at the metacarpophalangeal joint and then flexion at the interphalangeal joint. Hyperextension at metacarpophalangeal joint and then flexion at interphalangeal joint. This will give the appearance of a claw hand. Perfect. अब यार यहाँ पर क्या होता है? Along with the claw hand, there will be Horner syndrome. Horner syndrome तो आपको पता ही होगा. It will be ptosis, meiosis, and anhydrosis will occur. Fine. In exam, they'll ask you what is the reason for this one. Why? Why? Because even T1 is involved here. T1 is involved here. And thoracic nerves will also contribute to your sympathetic nervous system. Sympathetic nervous system is thoracolumbar outflow. So please remember that because of the involvement of T1, Horner syndrome will also occur. So the patient is going to come to you with the claw hand along with the Horner syndrome. It is nothing but your Klumpke's paralysis. In winging of scapula, what is the nerve getting injured? That is the long thoracic nerve will be involved. Long thoracic nerve is supplying to which muscle? Serratus anterior muscle. If that muscle is gone, you cannot keep the scapula intact with the thoracic wall. If the scapula cannot be present intact with the thoracic wall, that is why it is known as winging of scapula. And in this, please remember which border of the scapula is going to become prominent here. That is the medial border of the scapula becomes prominent here. This was given like 2 times as an image-based question in your FMG exam, sir. Please take care about that one. In FMG exam, 2 times this was given as an image-based question. Please take care about this one here. Done. Next, moving on to the next concept. Another very, very important one. Definitely it will be asked in your exam. Anatomical snuff box. Okay. On the lateral side, there will be 2 tendons here. One is abductor pollicis longus. Another one is extensor pollicis brevis. On the medial side here, there will be only 1 tendon. That is extensor pollicis longus. Done. Then what do you have in the roof of this one? In the roof, you'll be having the cephalic vein along with the superficial branch of the radial nerve. That's not that important, sir. Now, welcome to the floor of this one. In the floor, you will be able to find one of the carpal bone, that is scaphoid bone. The lower end of the radius here and the scaphoid and trapezium and the base of the first metacarpal. All this in sequence. I repeat again, lower end of the radius here, then the scaphoid, trapezium and base of the first metacarpal. And out of them, the scaphoid is very much important. Why? Because it is most commonly fractured. And they have given a clinical question in your FMG exam that a person falls on outstretched arm. A person falls on outstretched arm, then he comes to the clinic with a pain in the anatomical snuff box. Now, if there is a pain in the anatomical snuff box, then which bone is fractured there? Of course, it is scaphoid bone present in the floor of that one. Okay. And the last and final thing, the content, the only and only content of anatomical snuff box will be radial arteries. Radial artery is the only content of this one here. Definite question in your exam. Please take care about this one, sir. Next one, nerves related to humerus. They have asked multiple times about the ulnar nerve. Okay. Please remember that there are totally like 3 nerves related to humerus, sir. Number 1, axillary nerve. Axillary nerve is going to pass behind the surgical neck of the humerus. You can see here. Number 2, radial nerve. Radial nerve is going to pass in the radial groove or the spiral groove. You can see here. And ulnar nerve, मैंने आपको अभी पढ़ाया था. Just now I taught you that ulnar nerve is going to pass behind the medial epicondyle. Medial epicondyle. Okay. So there are 3 nerves related to humerus. Very, very important slides. You can expect a question from here. So tomorrow in the exam, if they give you a person comes to the clinic with the fracture of surgical neck of the humerus, which nerve will be gone? Axillary nerve. There is a fracture of shaft of the humerus. This was given, the same image was given last year FMG exam. Fracture of shaft of the humerus, then radial nerve will be involved. And if there is a fracture of the medial epicondyle, then ulnar nerve will be involved here. That is the importance of learning nerves related to humerus. Next one, carpal tunnel here. Now, my dear friends, in this diagram, first of all, this retinaculum here will be the flexor retinaculum. Now, you have to remember what are the structures passing superficial to that and deep to that one. I will tell you a simple trick. Follow here, sir. सबसे पहले मैंने आपको बताया था अल्नार ऊपर है ना. So ulnar nerve is the one which is going to pass superficial to flexor retinaculum. Along with that, there will be ulnar artery here, and this one here will be the palmaris longus tendon. Now these three structures are going to pass superficial to flexor retinaculum. Remember them. Now after that, if you are able to see this tendon here, this one will be the flexor carpi radialis tendon. And flexor carpi radialis tendon is going to pass through the flexor retinaculum. You can very clearly see in my diagram here, it is passing through the flexor retinaculum here. Okay, if you remember only these many structures here, if they give you anything else in the exam, everything else is passing deep to flexor retinaculum. And what do you mean by deep to flexor retinaculum? It is the one which is going to pass through the carpal tunnel. Carpal tunnel. Understanding, my dear friend? So just remember the three structures passing superficial here, the one structure which is going to pass through the through the flexor retinaculum, remaining everything will be passing deep to that one, and that is passing through the carpal tunnel. Clear with this one here? And by this, we have revised all the important topics in the upper limb, my dear friends. And there will be like definitely questions from the ulnar nerve, median nerve, and the radial nerve. And please remember about the anatomical snuff box also. Clear? So as I promised you, now the topics will be done like quickly here, sir. Welcome to the lower limb. Let's revise this one here. In lower limb, nowadays they are asking many questions from the minor nerves here, sir. First of all, you should be able to identify the minor nerves here. How to identify? Now in this diagram, you are able to see one muscle here. This muscle here will be the psoas major muscle. Fine. And this muscle here will be the rectangle shape, and this one is the quadratus lumborum muscle. I want you all to focus only on these two muscles only, sir. I repeat again, this one is the psoas major muscle here, and this one is the quadratus lumborum muscle. Fine. Now, are you all able to see that there is a nerve coming out between these two muscles? And the nerve which is going to come out between the two muscles will be iliohypogastric ilioinguinal nerve. Iliohypogastric ilioinguinal nerve, and the root value of this one is L1. It is coming out from L1. Then are you all able to see that there is a nerve piercing the psoas major? If it is piercing the psoas major, then it is genitofemoral nerve, and its root value will be L1 and L2. It is coming from L1 and L2. Then can you see that there is a nerve which is going to come from inner aspect of the ilium bone, that hip bone, ilium bone. It is coming from the inner part of that one, and that one is lateral cutaneous nerve of the thigh. And the root value already asked in the exam, L2 and L3. Sir. So these minor nerves, this is how you have to identify. It's very, very simple here. Now, once you have identified, please look at this diagram now. Now, my dear friends, this nerve is going to pierce. It is piercing the psoas major muscle. If it is piercing psoas major muscle, no doubt it is genitofemoral nerve here. नाम से ही पता चल रहा है कि इसके दो कंपोनेंट होते हैं, एक होता है femoral and दूसरा होता है genital component. Now this one here will be the femoral nerve of genitofemoral nerve. It is a femoral branch of genitofemoral nerve. And this one here will be the genital branch of genitofemoral nerve. And first you observe here, the femoral branch is going down here, and it is supplying to the skin over the femoral triangle. The femoral branch is supplying to what? It is supplying to femoral branch is supplying to the skin over the femoral triangle that you can describe as upper and medial aspect of thigh. Whereas genital branch agar aap isko follow karoge, it is going here, and it will be going and supplying to the cremasteric muscle here. Cremasteric muscle here, sir. That is the reason why these two nerves are involved in the cremasteric reflex here, sir. They're involved in cremasteric reflex. How come? In a reflex, you should have one afferent and you should have one efferent nerve. Hai na? So now if there is a stroke on the medial aspect of thigh, if someone scratches onto the medial aspect of thigh, from here the information will be carried by femoral branch. Acha, the femoral branch is acting like a afferent here for cremasteric reflex. Then what is going to happen? The efferent fibers are going via the genital branch and they are supplying to cremasteric muscle, and that cremasteric muscle will contract, and ipsilateral side, same side, the testicles will actually ascend up towards the inguinal canal, and that is known as cremasteric reflex. तो आपको याद रखना होगा कि what will be the afferent and what will be the efferent of cremasteric reflex. I have shown you crystal clearly in this diagram here, sir. Okay. Now, once you are done with this cremasteric reflex, this was asked in the FMG exam. Now, welcome to the PG exam. In the PG exam, they have asked the same thing here. यहाँ पर ना femoral artery vein nerve होता है sir. There will be femoral vein, femoral artery, femoral nerve. They'll be arranged in the form of van here. We know very well. Now suppose you have to do the femoral vein cannulation. When you have to do the cannulation, of course this skin has to be anesthetized. And what is the nerve supplying here? The femoral branch. So the same question asked in PG exam, but in a twisted manner. In femoral vein cannulation, which nerve has to be anesthetized? It is the femoral branch of genitofemoral nerve. Okay, now femoral branch of genitofemoral nerve, sir. That has to be anesthetized. Clear? Are you understanding my point here, sir? So in this manner, I'm covering all the MCQs possible here, sir, whether it is for your PG exam or for your FMG exams here. Done. Moving on to the next concept, which was last time asked in your FMG exam. Now, the moment you look at this nerve, the nerve is coming from the inner aspect of the ilium here. And this nerve here will be the lateral cutaneous nerve of thigh. From the name itself, we can understand it is supplying to the skin on the lateral aspect of thigh. Fine. Now, what is going to happen? This nerve is getting compressed. Three conditions. Condition number one. Number one, obesity. Condition number two, during pregnancy. And condition number three, wearing the tight clothing. So during obesity or during pregnancy and wearing the tight clothing, what is going to happen? This nerve is going to get compressed. Where? Near the inguinal ligament. यहाँ पर ये compress हो जाता है. If this nerve is compressed here, then the patient will come to you with numbness, tingling sensation or burning, pain, stabbing. I have given you every word possible there. With that sensation on the lateral side of thigh. और इसी condition को हम कहते हैं meralgia paresthetica. This condition itself is known as meralgia paresthetica. Okay, so recently in the FMG exam, they gave a clinical question. A pregnant female walks into the clinic with the complaints of pain on the lateral side of thigh. The condition is meralgia paresthetica. What is the nerve involved? Lateral cutaneous nerve of the thigh. And what is the root value of this one? It is L2 and L3. Every point covered here, sir. Next slide. Now, another important concept is welcome to gluteal region. In the gluteal region, first you should be able to identify all the muscles. Now, you have seen this diagram n number of times, you'll be easily able to identify this one right now. Sir. Now, all these muscles here will be actually covered by the largest muscle here, sir. That is the gluteus maximus. हमने उस gluteus maximus को निकाल दिया. We have removed that one. After removing, you'll be able to find the gluteus medius, and then there will be gluteus minimus here. And this muscle that is going to come out from the greater sciatic foramen, this is piriformis muscle. Then you'll be able to find the four more muscles over here. Number one, gemellus superior. And then below that, there will be obturator internus. Below that, there will be gemellus inferior. And below that, there will be quadratus femoris. There is a reason why I have written this on either side here. Why? Because gemellus superior and obturator internus, both of them will be supplied by nerve to obturator internus. Gemellus superior and obturator internus are supplied by nerve to obturator internus. Similarly, gemellus inferior and quadratus femoris, these two will be supplied by nerve to quadratus femoris. Easy? Are you understanding me? Why I have written like that here? So I repeat again, gemellus superior and obturator internus are supplied by nerve to obturator internus. And then gemellus inferior and quadratus femoris are supplied by nerve to quadratus femoris here. And all the four muscles are helping in what? Lateral rotation at the hip joint. चलो ये तो बड़ा आसान है, हो गया, it is done. Now welcome to the gluteus muscles. Gluteus maximus is supplied by gluteal nerve, but you have to focus on inferior gluteal nerve. Gluteus medius and minimus will be supplied by again gluteal nerve, but you have to focus on superior gluteal nerve. Okay. Now gluteus maximus is helping in what? Extension at the hip joint as well as external rotation. And medius and minimus are helping in abduction at the hip joint along with internal rotation. That is the reason why it is able to stabilize the pelvis while walking. It is able to stabilize the pelvis while walking. तो यहीं से सवाल आता है, अच्छा, if this nerve is gone, then what is going to happen? These two muscles will be paralyzed. If these two muscles are paralyzed, then the person will not be able to walk properly. He'll be lurching on one side and walking. That is nothing but lurching gait. And in lurching gait, what is the sign which is positive? Trendelenburg sign is positive. Trendelenburg sign is positive. Is it okay, my dear friends? Very clear about that one. Now, please remember very, very carefully here. In Trendelenburg sign, suppose if the pelvis is sagging on this side, the pelvis is dropping on this side, then contralateral side, gluteus medius and minimus will be involved. These two muscles are gone on the opposite side. Contralateral side, superior gluteal nerve is gone. So please remember with one reference here, any one reference, don't learn with multiple references and get confused here. If the hip is dropping on the left side, then the right side superior gluteal nerve will be injured. Confusion वहीं पर होता है exam में. Take care about that one. Okay, clear with this one here, sir? चलिए अब आगे बढ़ते हैं. Now greater sciatic foramen and lesser sciatic foramen. What are the structures passing from here? First of all, in this diagram, you are able to see that there will be greater sciatic foramen here. And what is this muscle which is going to come out from the greater sciatic foramen? अभी अभी मैंने आपको बताया था pyriformis muscle. Just now I told you it is pyriformis muscle. Fine. So therefore we have to learn what are the structures passing above the pyriformis. Above the pyriformis there will be superior gluteal nerve, artery and vein. That's all. It's easy to remember. So above the pyriformis there will be superior gluteal nerve, artery and vein. That's all. बड़ा आसान है. Above, superior. याद रखो. Remaining all the structures are going to pass below the pyriformis. So what is going to pass below the pyriformis? Inferior gluteal nerve, artery and vein, and the nerve to obturator internus and nerve to quadratus femoris. And then along with that, remember sciatic nerve. Sciatic nerve is also going to pass below the pyriformis. Now these structures are very much important nowadays for your FMG exams. Even pudendal nerve is going to pass from here along with internal pudendal artery and vein. And what is the importance of this one? Actually, what is going to happen? There is a spine here known as ischial spine. Ischial spine. And what is happening here? The pudendal nerve is going to take a turn. Along with that, internal pudendal artery as well as the internal pudendal vein is going to take a turn. Passing from greater sciatic foramen, and then they're going to take a turn around ischial spine, and they're going to pass through the lesser sciatic foramen. So pin structures are going to pass or take a turn around the ischial spine. और यहाँ से आपके एमसी एग्जाम में दो सवाल पूछे गए थे. What is the nerve which is going to take a turn around ischial spine? Pudendal nerve. ये ऑप्शन दिया गया था एग्जाम में, pudendal nerve वाला. Now, why this point is very much important? Because this is the site where we are going to block the pudendal nerve. The pudendal nerve block will occur at which place again? Ischial spine. Okay, so these 2 points are very much important here, sir. Clear? So by this, we are done with the topic of the structures passing through greater sciatic foramen and lesser sciatic foramen here. Now let us go ahead with the next one, that is attachment on the femur. What are the structures which are attached onto the femur here, sir? Okay. Now, my dear friends, yes, you people are answering right there. I'm really, really happy the way you are revising quickly with me. Now, what are the structures attached here? Number one thing, in this diagram, we are able to see here, this is the anterior superior iliac spine and this is anterior inferior iliac spine. Anterior superior iliac spine, anterior inferior iliac spine. Now, what is attached onto the anterior superior iliac spine? Number one, there will be a ligament from here that is known as inguinal ligament, and it will be going and attaching to pubic tubercle. Number two, यहीं से begin होता है, originate होता है sartorius muscle से. So there are two structures getting attached onto the ASIS, inguinal ligament and the sartorius. Inguinal ligament and sartorius. Anterior inferior iliac spine, what is attached here? Rectus femoris. What is the rectus femoris? Where did we come across this one? We learned about this one in the quadriceps femoris muscle. Quadriceps, they're like four heads. Vastus lateralis, vastus medialis, vastus intermedius, and then rectus femoris. The rectus femoris is going to originate from where? It is going to originate from anterior inferior iliac spine. Clear? Now, once you are done with this one, now welcome to the most important attachments, gluteus maximus, medius, and the minimus. And everything has been asked in like one exam, sir. I'll tell you how. First of all, in this diagram, you're able to see here, there is gluteal tuberosity. And what is the muscle that is getting attached onto the gluteal tuberosity here? That is gluteus maximus muscle will be attached. What is the muscle attached on the gluteal tuberosity? Gluteus maximus. Already asked in your exam. Then, sir, what about the medius and minimus? Medius and minimus, both of them will be attached onto the greater trochanter only. Both of them are attached on greater trochanter, but gluteus medius will be attached onto the greater trochanter posteriorly on the posterior aspect, whereas gluteus minimus will be attached onto the greater trochanter onto the anterior aspect. Anterior aspect here, sir. Okay, ना? Don't worry about what is written in the bracket there. It is the action written there. Actions मैंने आपको already पढ़ा रखे हैं, ठीक है ना? And now this was asked in your PG exam, sir. NEET PG as well as INS exam. Now welcome to MC exam. Yes, in the MC exam, this image was given and there was a arrow mark here. What is attached onto the lesser trochanter? That is iliacus and psoas major. Iliacus and psoas major will be attached at lesser trochanter. Very, very important topic here, sir. Completed in one slide. Now welcome to the next concept, that is a repeated question in your FMG exam. They have given in the last exam also, like the structures passing through the tarsal tunnel. In tarsal tunnel, actually you'll be having like three tendons here, sir. One will be the tibialis posterior. Another one will be the flexor digitorum and flexor hallucis longus. They are like three tendons passing from here. Along with these three tendons, which are coming from the posterior compartment, along with them, yes, there is a nerve here. Which nerve? Tibial nerve. And yes, I told many times in the lower limb topic when we learn in our regular classes that if this is your foot here, the tibial nerve will enter into the tarsal tunnel, dividing into medial plantar and lateral plantar nerve. And those two nerves will be supplying to all the muscles of foot, sir. That is your tibial nerve. And nowadays, the important one for your MC exam is this one, posterior tibial artery. Very much important for your exams. Posterior tibial artery here. Why? Because they are asking the question based on what? They are giving this diagram here. Now in this diagram, yes, the doctor is trying to measure the peripheral pulse, and he is measuring the pulse by which artery? That is nothing but the posterior tibial artery. Posterior tibial artery. Please remember that it is like a repeat question in your exam, sir. Now after this, my dear friend, some miscellaneous points that you have to remember is like, what about the spring ligament here, sir? इस diagram में आप clearly देख सकते हो. In this diagram you can very clearly see this is the heel bone calcaneum. Then in the front here, this is the navicular, and above you'll be having the talus. Now that spring ligament is between the calcaneum and the navicular. So what is the another name of this one? The another name of this one is calcaneo-navicular ligament. Present in the plantar region. Therefore, I can call it as plantar calcaneo-navicular ligament. Plantar calcaneo-navicular ligament. Done. Then one more thing which was asked in the PG exam is about the bifurcate ligament here. Bifurcate ligament is this one over here. So clear? So in this manner, my dear friends, we are done with all the ligaments present over there. Now in your MC exam, they're asking about the dermatomes here. Dermatome of the lower limb. It's very simple. Of course, the lower limb will be supplied by lumbosacral plexus. How to remember this one, sir? Number one, L1, L2 and L3 will be supplying up to the knee joint. First, you clarify this in your mind. Up to the knee joint will be L1, L2 and L3. Yes, up to the knee joint it will be L1, L2 and L3, sir. Okay. And after that, I told you the lower limb during development is going to rotate inwards. So that is why you follow on the inner aspects, sir. So L4 will be on which side here? That is towards the medial side. And L5, this will be the dermatome on the lateral side of the leg here. And after L5, it should continue into what? S1. S1 will be on the lateral side here. Understanding my point here? So in this manner, they will give you this image and arrow mark, and they'll ask you what is a dermatome there, sir. Dermatome पूछा जाएगा, so please remember about this one here. Okay. And yes, my dear friends, by this we are done with all the topics to be revised in the lower limb. Fine here. So by this we are done with the upper limb and the lower limb here. Done and done and done. Clear? Nikhil Kumar is writing there. All are watching now. Gonna pass with God grace and blessings of our loved one and our hard work. Of course, inshallah. Everyone should pass. I'm praying a lot for you people. So you do your hard work and perform well in the exam, and we all the faculties here are there to pray for you. Yes, all my blessings and all my prayers are there for you people. चलिए सर, अब हम आगे बढ़ते हैं. Now let us go towards the another easier part, that is the thorax and abdomen वाला part. In thorax, Yes, another definite question repeated from the last two exams in FMG. Please revise this before going to the exam, sir. I'm telling you again and again, don't think about anything else in your mind, sir. कि यार ये important है क्या, वो important है क्या, is this enough, what is the LMR, where is the PDF, ये सब मत सोचो आप. जो अभी हम यहाँ पर सेशन कर रहे हैं, whatever session we are doing here, discussing here, my dear friends, I want you all to please revise this video at least like 2 or 3 times before the exam. At least 2 or 3 times before the exam, sir. I want you all to revise this 2 or 3 times before the exam. Hardly it is a matter of another like 3 4 days, but 20 marks will be coming from here in your FMG exam, my dear friends. So please take care about that one. It's not a small thing. It's not about like 1 or 2 marks. It's like 20 marks almost coming from the anatomy part. So please revise this. So just put this on like like 2x mode जो आपका होता है ना 1.5x और 2x and फटाफट देख लो सर. ठीक है ना. चलिए सर आगे बढ़ते हैं. थैंक यू सैम्यूल. Yes. In the esophageal constriction, we know very well there are like totally 4 constriction in the esophagus. Number 1 at the very beginning of the esophagus, where it is at the junction of pharynx and the esophagus there. And number 2, where yes, it will be crossed by the arch of aorta. And number 3, where it is crossed by the left main bronchus. And number 4, of course, when it is crossing the diaphragm. Now, at the very beginning, you'll be surrounded by a muscle known as cricopharyngeus muscle. The esophagus will be surrounded by cricopharyngeus muscle, and that is at 15 centimeters from the incisors. 15 centimeters from the incisors. When it is crossed by arch of aorta, that will be at 23 centimeters from the incisors. And when it is crossed by the left main bronchus, the esophagus will be at 28 centimeters from the incisors. And finally, the diaphragm, that will be like 40 centimeters from the incisors. It is asked in your exam. Please take care about this one. Next one, sir. Now, I hope you all have learned about the subclavian artery in head and neck part. Subclavian artery is actually divided into 3 parts by a muscle known as scalenus anterior muscle. Before the muscle, you'll be having first part. Behind the muscle, there will be second part. And after the muscle, there will be the third part, sir. Before the muscle, first part. Behind the muscle, second part. After the muscle, there will be third part. Now, the first part of the subclavian artery will give rise to 3 branches, that is VIT, WIT branches. V for vertebral artery going up. We learned about in the circle of Willis, vertebral artery. And then I for internal thoracic artery. You can clearly see it's going down here. Internal thoracic artery. And T for thyrocervical trunk. Now, out of them, the internal thoracic artery is actually going down here, adjacent to the sternum. And finally, it is going in the 6th intercostal space, already asked in exam. There it is terminating by dividing into 2 terminal branches here. One is the superior epigastric artery, another one is musculophrenic artery. Superior epigastric artery and another one is musculophrenic artery. So in one of the exam, they have asked about what are the branches given by internal thoracic artery here. Number 1, it is giving the first 6 anterior intercostal arteries. It is giving the branches in between the ribs, anterior intercostal arteries. Then it is giving the mediastinal branches, and that is the main artery to thymus, important. Then, yes, it is also supplying to the mammary glands, perforating branches, which will be supplying to the mammary gland in females, predominantly important there. And then pericardiophonic artery will be there. From the name itself, we can understand that pericardium and the diaphragm, and then the 2 terminal branches, the superior epigastric artery and musculophrenic artery. So yes, of course, in your exams, once they have given about the branches of internal thoracic artery, all of them are the branches of internal thoracic artery except one करके, ठीक है ना? So please remember this one here. Okay, Shubham, the values that you are telling about the constriction of the esophagus, there, esophageal constriction, please follow these values because they are from the updated edition of 42nd edition of Grey's Anatomy. Latest edition of Grey's Anatomy. These are the values given. There is a slight change from the previous edition, that is 41st edition. So that is why I'm telling you this one. If you want any time, I can provide you with a screenshot from the Grey's Anatomy. Okay, I'll provide you the reference from there. Exactly these values are given there. Okay, चलिए अब हम आगे बढ़ते हैं. So let's go ahead now. Another important concept here is about the azygos system. Azygos system. Now in this diagram, you can clearly see upper half of the body blood is collected by superior vena cava. Okay, and in this diagram, you're also able to appreciate here, this is the azygos vein. My dear friends, what is the meaning of azygos? Azygos means what? Azygos means unpaired. It is only one single vein. And that is present towards which side? Towards the right side. towards the right side here, है ना? Azygos vein is actually unpaired vein present towards the right side here. Now, in this diagram, are you all able to see here on the left side, you'll be having the hemiazygos vein, and that is crossing and draining into azygos vein. And then accessory hemiazygos vein that is also crossing and draining into the azygos vein. I hope you're able to see there. Hemiazygos vein and accessory hemiazygos vein, both of them will drain into azygos. Then apart from that, the second, third, and the fourth posterior intercostal vein, the second, third, and the fourth posterior intercostal vein will combine together to form the right superior intercostal vein. And the right superior intercostal vein will also drain into the azygos vein. The right superior intercostal vein will also drain into azygos vein. So I repeat once more here, sir. Hemiazygos vein, number 1. Accessory hemiazygos vein, number 2. And right superior intercostal vein, number 3. All of them are draining into azygos. Except for which one? Except for the left superior intercostal vein. Extremely important, asked in your exams. Why? Because of course we don't have azygos vein on the left side. So therefore it is going and draining where? You can very clearly see in my diagram here. It drains into left brachiocephalic vein. Left superior intercostal vein will drain into left brachiocephalic vein. So this question was also asked in the PG exam, INSET exam. Also this question was asked in the FMG exam also. Like all of the veins are going to drain into azygos except one. तो एक्सेप्ट विच वन हियर? लेफ्ट सुपीरियर इंटरकॉस्टल वेन. कॉमन सेंस है यार, एजाइगस अनपेयर्ड है, उसका मतलब ही अनपेयर्ड है, वो राइट साइड में होता है, तो लेफ्ट साइड में तो एजाइगस होती ही नहीं है. क्लियर विद दिस वन हियर. नेक्स्ट वन, रूट ऑफ द लंग. In the root of the lung, we have to learn about the arrangement of the structures in the root of the lung. Now, in the root of the left lung, first of all, you're able to find here, there is a pulmonary artery here. Below the pulmonary artery, you'll be able to find the bronchus here. And then finally, below the bronchus here, you'll be able to appreciate the pulmonary vein. So therefore, all the structures are arranged above downwards in the form of artery, bronchus, and vein. And people love to remember this one with the mnemonic as Atal Bihari Vajpayee. Artery, bronchus, and veins. Now in the right lung, in the root of the right lung, what is going to happen? Here what will happen? The right primary bronchus will divide just before entering into the lung. So the right primary bronchus will be dividing into two just before entering into the lung, and it will be dividing in such a way that one of the bronchus is above the artery here, another bronchus will be present below the artery there. So therefore, my dear friends, please remember there, number 1, there will be arterial bronchus above the artery, and then you'll be having the pulmonary artery here, and then there will be hyparterial bronchus, below the bronchus, below the artery there, and then you'll be having again the pulmonary veins. That is arrangement of the structures above downwards in the root of the right lung. So in the left lung, it is very simple, sir. Artery, bronchus, and vein. In the right lung, be careful. It is going to divide just before entering into the lung. Okay. Then after that, anterior-posteriorly, it is very easy, sir. Why? Because it is the same in both the lungs. From anterior towards the posterior, when you are going there, first you'll be having vein, and then you'll be having the artery, and then there is a bronchus. Similarly, here also, first you'll be having vein, and then the artery, and then the bronchus. So therefore, anterior-posteriorly, please remember, it is vein, artery, and bronchus. That's all. So above downwards is different in right and left lungs, sir. You can clearly see there. But anterior-posteriorly, it is the same in both the lungs, right lung and left lung. Okay, you can remember as VAB. Now in the exam, if you want to answer like more quickly, because you'll be hardly having some time there and hardly a minute to solve the questions there. So above downwards, to easily yaad rahega artery, bronchus, and vein. Atal Bihari Vajpayee. Just make it reverse. ABV, and that is going to become like a VAB anterior-posteriorly. Simple. You'll be able to answer just in less than 1 minute. Is it okay, my dear friends? So remember like ABV and the VAB for the root of the lung cell. That's all. Done, done, and done. I hope it is clear. Now, once after completing the root of the lung, yes, mediastinal surface of the lung, they're asking you this diagram here. Of course, my dear friend, don't be happy that this diagram will be given in the exam. No. That will not be given in the exam with the structures. It will be given without the structure. This diagram will be given. You should be able to identify what is passing from here. Now if it is the mediastinal surface of the right lung, मैंने आपको अभी अभी बताया है कि azygous vein will be single present towards the right. So therefore this impression here is actually for the azygous vein. And the same azygous vein is going to ascend up, and here you'll be having the arch of azygous vein. Even that question has been asked. Above the root of the right lung, this is the root of the right lung. What do you have? Arch of azygos. And that azygos will finally go and drain into what? Azygos vein will drain into superior vena cava. And superior vena cava will finally drain the blood into, of course, the heart. Fine here. So this is how you'll be able to identify all the impressions over here. And no doubt about this one here, sir. This impression will be of esophagus. Esophagus, mostly they will not be asking in the exam. Why? Because esophagus is passing in the center. You will have the impression on both the lungs. And think like an examiner there. Examiner will never ask you about the impression present on both the lungs there. Esophagus, तो पता ही है सबको. So whatever is different, they will be asking in the exam. Please remember that one, sir. Similarly, my dear friends, welcome to the left side. And you all know our habit of drawing the arch of aorta always toward the left side. So therefore, in this diagram, you are able to see the impression of the heart here. And then there will be ascending aorta here, sir, which is going to ascend up. And then there will be arch of aorta here, impression of arch of aorta. And then there will be descending aorta here. Okay. And of course, again, you'll be having the impression for esophagus on both the lungs. Why? Because esophagus is exactly passing in the center. This is how you can easily remember this one here, sir. Okay. Next one, thoracic duct. 3 points to remember here. Already the question has been asked in the exam. Please remember. Thoracic duct, number one, it is going to form from where? It is going to begin from cisterna chyli. Cisterna chyli is actually present in the abdomen. तो वहाँ से thoracic duct begin होता है. So of course it has to cross the diaphragm. It is going to cross the diaphragm via which opening of the diaphragm? Remember the aortic opening. Aortic opening at the level of T12. Then it is deviating from the right towards the left. It is deviating towards the left at the level of T5. That is important. And finally the thoracic duct will go and drain, and where it is going to drain here, you can clearly see in the diagram there, at the junction of left subclavian vein and left internal jugular vein. Previous year question in FMGE. तो जैसे मैंने आपको कहा था, just remember like 3 points here. The thoracic duct is going through aortic opening of diaphragm at the level of T12, shifting from the right towards the left at the level of T5, and finally draining at the junction of internal jugular vein and the subclavian vein. Of course, the left one, left internal jugular vein and left subclavian veins. ठीक है ना? Now after this one, my dear friends, we are done with all the topics that you have to revise in the thorax wala part. And I'm not dealing with all that, the coronary artery, coronary circulation, the veins of the heart, the apex, base and everything. वो तो आपको already पता है, ठीक है ना? So in this revision session, I'm dealing with all those difficult things where you might be making a mistake. Like you should remember the values of the levels of thoracic duct here, like mediastinal surface here, as well as the root of the lung. So these are the topics where you tend to forget. Otherwise, blood supply of the heart, the apex of the heart, base of the heart, वो तो आप easily पढ़ सकते हो, आराम से फर्स्ट ईयर MBBS से पढ़ रहे हैं, है ना? तो that's the planning here, sir. Now the next one. After that, the next topic that we are going to learn is abdomen topics. वो MI में याद है आपको? Yes, very good. Now in abdomen topic, my dear friends, I have observed one thing in your exams. They are giving about this planes, and you have to remember the imaginary planes and that too at which level they are present. Number one, you are able to see here that there is a transpyloric plane here, sir. And transpyloric plane or Addison's plane will be present at the level of L1. Now, why the name is given like that? Why? Because it is passing through the pylorus part of the stomach, and there itself will be having the origin of superior mesenteric artery also at the level of L1 only. And then there itself you'll be able to find the hilum of the kidney. So you have to remember what are the structures present at the level of transpyloric plane, sir. Okay, now. Next, after that, subcostal plane will be at the level of L3 here, sir. Subcostal plane at the level of L3, touching the lowermost part of the costal margin here. Now this one here is the costal margin here, touching the lowermost part of the costal margin, that is subcostal plane, and that will be at the level of L3. Then this one is your ilium bone here. Everyone knows that. And this uppermost part of the ilium will be iliac crest here. And there is a plane touching the iliac crest, and that is supracristal plane. And supracristal plane will be at the level of, yes, L4. So supracristal plane will be at the level of what, guys? L4, already asked in your exams. Then here in the ilium bone, you'll be having tubercle and tubercle. So there will be a transtubercular plane or intertubercular plane, and that will be at the level of L5. So you have to remember all these planes very carefully. Now welcome to one question which is like confusing one for the students. Umbilicus. The moment you say umbilicus, I have seen like many students कुछ भी नहीं सर डायरेक्टली रट्टा मारते हैं कि T10 umbilicus T10 is actually the dermatome of umbilicus. स्टूडेंट्स आर जस्ट मगिंग अप अम्बलिकस आ गया T10 लगा दो भाई साहब रट्टा से नहीं होगा आजकल लाइक नाउ डेज इट्स नॉट गोइंग टू हेल्प यू विद जस्ट मगिंग अप यू शुड नो द कॉन्सेप्ट you should understand the question carefully. Recently, they have given the location of the umbilicus, and you can clearly see the location of umbilicus is between L3 and L4. So please be very careful in the exam. Are they asking you the location or the dermatome? Umbilicus दिख रहा आंसर मत लगाइए ठीक है ना. तो umbilicus T10 dermatome होता है. लोकेशन कहाँ पर होता है between L3 and L4 सर. Please keep that in mind here. ठीक है. Next one, apart from that, about the inguinal ligament, certain points to remember. Inguinal ligament, first to remember the another name of this one, it is also known as the Paupert's ligament. Inguinal ligament is also known as the Paupert's ligament. And inguinal ligament is actually the thickening of aponeurosis of which one? External oblique muscle only. And then midpoint of inguinal ligament and mid inguinal point, ये दोनों points में बहुत difference है. Midpoint of inguinal ligament, of course the inguinal ligament is between the ASIS and pubic tubercle. I mean to say it is between the ASIS and the pubic tubercle here. Fine. And that is the midpoint of the inguinal ligament. But what is mid-inguinal point? Yes, you have to actually put a line here between the ASIS and pubic symphysis. Not the tubercle this time, pubic symphysis. And that will be the mid-inguinal point. And what do you find at the mid-inguinal point? There will be the femoral artery. That was the question in FMG exam. Mid-inguinal point पर आपको क्या मिलेगा? You'll be getting the femoral artery there, sir. Perfect. And then the deep inguinal ring is present like 1.25 centimeter above which point? Above the mid-inguinal point here, sir. Above the mid-inguinal point. So all these are the points that you have to remember for for your exams, my dear friends. Okay. Yes, nice. Next one, sir. How can we forget revising this topic before going to the exam? That is inguinal canal. Every time in your exams, they'll be giving you a question about the inguinal hernia. My dear friends, listen very carefully right now. Last like another few minutes right now, so another 30-40 minutes, we'll finish off this session here. I want you all to listen very carefully here, sir. Now, inguinal canal exactly hota kahan par hai, sir? You all know very well, this is the anterior abdominal wall having all the 8 layers. In this 8 layers, please remember there is a layer known as transversalis fascia. Transversalis fascia, this is the one wherein you'll be having that deep inguinal ring. ये आपके एग्जाम्स में ऑलमोस्ट 2 से 3 बार पूछा गया है. Then there is a layer known as external oblique. External oblique muscle भी होता है और aponeurosis भी होता है. And in the external oblique aponeurosis, you'll be able to find a triangular opening here, and that opening will be known as the superficial inguinal ring. So you have to remember that superficial inguinal ring is present in which layer? Remember, it is present in the external oblique aponeurosis. Okay. So deep inguinal ring, I repeat again, deep inguinal ring is present in transversalis fascia. Superficial inguinal ring is present in what's the external oblique aponeurosis. Now in दोनों के दरमियान में आपको 2 layer नजर आएंगे. In between these two, you'll be able to find 2 layers. One is internal oblique here, another one will be the transversus abdominis. Both of them will join together and join together to form conjoint tendon. They are joining together here, they're going to form the conjoint tendon. So you can clearly see here, conjoint tendon will be formed by internal oblique plus transversus abdominis. First you try to recall these 3 points here, sir. इस diagram में आपको ये 3 one-liner पढ़ने होंगे. Number 1 one-liner, deep inguinal ring is present in which layer? Transversalis fascia. Superficial inguinal ring is present in which layer? External oblique. Conjoint tendon is made up of dash and dash, internal oblique plus transversus abdominis. Clear? Now once you are done with these 3 points, join the deep inguinal ring with the superficial inguinal ring. Join the deep inguinal ring with the superficial inguinal ring, and together they are going to form a canal, and that canal will be the inguinal canal. What is the canal? Inguinal canal. And now we have to learn what are the boundaries of inguinal canal. पहले आप आराम से ना ये डायग्राम देखिए यहाँ पर. अगर ये inguinal canal होगा, what do you have in front of the inguinal canal? External oblique and internal oblique. What do you have behind the inguinal canal? अगर ये inguinal canal होगा, conjoint tendon and transversalis fascia behind that one. What is passing above that one here? That is internal oblique and transversus abdominis. And then what do you have below the inguinal canal? You'll be having the inguinal ligament. So all these boundaries have been written here, which I explained you in a crystal clear manner in this diagram here, sir. Is it okay? So please remember, my dear friend, anterior wall will be formed by external oblique and internal oblique, whereas the posterior wall is formed by conjoint tendon and fascia transversalis. And then the roof will be actually formed by transversus abdominis and internal oblique. Both of them are going on the other side to form the conjoint tendon. And then the floor is formed by the inguinal ligament here. Perfectly done. Now, what are the content of inguinal canal in male and female? In males, you'll be having the spermatic cord along with the ilioinguinal nerve. And in the females, you'll be having the round ligament of uterus passing from here only along with the ilioinguinal nerve. So in the females, there will be round ligament of uterus along with ilioinguinal nerve. And in the males, there will be spermatic cord along with the ilioinguinal nerve. Perfect. So now we are done with the boundaries and contents of the inguinal canal. Completely done, sir. Now, what is spermatic cord? Spermatic cord is all about the structures which are going to connect with the testis, because the descent of testis aapne padha hoga, it will be descending from here only. Testis will be descending from here only. So therefore, all the structures which are going to connect with the testis. Number one, what is the artery which is going to connect with the testis? Testicular artery. What is a vein which is going to drain the blood from there? Pampiniform plexus of vein. And then what is the nerve supply? Genital branch of genitofemoral nerve. And then of course there is a duct passing from there, vas deferens, also known as ductus deferens. Okay, and yes, of course there will be artery to vas deferens also. And all these structures will be surrounded by these three fascia here: internal spermatic fascia, external spermatic fascia, and the cremasteric fascia in the middle. Clear with this one here? That is about the spermatic cord. Next one, inguinal hernia. Definite question in your MC exams. Inguinal hernia. Suppose if the herniation will occur via the deep inguinal ring, that hernia is referred to as the indirect inguinal hernia. So what do you mean by indirect inguinal hernia? Which will be taking place via the deep inguinal ring and coming out via superficial inguinal ring. If the herniation occurs via this triangle, which is known as the Hasselbalch's triangle here, and that is known as the direct inguinal hernia. Direct inguinal hernia. So indirect will be occurring via the deep inguinal ring. Direct will occur via Hasselbalch's triangle. Now, now my dear friends, please remember that what are the boundaries of Hasselbalch's triangle? Yes, welcome here. The base will be formed by inguinal ligament here. Inguinal ligament is going to form the base here. And on the medial side, there will be your favorite muscle, that is your rectus femoris muscle, okay, which is going to form that six packs. And on the lateral side, there will be inferior epigastric artery and vein. Inferior epigastric artery and vein. So that is your Hasselbalch's triangle, and from that Hasselbalch's triangle, direct inguinal hernia will occur. So we have completed all these points over here, sir. Next one. In kidney, mostly they're asking you the relations of the kidney. That is why I have kept this topic in the revision. Please revise the relations and go to the exam, sir. First of all, on the screen, you are able to see the posterior view, the back view of the kidney. Now on the posterior surface, it's very simple here. You can just put one horizontal line here like this and two vertical. Upper part will be actually related with diaphragm. Upper half of the kidney here will be related to diaphragm, and the lower half of the kidney is actually related with three muscles: psoas major, and then quadratus lumborum, and then the transversus abdominis. I repeat again: psoas major muscle, then quadratus lumborum muscle, and then transversus abdominis muscle. If you remember this, that is more than enough for your exams. Important one. Okay. Then what about the anterior relations of the kidney? Now, anterior surface relations are important. How to deal with this one, I'll tell you. In both the kidneys, upper part will be related with suprarenal gland, and the lower part is related with the colon and jejunum, sir. Okay, till here it is absolutely same for both the kidneys. The upper part is actually related with what? Suprarenal gland, and the lower part is related with what, sir? The colon and the jejunum part. Fine. Now the difference will come in the middle part. Now in the middle part, how to remember here? What do you have in front of the right kidney? In front of the right kidney, there is a duodenum taking a turn here. So this will be the duodenal area, and the remaining area will be covered by liver. So this will be the hepatic area. And in the left kidney, what do you have in the front here? Of course, there will be spleen here, splenic area. And then what is going all the way up to the spleen there? That will be the pancreas, and whatever area is left out here, that will be covered by stomach here. So there will be spleen and the pancreas and the stomach there. Clear with this one here? Now in this manner, we are done with the posterior surface as well as the anterior surface relations of the kidney. kidney topic is also completed here, sir. Now, welcome to another very, very important topic here, that is about the openings of diaphragm here, sir. And now, how many major openings of diaphragm are there, sir? 3 of them. Let us do it very quickly. Everyone knows about this one. And yes, you can expect one question from here, sir. So number 1, you'll be having the vena cava opening here. Number 2, there will be the esophageal opening here. And number 3, there will be aortic opening here, sir. Vena cava opening will be present at the level of T8. Esophageal opening will be present at the level of T10. And finally, aortic opening will be at the level of T12, sir. 8, 10, 12, very easy to remember. And I hope all of you remember that mnemonic very well. Voice of America. Vena cava T8, esophageal T10, and aortic opening will be at the level of T12. Now, what is going to pass through the vena cava opening? Of course, the vena cava. Inferior vena cava is going to pass from there. Forget about that one. They will never ask you this one. Yes, sir. Your focus should be on to the, yes, right phrenic nerve is going to pass from the vena cava opening. Then what is going to pass through esophageal opening? Of course, esophagus. Forget about that one. They will never ask you in the exam. Please remember, along with the esophagus, vagus will be passing from here. And then along with that, branches of left gastric artery. And then finally, along aortic opening से क्या पास होता है? Of course, aorta पास होता है, लेकिन examiner आपको कभी नहीं पूछेगा. Study smartly. Along with that aorta, there will be azygos vein and thoracic duct passing from here, sir. So you have to remember the 3 major openings, their levels, and what is passing from there. Yes, this is another important topic to be remembered here, sir. Okay. Now, next one, nowadays, what they're asking in the exam is about the peritoneum. In the peritoneum, they're asking about the epiploic foramen here. Now, in this diagram, you can clearly see here, my dear friends, there will be a lesser sac here. This one here will be the lesser sac here, sir. And this one here will be the greater sac here. And both of them are still connected with the help of a foramen here. That foramen is known as epiploic foramen. Okay, or the foramen of Winslow. Now, please remember one thing more carefully here. Many of the students are thinking that epiploic foramen yahan hota hai. This will be the epiploic foramen. Absolutely big blunder. No. Epiploic foramen is actually present behind here. That is epiploic foramen here. So if this is the epiploic foramen here, what do you have in the front of this one? This is lesser omentum, the free margin of lesser omentum. And what do you have behind the epiploic foramen here? Of course, यहाँ से inferior vena cava pass होता है. तो anterior posterior तो बड़ा आसान है ना? Now let us try to correlate here. Yes, what do you have anteriorly? I told you very clearly, there will be free margin of lesser omentum. Inside that, you'll be having that portal triad. What is the portal triad, sir? Hepatic artery, the bile duct, and the portal vein. Hepatic artery, bile duct, and the portal vein. In the free margin of the lesser omentum. And posteriorly, what do you have there? Posteriorly, you'll be having the inferior vena cava. चलो anterior posterior इस वाले diagram से आसान हो गया है. In this diagram, anterior posterior done, sir. Now, what about the superior inferior? Now, please look at this diagram here. Now, in this diagram, this one here will be the lesser omentum. And I told you, this is the free margin of lesser omentum. And where is the epiploic foramen? It is actually present behind the free margin of lesser omentum. Not on the side. Don't think that the epiploic foramen is present on the side here. No, no, no. It is actually present behind. कहाँ पर होता है? वो lesser omentum के free margin के पीछे होता है. Behind that one. Okay. If the epiploic foramen is present over here, what do you have above this one here, sir? You can very clearly see above you're having your liver. But which lobe of the liver that is important? It is caudate lobe of the liver. And what do you have below the epiploic foramen here? This is the first part of your duodenum here. So that is your first part of the duodenum present, sir. So all the boundaries of epiploic foramen made crystal clearly easy, sir. Understanding? So we are done with the anterior posterior boundaries in this diagram here, and then the superior inferior in this diagram here. Recently they have asked in the exam. Please remember this one, sir. Okay. That's all here about the abdomen topic. Now welcome to the pelvis and perineum topic, sir. Pelvis and perineum topic is actually a very simple, easy topic. Okay. But remember, don't leave this before going to the exam, my dear friends. Why? Because from here, they're asking the questions always about what nowadays? Extravasation of urine. Okay. So actually क्या होता है ना, I have observed some students that they will be concentrating more on neuroanatomy, head and neck, embryology and all. लेकिन ना छोटे छोटे टॉपिक छोड़ देते हैं. तो please remember that from small topics like one question will definitely come in the exams. Definitely come in the exam. Like pelvis and perineum, one question will come from here about the extravasation of urine. Joints topic, one question will definitely come from the type of joints. Okay. And epithelium and all, histology में epithelium है. And then cartilage, elastic cartilage, hyaline cartilage and all. From that histology, those two topics sir, वहां से एक क्वेश्चन पक्का आता है, तो please don't leave them. I repeat them again. Pelvis and perineum, one question from here about the extravasation of urine. Types of joint, one joint they will ask you. Okay, and epithelium, one epithelium or something they will ask you about, like you know, I think you have seen mostly about the urinary bladder, transitional epithelium and all, and then about the cartilage or sometimes they're asking about the cartilage. तो दे one question will come from here, तो please be like, oh, don't be overconfident about this topic. एक बार उसको रिवाइज करके जाना, ठीक है ना. So what I will do for these topics is, because in joints you just have to remember the examples of that one and all the examples, all the types of joints, and then epithelium you have to remember all the examples: squamous, cuboidal, columnar epithelium, and the cartilage, all the cartilages you have to remember the examples of them: hyaline cartilage, elastic cartilage and all. So all the examples I have kept in one PDF. Okay, and that PDF I will actually upload in the Telegram group. You can just view that and go to the exam, sir. Okay, now please go to the exam after seeing that one mark from there. And one mark is very much important, my dear friends. The importance of 1 mark asked to the student who gets 149. 1 mark is very much important. Okay, my dear friends. तो चलिए सर स्टार्ट करते हैं. एक्स्ट्रावेसेशन ऑफ यूरिन में ना आपको दो केसेस आते हैं सर. केस नंबर 1 इज riding a bicycle on the bumpy road. Riding a bicycle on the bumpy road. Okay, now when a person is riding the bicycle on the bumpy road, the urethra can be ruptured, and this injury is known as the straddle injury. And this straddle injury, this was given recently in the FMG exam. Or for example, a person falls in the manhole. If a person falls in the manhole, the pelvis will get fractured, pelvic fracture. And this question was given in the NEET PG exam. So therefore what I'm telling you is these topics are important for FMG as well as NEET PG, sir. ठीक है ना. So pelvic fracture and the straddle injury. Let's see how to identify this one. What is happening in this one? The first thing that you have to remember here is that in the pelvic fracture, when the person falls in the manhole, in the pelvic fracture, which urethra will be ruptured? Membranous urethra. और यार membranous urethra कहाँ पर होता है? It is the one which is passing through the deep perineal pouch. So therefore, the urine will be going out into the deep perineal pouch only. And अगर मान लो उसका superior wall rupture होता है, तो then the urine can also go into the space surrounding the urinary bladder, that is known as the space of Ridgius. Around the urinary bladder, the space of Ridgius. Okay, now I'm speaking about this space over here, sir. The space surrounding the urinary bladder and the prostate gland, that is space of Ridgius. तो urine वहाँ पर जा सकता है. That's all. So if membranous urethra is ruptured, the urine can be extravasating out into deep perineal pouch and space of Ridgius. Clear? आपको कौन सा वाला word find out करना होगा exam में? You have to find out this word in the exam. They will give you a clinical question, 4 to 5 lines. Yes, my dear friends, in the middle of that, in the NEET PG exam, it was given as pelvic is getting fractured. The membranous urethra is ruptured. And now welcome to the question which was given in FMG exam. Yes, straddle injury. A person riding a bicycle on the bumpy road. Yes, remember, bulbar urethra will be ruptured here. Bulbar urethra. And अगर bulbar urethra rupture होता है, my dear friend, please look at this diagram here. Yes, the urine will be going out into the, अगर bulbar urethra rupture होगा, the urine will go out into superficial perineal pouch. The urine is going into the scrotum. The urine will also go into the penile shaft. And then the urine will also go into the anterior abdominal wall also. Clear? So remember, the urine will be extravasating out into superficial perineal pouch, the scrotum, the penile shaft, the anterior abdominal wall, everywhere. So I told you everything in this one slide here. You'll be able to answer the question from here. 1 mark from this slide here, sir. 1 mark from this slide here. Okay. चलिए सर आगे बढ़ते हैं. Let us go ahead with the next one. Perineal body. What is perineal body? Now in this diagram you are able to see here between the vaginal opening and the anal opening, anal canal opening, you will be able to find a dense tough body that is known as the perineal body here. Okay, similarly in the males also you will be able to find the perineal body over here. Okay, clear? But what is the concept that you have to remember for your exam? Remember that there are totally 10 muscles which are going to meet at the perineal body. Out of these 10 muscles, 4 will be like paired muscles and there will be 2 unpaired muscles. And your examiner wants you to remember this one. The 4 paired muscle and 2 unpaired muscle. Now it's very, very easy. Number 1, this is the bulb of the penis here, sir. This one is the bulb of the penis here. And bulb of the penis is surrounded by bulbospongiosus muscle. And bulbospongiosus muscle is the first pair that we got here. First paired muscle. Number 2, transverse perineal muscle. Transverse perineal muscle. That too, this is superficial transverse perineal. STP. And beneath this, you will also have the DTP also, which is not visible in this diagram. So there will be deep transverse perineal muscle. We got the second and third pair. And this one here, which is sloping down, this muscle here will be the levator ani muscle. Clear? So there are like four paired muscle. Number one, there will be bulbospongiosus. Number two, there will be levator ani. Number three, STP and DTP. We got the paired muscle. And then you'll be having two unpaired muscle also. Surrounding this anal sphincter here, external anal sphincter muscle. And that is also attaching at the perineal body. Now, sphincter, will it be like paired or unpaired, sir? Unpaired hota hai sphincter. Hai na? So, external anal sphincter is also getting, yes, attached at the perineal body. That muscle is unpaired. And then one more and last and final muscle, which I can't show you in this diagram here, sir. That is actually the longitudinal muscles of the anal canal. So inside will be having anal canal, it will be having the longitudinal muscle. They are also going to join at the perineal body. So in the perineal body, remember, कुल मिलाकर कितने muscle यहाँ पर जुड़ते हैं? 10 muscles will be joining at the perineal body. Out of that 10 muscle, there will be like 4 paired muscle, and then there will be 4 unpaired muscles. There will be 4 paired muscle and there will be 4 paired muscle and there will be 2 unpaired muscle. Clear with this one here? Thank you everyone. चलिए सर आगे बढ़ेंगे. Next, after this one, ischiorectal fossa, hot favorite in the PG exams. Okay, now in this diagram you are able to find this one here will be the ischiorectal fossa. Now what is forming the boundaries? First of all, on the lateral side you're able to see this muscle here, that is the obturator internus muscle on the lateral side. Done. Then on the medial side you'll be able to find the levator ani muscle and external anal sphincter muscle. Yes, on the medial side you'll be able to find the levator ani and external anal sphincter muscle. Done. Lateral ho gaya, medial ho gaya. In this diagram we are done with the lateral and medial because this is like coronal section here. Now, apart from that, we have to learn about the anterior and posterior wall. The anterior wall is actually formed by the perineal membrane here, and the posterior wall will be formed by a ligament here. That is a ligament between the sacrum and the ischial tuberosity, sacrotuberous ligament, along with gluteus maximus. Sacrotuberous ligament along with the gluteus maximus. Now, what is the content of the ischiorectal fossa here? Yes, you are able to see it is filled with fat here. But along with the fat, are you all able to appreciate here? There is a canal, and this canal will be known as the pudendal canal. Inside the pudendal canal, you'll be having the pudendal nerve along with the internal pudendal artery and vein, sir. Internal pudendal artery and vein. Clear with this one here? Next one. Now, once you are done with this one, yes, the last and final thing that you have to learn here in the pelvis and perineum topic here, sir, that is about the internal iliac artery here. Internal iliac artery is actually dividing into two division here. That is your anterior division and the posterior division, sir. Now this one here is the internal iliac artery here, and that is dividing into two division here. One is anterior division, another one will be the posterior division. Anterior division and posterior division. Please just remember the branches given by the posterior division. Now what are the branches given by posterior division? Only there are 3 of them, and that you have to remember as SIL branches. S stands for the superior gluteal artery, I for iliolumbar artery, and L stands for the lateral sacral artery. S for superior gluteal artery, I for iliolumbar artery, and L for lateral sacral artery. SIL branches will be the branches given by which division? Posterior division. Remaining all will be the branches given by anterior division. We can learn them after your exam. Why I'm telling you like that is, why? Because just 3 days left for the exam. Always in the exam, they'll be asking you the same question. All of the following are the branches given from the posterior division except one. So my dear friends, if I am at your place preparing for the exam, I will never go for all these branches at this moment at least. Please remember the 3 branches here. Anything else given in the option, you can eliminate that one. Are you understanding seriously here? So please remember SIL branches here. Dr. Faisal is writing as Shubman Gill. Whatever yaar you want to remember. Remember, remembering is important here. 3 दिन की बात है, बस याद रखो. उसके बाद में मतलब जो करना हो करो लाइफ में, ठीक है ना. जस्ट इमेजिन द सिनेरियो आफ्टर 3 days विल बी लाइक टोटली फ्री नाउ, है ना. फुल प्लानिंग. चलिए आगे बढ़ते हैं सर. Now welcome to our last and final segment here. So that is the embryology wala part. Embryology wala part here, sir. Okay, no? Now in embryology wala part, recently in the exam they have given this diagram here, sir. I want everyone to be like 200% alert here, sir. Last few minutes left out, another like 15-20 minutes, we'll finish off this one, sir. I want you to be like fully alert. Now we are going to do the embryology part. I'll tell you the very high yield topics in this one. Number one, recently in the exam, they have given this one here. This is the transverse section of the embryo. Now, in the transverse section of the embryo, this one here will be the ectoderm here. This here will be the endoderm here, sir. And in the middle, this one here will be the mesoderm. Okay. Now, in the mesoderm, this one here will be the paraaxial mesoderm. This one here will be the intermediate mesoderm. And this here will be the lateral plate mesoderm here. Fine. Now, out of these three, remember, intermediate mesoderm is the one which is helping us in the formation of urogenital system. It is the one which is going to form your urogenital system here, sir. First, you learn that one. Now, now welcome to the paraxial. Paraxial mesoderm is the one which is actually going to form somites. ये क्या form करता है? Spherical ball-like structures known as somites. Now, those somites are the one which will be again having three parts in that one, sir. Dermatome, sclerotome, and myotome. Dermatome, and then there will be sclerotome, and then there will be myotome. Myotome. Dermatome, from the name itself, you will be able to understand. It is going to form the dermis. Okay. Sclerotome, it is going to form the axial skeleton wala part. Okay, now that vertebrae and all. And then myotome, it is going to form the muscle. But which muscle? Remember, only the skeletal muscle. And whatever you are learning here, leaving this, whatever is left out, you actually dump it in the lateral plate mesoderm. So it is forming from where? From the lateral plate mesoderm. Okay. Like for example, I told you myotome is going to form the muscles. Which muscle? Skeletal muscle. So smooth muscle and cardiac muscles will be derived from lateral plate mesoderm. Okay. Sclerotome is going to form axial skeleton. So therefore, appendicular skeleton will be derived from lateral plate mesoderm here. Understanding? And then the dermatome is the one which is going to form the dermis of the back of the body, and therefore the dermis of front of the body will be formed from the lateral plate mesoderm. So please remember like this, in this manner, it will be becoming easier for you. Now, apart from that, what are the other structures in this diagram here? Number one, you're able to find here, this is the notochord, sir. If this is the notochord, you know very well, it is going to induce and help in the formation of neural tube here. This is neural tube. And just adjacent to the neural tube, there will be cells here, and those cells will be the neural crest cells. Now, you have to remember what are the derivatives from all the three of them. They are repeatedly asking in your exams here. Is it okay? So now, my dear friends, welcome here. First of all, notochord. Notochord is actually helping you in the formation of what? Neural tube here. Now, neural tube is the one which is going to form your central nervous system, that is brain and the spinal cord, along with supporting cells also, all the glial cells like oligodendrocytes, microglial cells, all the glial cells are also formed here. आपका focus होना चाहिए यहाँ पर retina पर, ये आपको exam में याद नहीं आएगा. Remember, the retinal pigment, the retina is also formed from where? The neural tube only, from the neural tube only. Fine. And in the glial cells, remember, all the supporting cells are formed from neural tube only, except for what? The Schwann cells. That is why that is repeatedly asked in your exam. Schwann cells will be derived from where? The neural crest cells. Okay. Now the neural crest cells are going to form all your peripheral nervous system. So they're going to form all the ganglions in your body, as well as Schwann cells. Remember the parafollicular cells or C cells present in the thyroid gland, and then melanocytes, and then adrenal medulla. Adrenal gland will have two parts. The outer part is cortex, inner part will be the medulla. So adrenal medulla, along with that conotruncal septum. Conotruncal septum is made up of two septums, sir. One will be the spiral septum. Conotruncal septum is made up of two septums here. One is the spiral septum, another one will be the bulbar septum, which we have actually learned in the development of the heart. So spiral and bulbar septum, conotruncal septum is derived from neural crest cells. Along with that, skull bones and as well as the dermis of head and neck will be derived from the neural crest cells. All these derivatives, it's like a nonsense list. Why? Because neural crest cells, after the formation, they are going to migrate to many places and going to form all these structures. So you have to remember that one. Now मैंने आपको क्या कहा था? Notochord is the one which is helping in formation of this neural tube here. After formation, what should be the fate of notochord? Notochord will be gone, but there are remnant of notochord. Number one, nucleus pulposus. Where do you find this nucleus pulposus? Intervertebral disc में center में होता है nucleus pulposus, along with the apical ligament of dens and along with the membrana tectoria. Membrana tectoria. Clear with this one here? So all these things are done in this diagram here. First thing is completed. Welcome to second thing, and very much important for your FMG exam, development of diaphragm. Diaphragm will be formed from four structures, my dear friend. Number one, it is formed from septum transversum. It is the one which is going to form the central tendon. Number two, there will be cervical somites. The cervical somites are going to contribute to the muscle part of the diaphragm. It is going to form the muscles. And यहाँ पर esophagus होता है, and there is a peritoneum coming and then going back here, sir. So there will be a double layer of peritoneum here. And that double layer of peritoneum is known as mesentery, present behind dorsal mesoesophagus. Dorsal mesoesophagus. And then, agar yahan par diaphragm hoga, above you'll be having the pleura and below you'll be having peritoneum, pleuroperitoneal membrane. Pleuroperitoneal membrane on either side. So please remember this diagram also. This was given as an image-based question. Okay, so diaphragm will be derived from how many structures? Like 4 structures. Now, for example, if the pleuroperitoneal membrane is absent, then what is going to happen? Abdominal structures are going to herniate into the thorax. So therefore, the abdominal structures will actually herniate into the thorax, compressing the lungs, lung hypoplasia and all. And this condition is known as congenital diaphragmatic hernia. The most common one, that is your Bogdalak hernia. But you have to remember what is the reason for this one? The absence of which membrane? Pleuroperitoneal membrane. Please remember, congenital diaphragmatic hernia will occur due to absence of which membrane? Pleuroperitoneal membrane. And in your exam, they have given exactly the same image also. Please take care about the image-based question also. Okay, next one now. Definitely one question from this topic here. You can definitely expect like one question from this topic here, sir. Development of the neural tube. Now, neural tube, this is the diagram here. Already I told you it is going to form central nervous system. So this is going to become your brain and below this is going to become the spinal cord. Fine. But you are able to see one opening here and this one will be the anterior or cranial or rostral neuropore. That word was used in your exam. Anterior or cranial or rostral neuropore. And then you're able to see one more opening here, that is the posterior or caudal neuropore. In normal people like you and me, what should happen? They should be closed. So remember, anterior neuropore will be closed on 25th day, whereas the posterior neuropore will be closed on 28th days. 27th or 28th day, but the better option will be 28th day. अगर मान लो कि anterior neuropore close नहीं होता है, if it is not getting closed here, it will lead to a condition known as anencephaly. अगर मान लो कि posterior neuropore close नहीं होता है, it will lead to a condition known as spina bifida. Spina bifida. And now recently in your MC exam, this image was actually given, sir, where you have anencephaly, and along with the anencephaly, what is going to happen? There will be bony defect of the spine. The spine will also not fuse. There is a defect of the spine there. And that bony defect of the spine, this condition is known as rachis. This condition is known as what, sir? Cranial rachis. So you have anencephaly along with the bony defect of the spine, cranial rachis. Yes, so very good, my dear friends. By this, we have revised all the points in the development of the nervous system. CNS embryology is done here. And now welcome to the head and neck embryology. Now in head and neck embryology, yes, you know very well about the development of cleft and the pouches and the arches inside cell. Ectoderm is going to invaginate inside, and that invagination is known as the ectodermal cleft. So clefts are formed by what's the ectoderm here. And endoderm will be invaginating out here, and that is nothing but your pouches, endodermal pouches. In total, how many clefts do you have? 4. In total, how many pouches do you have, sir? There'll be like 4 pouches here. Now let us see the development of all the structures from here. Okay. The first ectodermal cleft, it is going to form the external acoustic meatus. The first ectodermal cleft is going to form external acoustic meatus along with the outer layer of tympanic membrane. Whereas the second and the third and the fourth cleft, these 3 clefts are completely obliterated. They are completely closed. So nothing will be derived from there. Thank God we don't have to learn anything from there, sir. Is it okay? So ectodermal cleft, only first one you have to remember. Done. Now what about the pouches inside? Now the first pouch, because it is coming and joining with the external ear, therefore it has to form what? Middle ear. Along with the middle ear, it is also going to form eustachian tube. Along with that, it is also going to form the inner layer of tympanic membrane. Sir. The second pouch is the one which is going to form palatine tonsil, but only the epithelium of the palatine tonsil. Now the most important one, repeatedly asked in your exams, is third pouch. Third pouch is going to form thymus. Remember with the rhyming word, third pouch is going to form thymus along with the inferior parathyroid gland. क्योंकि यहाँ पर thymus form होने के बाद वो migrate होता है. So because it's going to migrate down, it is going to form inferior parathyroid gland. And the fourth pouch is the one that is going to form superior parathyroid gland. Please be careful about that. Don't get confused in the exam. Clear? Now, once you are done with the ectodermal cleft and endodermal pouches, in one diagram, all the derivatives are done here, sir. Now, let us see the clinical conditions here. नाउ यहाँ पर ना एक स्पेस फॉर्म होता है और स्पेस को हम कहते हैं सर्वाइकल साइनस. Cervical sinus. There is a space formed here. Now, normally in healthy people like you and me, the cervical sinus has to be completely closed. It is closed here. But if it persists, अगर ये रह जाएगा, if the cervical sinus persists, that is known as what, guys? It is known as branchial cyst. Please be careful with the spelling. Branchial cyst, or else if it communicates, then it is branchial fistula. It's not bronchial, branchial. The branchial cyst or branchial fistula is nothing but the persistence of cervical sinus. I hope आपने सर्जरी में पढ़ा होगा. The branchial cyst यहाँ पर जो फॉर्म होता है, so that is the persistence of cervical sinus. And similarly, the one which is asked in your exams is about the DiGeorge syndrome, sir. Now, DiGeorge syndrome, I think आपने pediatrics में पढ़ा होगा in detail. That is like 22q11 mutation and all those things. But here, what is the anatomical importance here is which pouch is involved here, sir. So please remember, third pouch and fourth pouch will be involved, guys. So in DiGeorge syndrome, what is going to happen? Third and fourth pouch will be involved. अगर आपको इन दोनों में से कोई better option चाहिए, तो better option will be the third pouch, sir. Third pouch is more better option when compared to the fourth pouch. I hope it is very clear. Now, agar third pouch is gone, so what is going to happen in DiGeorge syndrome? Of course, thymus is not going to form here. If thymus is not forming there, that is nothing but thymic hypoplasia. And then parathyroid gland is also not formed there. And parathyroid gland is required for maintaining the calcium levels in our body. It will lead to hypocalcemia also. Clear? Now more than this one, my dear friends, in your exams nowadays, what is important is about the cleft lip and all. That is the development of the face. Yes, most commonly they're asking in your exams here. It's very, very simple. First, what you do is look at a diagram which is given below here, sir. Now, in this diagram which is given below here, in this diagram, first you are able to find this process here known as mandibular process and mandibular process. And both the mandibular process will fuse together to form the lower lip here. तो अगर मान लो ये fuse नहीं होता है, then it will lead to what, guys? It will lead to this condition here. That is midline cleft lower lip. So midline cleft lower lip is due to non-fusion of which process? Non-fusion of mandibular process. Easy. After that, in this diagram, you're able to see here, mandibular process itself is going to give rise to maxillary process. Maxillary process here. Fine. Now, this maxillary process will go and fuse with what? Please listen to me very carefully here, sir. Please be alert. Focus here one second. The maxillary process is going to go and fuse with the medial nasal process. And this one here will be the lateral nasal process here. So I'm using the same color, medial nasal process, and this one here will be the lateral nasal process here. The maxillary process will fuse with the medial nasal process to form what? Upper lip here, sir. The maxillary will fuse with what? The medial nasal process here. Done. Now, if suppose the medial nasal process on one side and medial nasal process on the other side, these two medial nasal process does not fuse together. If they does not fuse together, then what is going to happen? Midline cleft upper lip. Okay, this condition here, so this one. Midline cleft upper lip. Can you see that one? Midline cleft upper lip here. This diagram here, okay? Then next, अगर मान लो कि this maxillary process is not fused with the medial nasal process, अगर ये दोनों fuse नहीं होते हैं, if this is not fused here, then it will lead to what? Unilateral cleft upper lip. Unilateral cleft upper lip, this first diagram here, sir, ये वाला diagram. This is non-fusion of maxillary with the medial nasal process. अगर मान लो दोनों साइड में फ्यूज नहीं होता है, if it is not fused on both the sides there, then it will lead to what here? The bilateral cleft upper lip, sir. Okay, and now my dear friends, if suppose the maxillary process is not fused with the lateral nasal process also, मतलब ये lateral nasal process से fuse नहीं होता है, then this will extend in the face also, and this is known as the oblique facial cleft. This is oblique facial cleft here. So the students will be finding it like very difficult to memorize all these things here. No need to mug up at all, sir. You just follow this one diagram here. Everything will become damn easy here. Take it? Everything will become like damn easy, sir. Okay. Dr. Puneet is asking, sir, how long the session will be? Puneet, give me another 10 minutes. Okay. I know your time is very much important. And I hope right from the first minute of our session here, I'm not wasting your time anything here. Yes, of course, I respect your time there, sir. Yes, just give me, Puneet, sir, give me 10 minutes. I'll be finishing it, sir. Okay. Shall we go ahead? Am I allowed? एक बार हम लोग ना दोबारा कर लेते हैं इसको ना, लेट अस डू इट लाइक क्विकली अगेन, बिकॉज यस, मेरे को ना फीलिंग आ रहा है, ऐसे गट फीलिंग आ रहा है कि यहाँ से एक सवाल आएगा एग्जाम में। थैंक यू डॉक्टर मोहम्मद। या अगर मान लो कि मैंडिबुलर एंड मैंडिबुलर प्रोसेस, ओके, थैंक यू पुनीत जी। हाँ, अगर मान लो कि मैंडिबुलर एंड मैंडिबुलर प्रोसेस फ्यूज नहीं होता है, ओके, मिड लाइन क्लेफ्ट लोअर लिप, सिंपल। इफ mn this medial nasal अगर फ्यूज नहीं होता है, देन दैट इज मिड लाइन क्लेफ्ट अपर लिप्स। अगर मैक्सिलरी और मीडियल नेजल प्रोसेस फ्यूज नहीं होता है, देन इट इज यूनिलेटरल। अगर दोनों साइड में नहीं होता है, देन इट इज बायलेटरल, ओके। एंड इफ दैट इज गोइंग टू एक्सटेंड इन द फेस ऑल्सो, दैट इज नोन एज व्हाट, ऑब्लिक फेशियल क्लेफ्ट, ऑब्लिक फेशियल क्लेफ्ट। क्लियर दिस वन हियर? तो ऐसे प्रैक्टिस कर लो, हो जाएगा सर, डन। नेक्स्ट वन वी हैव टू एक्चुअली लर्न अबाउट द डेवलपमेंट ऑफ द आर्टेरियल सिस्टम। से आर्टेरियल सिस्टम से हमेशा एक क्वेश्चन आता है आपके एग्जाम्स में। नाउ इन दिस डायग्राम व्हाट यू डू इज फर्स्ट यू कॉन्सेंट्रेट ऑन टू द डोर्सल आयोटा सर। So in this diagram here, this one here will be the dorsal aorta, fine. And this one in the front here, this one is aortic sac here, sir. And these two are connected by the arch arteries. For example, you imagine I'm an embryo, okay? It's hard to imagine, but before exam, मानना ही पड़ेगा. तो I'm an embryo like this here, sir. So there will be like dorsal aorta. And remember, during development, there is not like only one dorsal aorta. There are like two dorsal aorta, sir. This diagram you're actually seeing in the side view. So there will be right dorsal aorta, left dorsal aorta. There will be two dorsal aorta. और आगे क्या होता है? Aortic sac होता है, aortic sac. और आपने पढ़ा होगा ना, एम्ब्रियो अगर ऐसे होता है तो यहाँ पर ना pharyngeal arches होते हैं. How many pharyngeal arches are there? 6. And those arches will have arch arteries. They'll have arch arteries. Okay. अब इन सबको जोड़ दो सर. Join them together. तो aortic sac आगे होता है, aortic sac आगे होता है, and then dorsal aorta पीछे होता है, and they are connected by arch arteries. అయోటిక్ సాక్ ముందు ఉంటుంది, డార్సల్ aorta వెనక ఉంటుంది, and connect చేయాల్సింది aortic arch arteries. Okay, now please look at this diagram here. Now in this diagram you are able to see here dorsal aorta. There will be right one and the left one here, and then there will be aortic sac in the front here, sir. Oh, and they are connected by the 6 arch arteries over here. Okay, the 6 arch arteries are connecting them, sir. Are you understanding me? So in this manner, this diagram, I hope now you are understanding it. Now this diagram, let us make it simple. Okay. So in our diagram here, my dear friends, welcome here. This is the right dorsal aorta. And this one here will be the left dorsal aorta. Okay. And this one here will be the aortic sac here. And then I told you there will be arch arteries. How many arch arteries will be there? How many? They are like totally 6 arch arteries. अब मैं आपको ना ये डायग्राम 2 से 3 बार इसीलिए रिपीट कर रहा हूँ. वाई आई एम रिपीटिंग दिस लाइक 2-3 टाइम्स हियर? वाई? बिकॉज पहले डायग्राम समझना इंपॉर्टेंट है. मेनी स्टूडेंट डोंट अंडरस्टैंड दिस डायग्राम एट ऑल. पहले डायग्राम समझना इंपॉर्टेंट है, ठीक है ना? अगर आपने डायग्राम समझ लिया है, यहाँ से सर टाइम पास. लेट्स मेक इट ईजी फॉर यू पीपल. लेट मी मेक इट लाइक डैम ईजी फॉर यू पीपल. नंबर 1, आर्च ऑफ अयोटा राइट साइड में होता है कि लेफ्ट साइड में होता है सर? लेफ्ट साइड में होता है. सो आर्च ऑफ अयोटा विल बी एक्चुअली डिराइव फ्रॉम हियर. ब्यूटीफुल. नाउ दैट इज गोइंग टू फॉर्म योर आर्च ऑफ अयोटा. आप ही मुझे डायग्राम देखकर बताओ. यू ओनली लुक एट अ डायग्राम एंड टेल मी आर्च ऑफ अयोटा विल बी डिराइव फ्रॉम विच आर्च आर्टरी? Come on, which arch artery here, sir? Yes, this is the first one, then the second one, third one, and fourth one here. Yes, the fourth arch artery. And which one here? Of course, it is the left fourth arch artery, sir. So left fourth arch artery is going to form arch of aorta. Done. It's a PYQ, sir. Number two. Number two, my dear friends, arch of aorta, it's the one which is going to give rise to common carotid artery. And common carotid artery will give rise to a bud external carotid, continue as internal carotid. Okay. Number one, this is the common carotid artery. This one is external carotid artery, and this one is internal carotid artery. Whatever it is, my dear friends, all the carotid arteries are derived from where? The third arch artery. So third arch artery is the one which is going to form the carotid arteries. Third arch arteries are going to form carotid artery. अब क्या होता है ड्यूरिंग द डेवलपमेंट, व्हाट इज गोइंग टू हैपन हियर? एट द सेम टाइम लंग्स भी फॉर्म होते हैं सर. मैंने कहा था ना एम्ब्रियो, ऑल दिस इज हैपनिंग हियर, आर्च आर्टरीज एंड ऑल. तो यहीं पर दरमियान में लंग्स फॉर्म होते हैं. अंडरस्टैंड इन 3D. ओके, लंग्स फॉर्म होते हैं. इफ लंग्स आर फॉर्म्ड हियर, ऑफ कोर्स द लंग्स विल बी सप्लाइड बाय द पल्मोनरी आर्टरी हियर सर. सो दिस वन विल बी द राइट पल्मोनरी आर्टरी हियर, एंड दिस इज द लेफ्ट पल्मोनरी आर्टरी हियर. डायग्राम देखकर आप ही मुझे बताइए कि पल्मोनरी आर्टरी कहाँ से फॉर्म होता है? Pulmonary arteries are derived from 6th arch artery. derived from sixth arch artery sir. Okay. एंड फाइनली यस, जो आपके एग्जाम में रिसेंटली पूछा गया था कि पल्मोनरी आर्टरी एंड आर्च ऑफ एओर्टा, दीज टू आर कनेक्टेड बाय व्हाट? डक्टस आर्टेरियोसिस. And ductus arteriosus will be derived from where? It is derived from the left sixth arch artery. इतना आसान है सर. यू जस्ट प्रैक्टिस दिस वन. नो नीड टू मग अप द नंबर्स. नंबर्स रट्टा मारने का जरूरत ही नहीं है. इज इट ओके? चलिए एक बार दोबारा हम लोग ना इसको रिपीट कर लेते हैं. आर्च ऑफ अयोटा इज डिराइव फ्रॉम विच आर्च आर्टरी? आर्च ऑफ अयोटा लेफ्ट फोर्थ आर्च आर्टरी. कैरोटिड आर्टरीज आर डिराइव फ्रॉम थर्ड आर्च आर्टरीज. आई एम नॉट राइटिंग लेफ्ट और राइट देयर. व्हाई? बिकॉज कैरोटिड आर्टरीज दोनों ओर भी होते हैं. फाइन. Pulmonary arteries are derived from where? They are derived from sixth arch arteries. दोनों ओर भी होते हैं. Ductus arteriosus will be derived from where? The left sixth arch arteries. Done. Clear? So remember this, you'll be able to solve the questions from here. Okay. now my dear friends, remember one thing very carefully here, that sir आपने तो हमको यहाँ पर थर्ड फोर्थ और सिक्स्थ वाला ही बताया है. What about the first, second and fifth वाला? Why are not showing that one? तो please remember my dear friend, nothing will be derived from the fifth arch artery. यहाँ से कुछ फॉर्म नहीं होगा, क्योंकि हमने कई बार पढ़ा है, राइट फ्रॉम फर्स्ट ईयर MBBS डेज वी हैव लर्न दैट आउट ऑफ द सिक्स आर्च विच आर्च विल डिजेनरेट? द फिफ्थ आर्च विल डिजेनरेट. तो वो तो गया, वहाँ से कुछ फॉर्म नहीं होगा. Now from the first arch artery there will be a remnant, and that remnant will be maxillary artery, and from the second arch artery there will be remnant, and that will be the stapedial artery and hyoid artery. So please remember all these things, sir. More than enough, my dear friends. Okay. So what is the remnant of first arch artery here? The remnant of first arch artery here is maxillary artery, and the remnant of second arch artery will be the stapedial artery, as well as, remember, the hyoid artery, my dear friends. Is it okay? Thank you, Dr. Sharma. Thank you. Thank you, Dr. E Football Mania. वन लाइनर के नाम पे आपने आग लगा दी. Thank you. No, that is what is my intention. Why? Because always I think that, whenever I'm spending some time with my students, it should be like a quality time. So it should be like completely, है ना? Why to do like Sauntila Vyavhar and all? Okay. Next one, sir. So this is the same diagram that I have drawn there. By this we are done, sir. And now welcome here. Now in this diagram, are you all able to see here? This is the left vagus nerve here, and this is the right vagus nerve here, and vagus nerve will give rise to recurrent laryngeal nerve, RLN. And one very famous question is that left recurrent laryngeal nerve and right recurrent laryngeal nerve, which is more longer? So which is more longer here? The left recurrent laryngeal nerve is more longer. Why? Because you can clearly see वो यहाँ से ऊपर आ ही नहीं सकती है, क्योंकि यहाँ पर क्या फॉर्म हो रहा है? पल्मोनरी आर्टरी, और यहाँ पर डक्टस आर्टेरियोसिस. इसकी वजह से वो ऊपर नहीं आ सकती है. Whereas the right recurrent laryngeal nerve, the right वाली, वो ऊपर आ जाएगी, क्योंकि यहाँ पर डिस्टल वाला पार्ट कुछ फॉर्म नहीं करता है, और फिफ्थ आर्च आर्टरी यहाँ से कुछ फॉर्म नहीं करती है. Therefore, the right recurrent laryngeal nerve will be coming up, and that is going to take a turn around the right subclavian artery, whereas the left recurrent laryngeal nerve is going to take a turn around the arch of aorta. है ना? याद है आपको? तो remember my dear friends, they have already asked in the exam that the left recurrent laryngeal nerve is the longer one because of which arch artery? Because of the sixth arch artery. Left recurrent laryngeal nerve is longer when compared to the right one because of, yes, the left sixth arch artery here. Left sixth arch arteries. ठीक है ना? चलिए सर आगे बढ़ते हैं. Next one. After this one, yeah, the same thing which I told you just now is the same diagram here. Now, welcome to almost at the end right now, sir. Yes. Nowadays, in your PG exams also, as well as FMG exam, they're asking questions from this diagram, sir. How? I will tell you. Listen here. First of all, this is your embryo here. Now, in this embryo, whatever this outer white colored line that you're able to see here, this is the body wall, and body wall will be derived from ectoderm. Fine. Whatever this pink colored line you're able to see, that is gut here, and gut is derived from what, sir? Endoderm here. Fine. And now, the gut will actually be having the foregut here, and then the midgut here, and then this one is the hindgut here, sir. The midgut will have an extension known as vitello-intestinal duct. Vitello-intestinal duct. And the hindgut will have an extension here known as the allantois here, sir. Allantois here. Now the first thing, please remember that in normal healthy people like you and me, during our development, what should happen? Vitello-intestinal duct should be completely closed. It should be completely closed. Okay. If it is not closed, then what is going to happen? Meconium. आपको meconium पता है? Meconium will start coming out from the umbilicus. So therefore, If you are able to see meconium coming out from umbilicus, meconium from umbilicus, गड़बड़ी कहाँ है? Where is the problem? The problem is in the vitellointestinal duct. Persistence of this vitellointestinal duct. Meconium coming out from the umbilicus, it is due to persistence of vitellointestinal duct. Acha. Now, entire vitellointestinal duct is not persisting. Another case, sir. Case number 2. Entire vitellointestinal duct is not persisting. Only the proximal part is persisting here. The remaining part is gone, sir. I hope you have learned about this one in the surgery also. If this proximal part is persisting here, that diverticulum is known as. Come on, anyone? Come on, anyone. Can anyone answer in the comment box there? That is which diverticulum? Meckel's diverticulum, sir. क्या क्या लिख रहे हो भाई साहब? That is Meckel's diverticulum. So if only the proximal part is going to remain there, that will be the Meckel's diverticulum. तो दोनों भी, both of them are actually the गड़बड़ी in the vitellointestinal duct only. If the entire vitellointestinal duct is persisting there, then it is meconium coming out from umbilicus. And if only the proximal part is persisting there, it is Meckel's diverticulum. ठीक है ना? Now, that is about meconium coming out, sir. Now, one more question is that urine coming out of the umbilicus. Now, urine कैसे umbilicus से आ सकता है? तो please look at this last वाला part. पहले क्या होता है? This hind gut here, it will be separated apart, and that is going to form the rectum as well as the anal canal here. And then the allantois part here will be going to form the urogenital sinus. Extremely important. I think you also heard a lot of time about this one in obs gynae. So I'm telling you only about this last wala part, sir. This part here. Okay. So hind gut separated and allantois separated. Allantois is going to form urogenital sinus. And the cranial part of this urogenital sinus, it is nothing but the urachus. Normally, this urachus has to be closed. And if it is closed, it is the one which is going to form median umbilical ligament. Sir, what the hell is this? How come median umbilical ligament is coming here? I'll tell you. Now, this urogenital sinus, this is the one which is going to form your urinary bladder here, sir. Okay. So, urinary bladder जो होता है, apex of the urinary bladder. Please look at this diagram here. If this is the urinary bladder here, the apex of the urinary bladder over here, it will be attached with the ligament. That ligament is going and attaching to umbilicus. Okay. And that ligament will be the median umbilical ligament. Median umbilical ligament. So median umbilical ligament should be formed from where? It is formed from the urachus. Perfectly done. In some unfortunate babies, वो close नहीं होता है. अगर वो close नहीं होता है तो क्या होता है? यहाँ पर जो यूरिन होता है, वो यूरिन यहाँ पर umbilicus से बाहर आता है. और इसको हम कहते हैं weeping umbilicus. Umbilicus like weeping, urine coming out from umbilicus, and that is due to the persistence of urachus. So please remember, my dear friends, two things here. Hello. Please remember 2 points here, my dear friends. कि meconium coming out from umbilicus, yes, it is due to the persistence of vitellointestinal duct, and urine coming out from the umbilicus, it is due to the persistence of urachus. ये questions आपके एग्जाम में आजकल ज़्यादा पूछे जा रहे हैं. Please take care about that one here, sir. Okay. And then one more point, let me ask you here itself. Urogenital sinus is the one which is going to form your entire urinary bladder except what? Except the trigone. I will be really happy at the end of the session if anyone can tell me that trigone will be derived from where. At the end of the session, I'll be like really happy, my dear friends, if anyone can tell me trigone will be derived from where. Come on. Come on. Yes, trigone will be derived from the mesonephric duct. Which one? Yes, Wolffian duct. Very good, Dr. Rahul. Wolffian duct, which is also known as the mesonephric duct, absorbed part of the mesonephric duct, sir. That was a direct question asked in your exam, sir. Okay, now. So urogenital sinus is going to form the entire urinary bladder. Fine. Except what? Except the trigone. And trigone will be derived from where? The urogenital sinus, sir. Okay. Next one here. Yes, of course, if this is your, gut here, my dear friend, that is your foregut. If this is the foregut over here, stomach here. In front of that, there will be a mesentery. That mesentery is known as the ventral mesentery. And behind that, there will be a mesentery known as dorsal mesentery. And you just have to remember the derivatives of this one. And we have discussed that in detail already. Right in front here, you're able to see the liver here. और liver के सामने क्या होता है sir? What do you have in front of the liver? This ligament will be the falciform ligament. And what do you have between the liver and the stomach here? That will be the lesser omentum. All that will be derived from the ventral mesentery. And behind the stomach, you're able to see the spleen here, and spleen. Between the stomach and the spleen here, there'll be gastrosplenic ligament here, and between the spleen and the kidney behind here, that is splenorenal ligament. Splenorenal ligament here. Okay. So by that diagram, you can easily remember what is derived from ventral mesentery and what is derived from the dorsal mesentery, my dear friends. Okay. And yes, of course, we remember about the rotation of the gut. Foregut is going to rotate 90 degrees in clockwise direction. Okay. And midgut is going to rotate 270 degrees in anti-clockwise direction. That is anti-clockwise direction here, sir. Okay. And then what about the hindgut? Hindgut rotate nahi hota hai. And now when it comes to midgut rotation, remember that midgut is actually going to come out via the umbilical opening and then going to rotate. In some unfortunate babies, agar मान लो ये reduce नहीं होता है, if that hernia does not reduce back, then it will lead to a condition. That condition here is known as the omphalocele. Omphalocele. Okay. Please remember, this hernia is not like pathological hernia. This is physiological hernia. That physiological hernia will normally occur at 6th week and it will reduce by 10th week. अगर वो रिडक्शन नहीं होता है, that condition is known as omphalocele. Okay, omphalocele, sir. Fine here. And by this, my dear friends, we are now done with all the concepts in the embryology also. I'm done with general embryology as well as CNS, CVS, the gut embryology. Everything has been covered here, sir. Okay. And by this, my dear friends, we are actually done with the entire anatomy here. As I told you in the middle of that, joints and the epithelium and cartilage and all those things, you just have to remember the examples. I'll send you that PDF in the Telegram group. You can actually learn those examples and go, because you can expect like one question from types of joint and one question will definitely coming from the epithelium and cartilage and also. Fine here. Is it okay, my dear friends? I hope you have enjoyed this concept. Please do one thing here. Revise this video as much as possible before your exam on 2x. I think I don't remember the timing exactly, how much time it is. I think on 2x it will be done in like a couple of hours, my dear friend. So please revise this before going to the exam, one day before the exam in the night time, or revise this early morning before going to the exam on the way to the exam, sir. And because like, there's a lot of hard work behind that, we have covered everything possible in anatomy over here. Fine. So I thank you all, my dear friends, for patiently listening to me here, and God bless you with a lot of success in your life. Whatever your future endeavors are there in that, God bless you with a lot of success. May you come out with the flying colors in your exam. Okay na? God bless you. मेरी दुआ रहेगी सबके लिए मैं दुआ करूँगा इंशाल्लाह. आप थोड़ी सी मेहनत करिए एग्जाम में, हम यहाँ पर आपके लिए दुआ कर रहे हैं. डोंट वरी अबाउट दैट. ठीक है. और प्लीज़ शेयर दिस वीडियो विद ऑल योर फ्रेंड्स. प्लीज़ हेल्प योर फ्रेंड्स, क्योंकि बिलीव इन वन थिंग, that it is just your FMG students I'm telling you, mainly because your exam is closer. It is just a screening exam, my dear friends. It's not like competitive exam कि कोई दूसरा पढ़ लेगा तो आपका रैंक कहीं पीछे रह जाएगा. तो ऐसा कुछ नहीं है. जितना आप हेल्प करोगे दूसरों को, उतना ही आपको कहीं ना कहीं से हेल्प मिलेगी. क्योंकि मेरा फर्म बिलीव है, वेर एवर यू बिलीव, वॉट एवर योर बिलीव इज दैट, मेरा फर्म बिलीव ये है कि देर इज सम एनर्जी इन द यूनिवर्स. ओके ना, वॉट एवर यू बिलीव इन, देर इज सम एनर्जी इन द यूनिवर्स कि आप जितना दूसरों को हेल्प करोगे, कहीं ना कहीं से एक गैबाने तरीके से आपको ना आपके एग्जाम्स में हेल्प मिलेगी. ठीक है ना. तो हेल्प अदर्स, दे विल आल्सो हेल्प यू, गॉड विल हेल्प यू इन योर एग्जाम्स. तो प्लीज़ शेयर विद अदर्स ऑल्सो, दे विल ऑल्सो लर्न फ्रॉम हियर. ठीक है ना. देयर इज अ लॉट ऑफ हार्ड वर्क पुट इनटू दिस वन हियर. सो आई होप दिस विल बी हेल्पफुल फॉर माई स्टूडेंट्स. ओके, सो थैंक यू ऑल. गुड नाइट, टेक केयर, शब खैर, नमस्ते, ऑल द बेस्ट.